First, I would like to welcome Dr. Y.K. Batra, Director Anaesthesia and Pain Management, Max Super Speciality Hospital, Mohali, ex-HOD Department of Anaesthesia Intensive Care, PGI Chandigarh. He has received Lifetime Achievement Awards from National Societies for contribution in the field of anesthesia and pain medicine. And there are many publications in international and national journals and invited book chapters. His areas of interest are pain management. Welcome, sir. Next, I would like to introduce Dr. Sukanya Mitra, Professor and Head of Anesthesia and Government Medical College, Chandigarh, has won many academic awards, including Pain Research Fellowship at Yale University, USA, Pain Education Award of International Association for Study of Pain, ICMR International Award for Biomedical Scientists to visit Rochester University, ISCCM Research Grant Award, and many ISA awards, 90 research publications in peer-reviewed index journals, invited book chapters in books published by Lippincott, Oxford University Press, Cambridge University Press, New York. Her areas of interest are acute and chronic pain management, including labor analgesia, palliative care, and cancer pain management, pain education. Welcome, ma'am. Next, I would like to introduce Dr. Amit Dixit, Consultant Anesthesia in Ruby Hall Clinic, Pune, Fellowship in Regional Anesthesia, MGR University, Course Lead for Regional Anesthesia Fellowship, Member of Board of Studies for Fellowship and Research in Aura, India, Peer Reviewer for Indian Journal of Anesthesia, and he has many articles in index journals and has contributed chapters in POCUS and Regional Anesthesia handbooks. Next, I would like to introduce Dr. Vandana Mangal, Senior Professor of Anesthesiology in SMS Medical College, Jaipur, President-elect of ISSP, Executive Member of Aura, Member of BOSS Aura, and Scientific Chair of ISACON 2015, Jaipur. Her special interests are regional anesthesia and pain management. There are several publications in national and international journals. Welcome, everyone. Now I would like to request Dr. Y.K. Batra to please introduce Dr. Sudarshan Shetty, our first speaker.
Is it live? So that's क्या ना? ये live है?
He's not.
हाँ? नहीं, he's there.
Dr. Shetty, Dr. Batra would be introducing you soon.
Okay, sounds good.
First one. अच्छा ठीक है जी नहीं इसका टॉपिक क्या है इसका बता देना जब शुरू करना है ओके Well friends, we are going to start the first session and it will be delivered by Dr. Sudarshan Shetty. Dr. Shetty, he is a PGI alumni and presently he is working in University of Minnesota, Minneapolis. In fact, is Dr. Shetty hearing me?
Yeah, Dr. Batra, I can hear you.
Yeah, I was also there in your place for almost 3 months. This city is beautiful, full of lakes, and of course, we'll enjoy your talk on ultrasound for arresting trauma patient. Please continue.
All right. Can you guys hear me?
Yes, we can.
Yeah, thank you. Good morning, and thank you for inviting me to this webinar conference. I would like to thank Jitendra and Dr. Kajal for inviting me, and Sat Sri Akal. I wanted to say that. Right. So my topic today is point of care ultrasound in trauma, ultrasound for the arresting trauma patient. I have no disclosures, no conflicts of interest. In today's session, I'll talk briefly about introduction to POCUS in trauma. We will see the tools that we need to carry out our mission, probe selection, a little bit about FAST and EFAST, which will form the crux of the trauma POCUS exam.
Sorry, Dr. Shetty.
Yeah.
Just 1 second. Probably there is some problem in the physical room. They're not able to hear, so you might have to start again.
Okay. Okay. Sounds
Yeah.
good.
1 second. I'll just give you a cue. Dr. Jeet. Now, okay. I'll ask him to say something so that if you are able to hear, please do let me know. Dr. Shetty.
Yep.
Can you
here.
say hello?
Yeah, I'm here. Can you hear me? Hello?
Yeah, 1 second, sir. They are not able to hear you.
Are you able to hear me?
Yes, sir. We are able to hear you. The virtual ones are able to hear you. Probably the physical ones are not. Sir, can you do a sound check, please?
Sure. Can you guys hear me?
Yes.
Yep. Okay. Restart.
Just give me a second, sir.
Okay.
Hello, Sudarshan, can you hear us?
I can hear you. Can you hear me?
So, yeah, I will give the mic again to the chairperson and we'll start from there.
Sure, sure.
We're sorry for the small hitches. It is just that this is the first session of the day.
Don't worry, don't worry. It's all right.
Giving the mic to Batra, sir.
Okay.
Sudarshan has the practice.
We can stop sharing as of now, Dr. Sarthi.
Stop sharing.
Yeah.
Okay.
Sudarshan, can we have your video on?
Oh, I thought he wanted me to stop.
Yeah, we can see you now. Great.
Hello, Dr. Sudarshan.
हाँ जी सर, कैसे हैं आप?
आप बताइए.
बढ़िया सर.
You are in a beautiful place.
Yes, this is a beautiful place for sure.
City of lakes. So I was there in 96 for about 3 months in this place.
Oh, nice. Okay. Awesome.
Dr. Belani is there still?
Oh yeah, he's still here. He's still here.
Convey my regards.
I will.
And I think we are already late by a few minutes. Can you start your talk with the ultrasound for arresting trauma patients? Okay, Dr. Sudarshan?
Okay. Thank you, sir.
Sudarshan is in University of Minnesota, Minneapolis as associate professor. And he is also director of perioperative ultrasound department of anesthesiology. So thanks, Shetty. Please continue.
Thank you, sir. Morning all and Sat Sri Akal. It's glad to see so many familiar faces, and thanks to the organizing committee, Jitendra and Dr. Kajal, for inviting me. It's an honor. And as Dr. Batra said, my topic for today is focus in trauma, ultrasound for the arresting trauma patient. I have no conflicts of interest. And in today's session, brief introduction to focus in trauma. I'll talk a little bit about probe selection, talk about the FAST and the eFAST exams, which will form the crux of focus in trauma. And there'll be a few cases.
Dr. Sudarshan?
Yeah.
आपका करना sorry sir, please continue.
Okay, and a few cases sprinkled in there. So as Dr. Narayana was saying, this is a very sobering set of statistics here. Road traffic accidents, I think this is data from 2015, leading cause of death in the age group of 5 to 29. 93% of the fatalities occur in low and medium income countries, which is very relevant to us in India. About 1.3 million people die every year because of road traffic accidents. We are here to talk about what to do after somebody is in an accident, and my session is only about ultrasound. This is a review article by Davinder Ramsingh. If anybody is interested in learning more about point of care ultrasonography in trauma anesthesia, this is a great resource. I've taken some of the images from this particular article. Brief history of trauma focus. The year 1996, the FAST exam became popular. What it did was essentially replace the diagnostic peritoneal lavage. Till then, anybody with abdominal trauma had to get a peritoneal lavage to see if there's any blood in the paracolic gyrus. And with the advent of the FAST exam, that kind of went away. And in 2013, they extended the FAST exam. Now it's called the eFAST. And now they've added the lung assessment during trauma, the anterior lung assessment. Now, the big question is, how useful is it? I will give you two sides of the coin here. The gold standard for any evidence-based medicine is the Cochrane database. What does this say? This is from 2015. A lot of words. I don't expect you to read everything there, but this is the conclusion. As usual, insufficient evidence. But this is the plain language summary. What they're saying is, if you're a patient and end up in a trauma situation in a hospital, ask your doctor to do a CT, because not much evidence to say that ultrasound is useful. The other side of the coin, if you take lung ultrasound, which is part of the eFAST exam, versus CAT scan, if you look at the sensitivity and the specificity versus CAT scan, it's really good. Almost most of it is in the 90s. Now, point of care ultrasound in the arresting patient, very similar to focus in the trauma situation, but at a quicker pace. I'm going to be talking not just about focus in trauma, but a little bit more about other situations where the patients can be arresting. Why do point of care ultrasound at all? Mainly to rule out pneumothorax, effusions in the lung, intra-abdominal bleeding, pericardial effusions, and to get an assessment of the cardiac function. Or in other words, this will help you differentiate the different types of shock. What do you do? Like if it's a cardiogenic shock versus hypovolemic versus hemorrhagic versus obstructive shock. As you guys all know, the treatment is very different from each of them. And a few wrong steps in a fragile patient may not end well at all. And these are some of the probes, the tools of the trade. This is a microconvex probe, kind of antiquated. This is from one of our oldest machines in our hospital. I didn't know how to use it initially, but it's an amazing probe. If you get your hands on one, use it. Smaller footprint, and you'll get all the images that you need. And the different probes based on the shape and the frequency, low frequency probes and high frequency probes. High frequency probes will give you better resolution and shorter depth of penetration, good for assessing, lung sliding. But Anything else, you use a low frequency probe. And what I've displayed here as A is a curvilinear probe. And of course, then there's a standard TT probe. But the topic today is point of care ultrasound. What if you don't have any of these? We were in that situation not too long ago, and we ended up doing intraoperative transdiaphragmatic echocardiography. Patient not doing well after like some abdominal surgery, and we needed an answer. What do you do next? Hypertensive patient, do you give pressors or do you give fluid? And to get an answer quickly, since we could not find any other usual probe, what we did is we took a high frequency probe that we use for vascular cannulation. That's a surgeon putting it inside a sterile sleeve, and he put it inside the abdomen next to the diaphragm, and to look at the heart to see what to do next, fluid versus pressors. And all the way on the right side, this is telling you that this will work like a TEE probe because of its location. So what I'm trying to say is this is point of care ultrasound. You don't have to like hang your hat on one probe or the other. What you're seeking here is a yes or no answer. Most of the time it's binary. And just for that information, any probe will do. So moving on to the lung ultrasound in the arresting patient. Part of the EFAST exam, why would you need a lung ultrasound? One, to confirm endotracheal intubation. Look for pleural sliding. If you have pleural sliding on both sides, you're good. To rule out a pneumothorax, and of course, pleural effusions, whether be it fluid or blood. And then what you do next is, I'm going to talk about that in the next few slides. Now, the next question. We talked about the tools of the trade. Where do you scan? So this is a model putting his hand on his chest, just underneath the clavicle. And the center point of his hand, that will be the first part or the first point that you're going to scan. And this is him like with two hands underneath his clavicle. The midpoint of those two hands are called the blue points. Blue as the color blue, blue point 1 and blue point 2. This is just for standardizing the views when you describe it to somebody else. That's me like scanning the anterior lung. As you notice, the probe is a linear probe. It's a high frequency probe, and there's an indicator on the probe. For most of the exams, it should be pointing cranially. Then pleural scanning or the right upper quadrant. So this is a low frequency probe. If you pay attention, that's a C1 to 5 probe. And what I'm doing there is scanning the pleura. You look for the diaphragm. Anything above that is going to be the lung and the pleura. You look for like lung movement and your fluid there. And then if you come down a couple of rib spaces, then you'll run into the liver. And below the liver is going to be the kidney. The same thing on the left side. With one sweep of your hand, you can scan the lungs, the diaphragm, the spleen and the kidney, and look for fluid in the splenorenal recess here. This is a slide of lung sliding. This is what it's supposed to look. So if you see here, this is all soft tissue from the point where the probe is touching the skin. And this shimmering line that looks like a worm, that's the two layers of the pleura rubbing against each other. And this is what it looks like. If you see this, you're good. You don't have a pneumothorax. If you don't see it, it could be one of many things. One of them is a pneumothorax. And if you drop a M mode across the pleura there, this is what you will see. This is called the waves on a sandy shore. The soft tissue will show up as a pattern of like a barcode or waves. And the lung parenchyma itself will show up as a sandy beach. So this is classic of waves on a sandy beach or the seashore sign. What if it's a pneumothorax? If you drop the M mode across a patient who's having a pneumothorax, because the lung parenchyma is pushed down, the pattern from the skin to the pleura kind of repeats itself. And this is what it looks like, kind of a barcode, the old type of barcode, not the new ones. And this is a video of the lung point. If you see the pleura sliding and stopping abruptly, that's the point that is called as a lung point. If you see this, you are ruling in a pneumothorax. But if you see any kind of lung sliding, you're ruling out a pneumothorax. So this next few images are from a patient of ours who was on ECMO, not doing well, hemoglobin drifting down slowly over days, acutely becomes unstable and drops his blood pressure. Chest X-ray was kind of equivocal, we couldn't really tell. So we took out the ultrasound probe from our oldest machine and we started looking. This is image from the upper chest, and you see like this dark hypoechoic pocket there. So that tells me there's either fluid or blood. And if you add all the clinical information, more likely to be blood. This is what we saw in the mid part of the right chest. And that's about the pleural line there. And this is the collapsed lung. All this black fluid is possibly blood. And if you look on the right side of the screen, each dot there is about 1 centimeter. So if you measure from here to there, that's about like 6 or 7 centimeters. What it tells me is there's a lot of blood or fluid in the lung there. Sorry, give me 1 second. Something happened here. Okay, so this was a chest X-ray. Just looking at the chest X-ray, we would not have guessed that the patient has like so much blood in his thoracic cavity. He went back to the operating room. They washed his chest out, found a bleeder, and things came back to like pseudo-normal. All right, moving on to the abdominal part. The FAST exam of the EFAST exam portion. We look at 4 different views: subcostal 4-chamber view, right upper quadrant and left upper quadrant views, and the pelvic views. The same probes that I described before. For the FAST exam, better to use a low frequency probe. And way to scan, we saw on the right side, if you're scanning for the pleura, on the right side and with the slide down, you're going to see the right upper quadrant, and similarly for the left upper quadrant. So this is a clip from YouTube, from the Sonosite website. What you're seeing here is the bright line that you see there is going to be your diaphragm, and the granular structure right below that is your liver with all the vasculature inside, and the kidney comes right below that. So if you start seeing fluid between the liver and the kidney, the Morrison's pouch, then you know it's not normal. And this is just a cartoon of like what it will look like if you place a probe there. So here on the right side, labeled A, is a normal looking right upper quadrant EFAST or FAST exam. You see the diaphragm, the liver, the kidney, and B here, that's the diaphragm is kind of obscured because there's a lot of like anechoic or hypoechoic structure there, and there is blood underneath the diaphragm. And that's the source. What about the left side? Similarly, you're going to see the diaphragm, that bright line that you're seeing. Anything above that is the lung. And you see the spleen, and then the kidney. That's how you scan that. And what does abnormal look like? This is a normal splenorenal space. Excuse me. And if you see, it's kind of like abutting each other. And if you start seeing this anechoic or hypoechoic band, then it tells you like there might be like there's fluid or blood there. They are pelvic views. So there's 2 kinds of pelvic views. One is a longitudinal, and the other one is perpendicular to that. If you see in this video, they're showing you like where to place the probe. The orientation marker should be to the right. The rest of the exam, the orientation marker is should be facing cranially. So that's in one axis, and this will be the other axis. All right. So that was normal. And this is what an abnormal pelvic view looks like. And you're looking at the cross section. This is the uterus, cervix, and this dark hypoechoic or anechoic fluid there, that's blood or fluid between the fundus of the uterus and the bladder, the most common place for accumulation of blood in a female. What about the male? So you have the short axis and the long axis. And if you look here, that's the bladder, and this is free fluid. The seminal vesicles also show up here as hypoechoic structures, not to be confused, but this is free fluid. And whenever in doubt, always check in multiple views. And this is in the long axis, you see the free fluid between the bladder and the rectum. What about the subcostal views of the EFAST? So here are two images. Well, this is a normal looking subcostal view. You have 4 chambers. You're kind of like going through the liver there. The first chamber you see is the right ventricle, the left ventricle, and the other chambers there. Right next to it, yeah, this is a patient who has like an ejection fraction of probably like 10%. So if you see a patient who is arresting and has an EF of like 10%, fluids would be the wrong choice. This is another subcostal view. So you see something moving there, that's your heart. And the rest of the dark hypoechoic or anechoic structure there is pericardial fluid around it. And each dot here is 1 centimeter. And if you measure that, that's about like 6 or 7 centimeters. That's a huge pericardial effusion. And if you see collapse of the right ventricle in diastole, that tells you there is tamponade. Moving on to the DVT exam. I'm sure like most of you would know what a femoral vein would look like, even when you're doing your femoral blocks. This is a non-compressible femoral vein, and there is some hyperechoic structure in there that's possibly a clot. And we'll put this together in the next couple of slides, all the different exams that we did. So if you have a crashing patient who is unstable, do the EFAST exam. Rule out the pneumothorax, look for pleural effusions, and as you come down to the subcostal view, you will see what the ejection fraction is, what the fluid status of the patient is, and when you go into the right and the left upper quadrant, you are looking for free fluid in the abdomen. It may be blood, it may be fluid, and then you look for the DVT. If you practice this, you can do the entire sequence: anterior chest exam, subcostal right and left upper quadrant, and pelvic and DVT views in well less than like 2 minutes. So in summary, point of care ultrasound can be a valuable tool in the arresting patient or the trauma patient. And this is, there are like multiple protocols for scanning patients who are in trauma. You have the RUSH protocol, you have the FAST, you have the EFAST. It's like an alphabet soup, but the components are all like pretty much the same. So this is what I usually do in a patient who is crashing in the ICU. Anterior lung, look for pneumothorax, go to subcostal, look for the ejection fraction, and if possible, look for the pericardial tamponade. Right and left upper quadrant, looking for free fluid, go to the pelvis, free fluid again, do the DVT, and you're done. Any questions? So Dr. Batra, like the 10,000 lakes of Minnesota, this is one of them. Freezes over in winter, and there's a lot of people like spending time on a frozen lake in the middle of winter. That's all I have. Thank you.
Yes. Excellent lecture, Dr. Sudarshan. I'm Dr. Amit here. Can you hear me?
Yes, I can hear you. Go ahead.
Yeah. Yeah. Dr. Batra wants to say something.
No. Continue, Dr. Amit.
Yeah. So really fantastic, and it's always the man behind the probe who is taking all those decisions. And if we are late, then probably ultrasound may not help us more So while setting this type of technique in our department or in emergency units, what is your suggestion? Because it is purely use of ultrasound is observer dependent, and how the person is trained and what are the credentials. So are we wasting the time, or are we investing it? Like if patient has to go for CT, how to set it and what protocol you would like to suggest? Because we have different group of trainees working in this area. Yeah. Over to you, sir.
This is like a question that comes up pretty often. Is this definitive? Is point of care ultrasound definitive? Well, yes and no. It's an extension of your stethoscope. If you are listening to somebody's chest and you come up with a clinical diagnosis, this is more like that. More and more, what's happening is there are more protocolized training programs. Now the ASA has come out with a perioperative, like a POCUS certificate. You put your trainees through a certain number of exams that they need to do, and it has to be signed off by somebody who is competent in that. So that's how you maintain your credentialing. And as usual, you have to save all these images and have it reviewed by somebody for quality control. Will it save a trip to the CAT scan? Well, that's a difficult question to answer. Like you saw, if you go back to evidence-based medicine, there is not enough evidence to do this. And like much of medicine today, you may never get the evidence to say that, ultrasound is going to replace CAT scan. But if you ask anybody who's passionate or uses ultrasound regularly, they all have their war stories of how their ultrasound saved somebody's life. The technology is improving. We have handheld devices now which come close to, but not as good as the high-end machines. It's like the difference between I'm blanking on the stethoscope that we used to use in India, that versus a Lickman, but it doesn't matter. You can still hear the heart sounds, you can still hear the breath sounds. And then, like you said, it's the person behind the equipment that makes the decisions. It's a growing field. I'm sure it's going to grow much bigger. Waste of time? I don't think so. It's going to be it's going to be a huge investment. What's happening here is the medical students that are graduating, the residents that are graduating are much better versed at point of care ultrasound than some of the faculty. And what I'm noticing is I'm training all the residents and the fellows. They go and ask the faculty can you watch this over? What do you think about this? The faculty feel bad. They come back to me and say can you train us in this? So if you don't catch up, you'll be left out. Yeah. So it's not a waste of time by no means.
Sudarshan, thank you. I asked you a very, controversial question, but you have answered it very nicely. And what in our practice also we find is there is a lot of enthusiasm with residents to do this ultrasound venture. And by the time the patient is stabilized for shifting to CT or something, we are settled with the diagnosis. So it's a very good futuristic tool. And I'm sure everyone would like to hands-on good experience with that. Thank you so much. Thank you.
You're welcome.
We can only take one or two questions.
A very nice talk, Dr. Shetty. This is Dr. Kapil. I'm professor here in VMMC Safdarjung Hospital. One question for you. I use POCUS a lot. What I have found is when we go for the cardiac views, you use the subcostal view. In my personal experience, I found instead of the subcostal view, isn't the parasternal short axis view better because it'll give us a better idea about the volume status of the patient as well as the contractility of the patient and not just a pericardial effusion, which is much better visualized with a subcostal view. What are your comments on that?
So again, this is point of care ultrasound. You're looking for yes or no answers. It doesn't matter. It doesn't even have to be a standardized view. It doesn't have to be short axis, long axis, parasternal. A lot of times, you place the probe on the chest, you get the answer you're looking for and you move on. As far as one over the other. I don't think it makes a huge difference. But if you're trying to diagnose a tamponade, then probably the subcausal view is better. And there's like enough data out there. If you take a big subsection of the population, there will be, out of like all the patients, one of the 4 views is possible in over 90% of the patients. And it depends on like where you're doing this and what the situation and the scenario is. Let's say you have a patient who has like had a abdominal surgery, subcausal views are kind of like out of the, it's like out of question there. There'll be bandages, there'll be like chest tubes. You can't put a probe on the subcausal space. Whereas you have a patient with COPD, big lungs, subcausal views is better probably than the parasternal long and short because the lungs get in the way. And this is like anything else. Since we're looking for just binary answers, yes or no, does the patient have heart failure? Does the patient have right heart failure? Does he need more fluid? And you look for these answers and move on. I don't know if that answered your question, but that's all I have.
Thank you, Dr. Sudarshan. That was, I think, Dr. Kapil is very much satisfied with your answer. And with this, we come to the next speaker. That is Dr. Sudhira K. Satyanarayan. He was also an alumni of this great institute. And currently, Dr. Sudhira is an assistant professor of clinical anesthesiology at Weill Cornell Medical College, Cornell University, New York. He's going to talk about deciding to intubate in trauma triage. This is a very important topic and we are running late, so I'll straight away hand over the mic to Dr. Sudhira to continue with his talk. Dr. Sudhira, please.
Okay. Hello. Good morning, everybody. Greetings from New York. First of all, my sincere thanks to the organizers and my distinguished teachers in PGI and residents, students as well. Okay. So my topic is deciding to intubate in trauma bay. Okay. So presently I'm working as an attending anesthesiologist at Lincoln Medical Center, which has affiliation with Weill Cornell Medical College, Cornell University in New York. I have no disclosures. I have no conflicts of interest. This is our Lincoln Medical Center, which is an acute care hospital and a premier trauma center serving South Bronx community of New York City for almost 170 years. It is served by 300 physicians. We have 362 beds, and it is a premier level 1 trauma center, which is the busiest in the Northeast region and third busiest in the ESA. So moving on to the topic. So objectives of my talk is about when to decide, when to intubate in a trauma, whether it's in a trauma bay or in the operating room, or how to intubate. So I'm going to start with the case discussion. In following 3 slides, I have 3 different case scenarios, so that I can make it a little bit interactive. Sorry. Okay, so case 1. As you can see, this 50 years old male fell from height straight into the gate, which basically a metal gate, and you can see in his neck, he has penetrating injury to the neck. Luckily, this patient was awake, alert, maintaining airway. He has a stable blood pressure, but he was in tachycardia due to pain. So how will you proceed? I'm going to come back later in my session about the management, what we did with this patient. Case 2, almost similar case. He has a 60 years male who was intoxicated, has a penetrating injury to the back of the neck. Basically, it's an umbrella piercing into his neck. He had stable blood pressure, is tachycardic, restless, intoxicated in the emergency department. Case 3, which is basically a case which I had last week. It's a 26 years old male, a single gunshot wound to the center of the sternum. He was fully awake but oriented to self. Initial blood pressure in the ED was 146/95, heart rate 120, respiratory rate 30, saturation 99% on face mask. He kept saying, "I'm scared." First was positive for pericardial effusion and right pleural effusion. What would you do next? Will you intubate him in the ED, or will you perform chest tube placement, or will you do will you take him to the OR? So deciding to intubate, I had to go to get an answer. I had to go through the trauma primary survey, because intubation is an integral part of primary survey. We can get the answer to intubate the patient from doing a primary survey. Basically, the primary survey is designed to assess and treat injuries that pose immediate threat to life, like tension pneumothorax, cardiac tamponade, or massive external or internal hemorrhage, flail chest, or intracranial bleed, or in situations with increased ICP. So first, you do airway assessment. If the patient breathing, is he protecting his airway? Does he need any C-spine stabilization? Next, you move on to check whether it's breathing comfortable. Is he maintaining ventilation and oxygenation? Is he coherent? Next, you check the circulation. Of course, trauma in a trauma bed, it can be a very fastly changing clinical scenario. So you have to do this primary survey within first few minutes, right? So you assess the circulation by palpating femoral or carotid arteries. If the blood pressure is lower, if the first blood pressure in the ear is lower, and patient has a 3D pulse, so patient might have either concealed hemorrhage, or patient may not be maintaining perfusion to his vital organs. The next, we have to make a quick assessment on the neurological status of the patient. Is he conscious? Is he make an assessment of Glasgow Coma scale? Does he have any focal neurological deficits? Is he moving all the limbs? And E stands for exposure, where you undress the patient and search for any other possible injury that otherwise would be missed. After doing primary survey, you do the adjuncts to the primary survey, which is basically a fast examination, which is already discussed by Dr. Sethi, and do the chest X-ray. Now, this is just a guideline to do the primary survey, which should be done within a few minutes, as I mentioned earlier. One of the case scenarios which I discussed earlier, for example, the case 3, who had single entry bullet wound to his sternum, had a pericardial effusion, had a right pleural effusion, and we did a primary survey, and we took him to the OR immediately without wasting any time in doing X-rays or any lab tests or anything. So the time is very precious when we do the primary survey. So by doing this primary survey, we get our answers whether to intubate the patient or not. Why do we need to do intubation in trauma because it's an integral part of ongoing resuscitation. There is definite evidence to show that there's increased mortality if the patient is not intubated on time. So is in most of the case scenarios in a major trauma, it will be quite obvious whether the patient needs to be intubated or not. But on the other hand, patient may be doing okay in the first few minutes. For example, patient may be awake, alert, but may be anxious, maybe tachycardic, initial blood pressure may be normal. But if there's any anticipated potential decline in the clinical scenario, for example, if you find a big intra-abdominal bleeding on the fast examination and the patient is tachycardic, so it may be a good thing to intubate rather than waiting for a few more minutes, because it's a team approach. One team will be focusing on the intubation and securing the airway. Other team will be focusing on getting the large bore IV access, and other team will be getting the patient ready for the OR. So a collaborative team approach is vital in resuscitating these patients. And I was doing the literature research. There is no definitive guidelines for intubation in trauma, but we have to individualize this case scenario from patient to patient. So that's why doing the primary survey to rule out any major life-threatening conditions is so important in managing these patients. And not making any delay in unnecessary tests or imaging in an unstable patient is very, very important. So what are the indications for intubation in trauma? The obvious airway obstruction, or if high risk for airway obstruction is there, that's one of the first and foremost indication for intubation. In a severe uncontrollable nasal, pharyngeal, or upper airway hemorrhage, or if the patient has altered mental status consistent with the traumatic brain injury, or has aspiration risk with the Glasgow Coma scale 8 or less. So that doesn't mean that Glasgow Coma scale of 12 doesn't have to be intubated. Again, we have to weigh in other factors in the primary survey. For example, if the patient has Glasgow Coma scale of 12, but is very combative, he's intoxicated, he's a threat to himself, the patient needs to be intubated before we take him to the CAT scan or to the OR. And also, in this, depending on the type of injury, there should be high suspicion for high spinal cord lesion. Patient with the high spinal cord lesion will have insufficient respiratory mechanics who need to be intubated immediately. Patient with the refractory or severe hypoventilation or hypoxia. And of course, if the patient has a cardiac arrest, patient needs to be intubated with no doubt. If there is ongoing hemorrhagic shock with impending respiratory failure, as I mentioned in one of the case scenarios, case 3 had an ongoing hemorrhagic shock even though he was fully awake, but there was an impending respiratory failure which had to be intubated sooner than later. In cases like severe smoke inhalation or major thermal or chemical burns, it's better to intubate early because more delay is made. In this case, there will be more swelling in the airway. The chances of successful intubation will be decreased in successive attempts. So, intubating in these patients in the trauma bay is very important. So, how to approach in patients with trauma? First and foremost, of course, you have to assess if the patient has any direct airway-related injury. if the patient has a if the patient has a direct airway related injury, of course you prepare for intubation with the anticipation of a difficult intubation. Okay, if the patient has concealed airway injury, for example, is there any penetrating neck injury with the expanding hematoma, with the upper airway obstruction, which may not be visible from outside, but we have to do a thorough examination during the primary survey, looking for any tracheal deviation or any absent chest excursion on one side than the other. And also we have to make an assessment for mentation of the patient. Is he awake? Is he coherent? Is he speaking fluently? Is there any change in the phonation? Is there any foreign body, or is there any blood or any secretions or any laceration in the airway? So observe the face, neck, and chest to look for any obvious injuries. Inspect oropharyngeal cavity for any disruption or of the tissues or bleeding or any foreign body. Inspect the anterior neck and chest for any crepitus or swelling, because it's quite common to have pneumothorax leading to crepitus in penetrating injuries or even a blunt trauma chest. Also, when you are doing the primary survey, also assess for the possibility of difficult intubation. Stick to your basics. Do a Mallampati test if you can, mental height, mental thyroid distance, neck circumference. All these subtle signs that will lead to difficult intubation, we have to pay attention to. And also, when we are making an assessment for the primary survey, as a part of primary survey, also assess for the landmarks of emergency airway, because you never know. Once you start the process of intubation, if you end up in a difficult intubation scenario, you should be prepared simultaneously. So it's better to coordinate with the trauma surgeon or the ED physician for the simultaneous preparation of emergency surgical airway from the beginning. So this is the rundown of algorithm, which I got from uptodate.com. Okay. So basically, it summarizes what I have said so far. Initial airway, initial assessment of airway and breathing. Is there a need for a definite airway? If yes, then call for help. Simultaneously, other team will get the IV and oxygen supplementation, put the monitors on, and get the difficult airway kits, and also adjuvant airway devices like video laryngoscope or cricothyroidotomy set next to you. If there is no need for definite airway, then do a complete trauma evaluation, close observation, including airway reassessment. There is no contraindication or there is no exclusion for not doing primary survey. Is the trachea lacerated or exposed? If no, then airway appears to be obstructed above larynx. If yes, establish surgical airway, either cricothyroidotomy or tracheostomy. If the patient is not maintaining saturation above 90%, and if the patient becomes unstable with hypotension, tachycardia, or loss of consciousness, then in suspect major vascular injury or shock, ongoing shock, and proceed to rapid sequence intubation, and get this trauma surgeon. Usually in our institution, trauma surgeons, ED physicians, and anesthesiologists are called to the trauma base simultaneously. We have a pager system where we do a tier 1 activation for any penetrating injuries. So we take care of the patient in a collaborative approach. So here's the key. Our rapid sequence with the double setup means simultaneous preparation for both direct oral intubation and emergency cricothyroidotomy. What we do is, as anesthesiologists take care of oropharyngeal intubation, trauma surgeon simultaneously prepares for emergency tracheostomy. Okay, how to intubate in a trauma patient? There is no single best technique or device that's meant for intubation in trauma bay, whichever you're comfortable with. What, for example, direct laryngoscopy or video laryngoscopy, but usually, as per our other consultants' opinion, the video laryngoscopy or fiber optic bronchoscopy play a less role in a patient who has a lot of bleeding and secretions and a distorted anatomy within the oropharynx, because any tiny amount of blood that gets in front of the camera of the glide scope will obscure the vision completely. And also, when there's a lot of blood inside the oropharynx, it's hard to visualize the normal airway from normal tissues from the abnormal tissues. That's why always stick to your fundamentals. Get the direct laryngoscopy and take a best shot. Of course, you'll have a pre-oxygenation and suction apparatus and the inline stabilization of the neck when you're doing the intubation. Anticipate difficult airway and have a backup plan. Maintaining spontaneous breathing can be challenging, but it'll be life-saving in a patient with a highly suspicious difficult airway. Continuous capnography is so vital, not only to confirm your intubation, but also to make a successful resuscitation for ongoing treatment of the shock. As I mentioned earlier, simultaneous preparation of surgical airway is very important. Okay, coming back to my case scenario, what we did in this case one, patient was 55 years male, had a penetrating neck injury. He was fully awake, very cooperative, but he was complaining of pain, of course. And we took him to the OR. We did an awake fiber optic intubation after local anesthesia with 5% lidocaine with mild sedation. And it was a relatively smooth atraumatic intubation. And there's a foreign body was taken out without any major neurovascular injury, and patient survived fine. Case two, in this case, patient was already intoxicated. So we had to put him to sleep before attempting intubation. We did rapid sequence intubation in the operating room with the video laryngoscope, and this umbrella was taken out without any major neurovascular injury. Case three, this was an unfortunate patient. Look at how we presented. It was a 26-year-old male. Blood pressure was 146/95, heart rate of 120. Keep in mind that you will not see any hypertension, especially in younger individuals, until they have lost 30% of the blood volume. So he had a normal blood pressure. It may be falsely elevated blood pressure because of the anxiety and pain, so he was maintaining saturation, but he kept saying, "I'm scared." So FAST was positive for pedicular infusion. Would you waste any time in intubating the patient in the ED or putting a chest tube? No, the patient was taken straight to the OR, was intubated in the ED. Intubated in the OR. His blood, first see how his clinical scenario changed so rapidly. His first blood pressure in the operation theater was 91/46. He was already declining in his clinical scenario because of ongoing hemorrhagic shock or cardiac tamponade. His tachycardia worsened. He was so restless at that time. We did a rapid sequence intubation, and trauma surgeons did the sternotomy and thoracotomy, and they found a hole in the AV junction and also hole in the SVC. the massive transfusion protocol was activated. Patient ended up getting 20 units of Paxil, 18 units of FFPs, 2 rounds of platelets, but bleeding was uncontrollable. Patient ended up having ventricular fibrillation. Trauma surgeons did open cardiac massage. We gave DC shock, multiple rounds of epinephrine, but a patient did not survive, and he was pronounced dead 40 minutes after 40 minutes of CPR. But we gave a best shot, but patient could not be survived. So to summarize, it's a resuscitation of a trauma patient is a collaborative team effort, and we need to have very clear communication about what we are doing. It's a team approach. Multiple teams will be doing many things at the same time. As an anesthesiologist, it's very important to make an assessment in the beginning whether the patient has a direct or concealed airway injuries, and always take C-spine precautions. Not to forget, these patients, most of the patients will have a full stomach, and there's also risk of aspiration. If you see any immediate, if you see any external hemorrhage, try to control the hemorrhage immediately, and beware of any rapidly changing clinical scenario because of the internal hemorrhage. In 1 minute, patient will be looking fully awake and vitals are within reasonable limits. In the next couple of minutes, patient will deteriorate rapidly. So we have to keep doing this primary survey more often. Anticipate difficult airway and prepare accordingly. Prepare for massive transfusion. Get big bore, large bore IVs. If the patient has a gunshot wound or stab wound in the chest, it is better to get a large bore IV in the groin, namely femoral veins. And we have to quickly decide whether the patient is to be intubated in the ED or operation theater. In our setup, we hardly take not more than 2 minutes to get the patient from the ED to the OR. So if the patient is awake and maintaining his airway and vitals are within reasonable limits, we get the patient as early as possible to the operation theater and we intubate the patient there. This is our protocol. That's the end of my discussion. My sincere thanks to the organizers, Dr. Jitinder, Dr. Kajal Jain, and Dr. Batra, Dr. Puri, Dr. Violan. I learned a lot from PGI. I feel like, most of my clinical skills, more than 90%, what I have learned in my life so far is from PGI. I'm very grateful to it. My sincere thanks to my parents as well, who brought me into this wonderful world. My wife, my kids, and also my friends who have helped me in my difficult times. Thank you so much, everybody. Any questions?
Dr. Vandana, are you there?
I'm there.
Okay.
Okay. So, Dr. Sudhir, that was a very nice lecture, very clearly put out. Everything was very clear, and I think whoever saw it got the message loud and clear. But I was just wondering that how do you feel that is it important that, except for difficult intubations, for the easy ones, where the airway is not challenging, is it necessary that the anesthesiologist be there to intubate, or the other people in the emergency room should also be doing it?
Okay, so in our setup, we have a policy where any penetrating injury will be tagged as a tier 1 activation. Penetrating injury to the chest or abdomen. I'm not talking about the peripheral, like, if he has one gunshot wound to the one lower extremity, not But we don't know. On the primary survey, we may find out more injuries in the next few minutes. So we don't want to lose any chances of possible, any possibility of identifying further injuries. So any penetrating injury, we call it as a tier 1 activation. So anesthesiologists will be there as a part of a resuscitation group, because patient may need to go to the OR immediately.
What I'm trying to come
simple
to is-
injuries, like simple injuries for just like isolated injury, patient has stable vital signs from the field and completely awake and alert, then they label it as a tier 2 activation. We don't go to see those tier 2 activation, but intubation will be done by the ED staff mostly, but anesthesiologists will be there to assess the intubation.
Because at times anesthesiologists are not enough in number and they've gone around to attend some other call and there's a patient right there. So I'm just wondering, should everyone not be equipped? Because I was going through a couple of papers where they said that the success rate was not very significantly different between in the routine intubations, not the difficult intubations, whether the anesthesiologist was doing it or another person trained in intubation was doing it. There was a difference of merely 0.5%.
I think, again, it depends on the patient population. So in our patient population, we have a high percentage of patients with a high BMI more than 40 or 45. Those have a high rate of unanticipated difficult intubation. So in those cases, our hospital policy is like not to take any chance of doing the intubation by ancillary staff and then calling the anesthesiologist, because we'll lose opportunity to secure the airway. Because as you know, in the multiple attempts of intubation, failed attempts of intubation, it becomes more harder for a successful intubation in the third or fourth attempt. So again, it depending on your setup, whether how many anesthesiologists you have, I think you can make a policy where certain set of patient population can be intubated by other than anesthesiologists. Again, it depends on the local hospital policy.
Because in our setups, we are trying to encourage everyone and maximum people to take up the ATLS courses. So people who are in the ED or even in the periphery, if they have taken up the ATLS courses, then Anyway, agree with you. Your patient population is totally different than ours. We get our intubations because our BMIs are much low. Definitely.
But what I would suggest is whenever you make a policy like that, there should be a clear-cut guidelines to make an assessment for possible difficult intubation before attempting any intubation, so that if they anticipate any difficult intubation, call anesthesiologist beforehand. They can still go and do the intubation as long as they have anesthesiologist immediately available.
Amit, you want to add something? You want to say something? There was a question, this is not for Dr. Sudhir specifically, but Dr. Rashmi Datta had asked a question about availability of USG machines in our setups, considering the PCPNDT Act. So she wanted to understand how practical it is going to be if we want to do POCUS in the emergency departments.
Well, ma'am, I think I am going to try to answer this question. Here at PGI, we have an ultrasound machine which has been procured by trauma anesthesia department, but it is under us. So whenever there is a need of ultrasound in the triage area, one of our technical staff takes the machine there. It is used under our supervision and then we get it back into the trauma ICU. That is how we are doing it here, because PNDT Act is definitely a problem, and the problem is where should we station the machine in emergency where there is so much of turnout. So we have stationed it in our trauma ICU and then we get it down there.
Okay. Thank you. Thank you so much.
Actually, in actual practice, if you see in most of the hospitals, ultrasound machines, they are hardly available in ER. In fact, it's not possible to keep ultrasound machine because of some legal problems. And of course, there are most of centers, not all centers. So it is difficult to acquire also. And but as Dr. Sudhira has pointed out that availability of the anesthesiologist come paramedics. In USA, there are a lot of paramedics who are trained in intubation, they can do the intubation. But here, the anesthesiologist may not be available in ER. As Dr. Vandana has pointed out that it may take some time to come to the ER for any anesthesiologist. So better a person who is a medical officer, like in many of the hospitals, they are trained for endotracheal intubation. As Dr. Sudhira has pointed out that there is no ideal technique for patients having trauma, but of course, you can't get fiber optic and other sophisticated gadgets like video laryngoscopes in emergency setup. Of course, there are as many techniques as an anesthesiologist, and who knows the best technique of intubation can take the first lead in ER. That's my suggestion, that who knows the best how to intubate with the armamentarium he or she is having, and that's possible in that scenario. But of course, there are constraints of various gadgets which are not handy in ER for basic life support.
Dr. Vanna, I have a suggestion. Kapil here, Dr. Kapil.
Yeah.
We have 4 ERs in our hospital, in Safdarjung Hospital, New Delhi. And one of the ERs is under us only. Like we consultants manage there with our residents, where we give the primary care like intubation and IV and things like that, fluid resuscitation. So we have posted one machine there and it is under us. So there is no problem with PNDT per se there because it is under us, and we just have to maintain a record of who's using this machine for what patient, and their all details are entered into the register, and even we are trying to put it online into a computer there. So it can be circumvented.
Yeah, that appears to be the best scenario. Very right.
Thank you, Dr. Kapil. Actually, the problem is not in our institution because we are a tertiary care center and we have all the facilities available. In fact, we have residents posted in the ER. It is for general people who will not have that facility and how to go about it doing. Like Jitendra has said, so procuring it in the department, like in our setup, the radiology people have a machine which is mobile all over the hospital. So we can get it shifted anywhere we wish to. It can come to the ER, it can go to the ICU or the wards. But then for people who are less privileged, they should know how to go about it. Thank you so much. Very nice suggestion. Thank you so much.
Small trick, and when this slide I am showing, I usually keep this probe parked here where I can see esophagus and trachea together. There is always some amount of anxiety when some junior is intubating. So if you have ultrasound machine, one of the person can just park the ultrasound probe. Usually the position of esophagus is posterolateral. Most of the time it is on the left side, and you can very nicely see esophagus as well. So as the tube is passed in, before EtCO2 is attached, you can very well recognize where the tube has gone, and you can guide the person. So if focus for airway, you can always use it if it is handy. Thank you.
Thank you, Dr. Amit. With this, we close the session. Just one comment. Probably time has come to do the task shifting. We need to train the paramedics also and empower them for, at least simple intubation. And it is very important that the tertiary care institutes take a lead in this and start the pre-hospital trauma technician course as well. With this, thank you very much for the wonderful talk, and we close the session here. We go over to the next session. Thank you.
Thank you. Thank you very much.
Thank you, Sudhir. Can you hear me, Sudhir?
Yes, I can hear you. Yes.
Thank you so much, Sudhir. You have been staying awake late in the night, and
You're welcome.
and you have been connected to so many national students all over India. They are hearing you out. And
Oh,
this
thank
is a
you.
very
Thanks for having me.
potential problem with us, how to manage and how to decide to intubate in trauma triage. Dr. Amit has given his valuable inputs and he is very good at focus. So I'm sure the residents will learn a lot from you all. Thank you very much for staying with us and being online from such a long distance. Thank
My
you.
pleasure. My pleasure. Thank you for having me.
Thank you so much, sir. Now we will start with the second session, trauma killers. First, I would like to introduce Colonel Dr. Sukhbir Mukherjee, Head of Department of Anaesthesia, Command Hospital, Chandigarh. He has many national and international publications. Dr. Apinder Preet Singh, Associate Professor, MCH Neurosurgery, PGI, Chandigarh. Areas of interest, neuroendocrine surgery, skull-based surgery, neurovascular surgery, and neurointensive care. Dr. Suman Arora, Professor, Department of Anaesthesia and Intensive Care, PGI, Chandigarh. Her areas of interest are ultrasound-guided regional nerve blocks and airway management. Major General Rashmi Datta. Yes, our virtual chair, Major General Rashmi Datta, Professor and Head of Department of Emergency Medicine, Hamdard Institute of Medical Sciences. Her special interests are critical care, pain relief, labor analgesia, and fluid management. Dr. Prasanna Bidkar, Professor, JIPMER, Puducherry, Department of Anesthesia and Critical Care. His areas of interest are neuroanesthesia. Now I request the chairperson to please welcome the speakers.
Morning, everybody. Starting the second session, we have the theme is trauma killers. We have two speakers. The first is identifying and crashing head injury patient in trauma intensive unit. Speaker is Dr. Avinash Kumar. He is Professor Anesthesiology at Critical Care Vanderbilt University, Nashville, United States. And the second lecture will be by Dr. Radwan Safa. The topic is Avoid Transfusion Killers, Damage Control Resuscitation. May I request Dr. Kumar to come online? He's ready.
I'm here, sir. Can you hear me?
Yeah, we can hear you.
Oh, great. Are you okay for me to share my screen?
Yeah.
I'd like to thank the organizers for the opportunity to talk to you all. It's a great honor to speak to the folks at PGI and for folks all over India, and to Dr. Jitendra and Dr. Kajal for the invitation to join this esteemed group, and to all the panelists as well. My primary focus is going to be on on scenarios that we need to be careful about in the trauma ICU. We're going to go over a couple of different things, including what is the evidence-based approach that we have to take care of patients with traumatic brain injury. We want to look at what the appropriate invasive, non-invasive techniques are there for intracranial monitoring. And we want to understand the strategies that actually will work and to avoid those that actually may cause more damage. So when we look at traumatic brain injury, when you look at the overall impact of traumatic brain injury in developed countries, this is data from the US. We are talking primarily about moderate to severe TBI. So patients who have severe TBI, 50% of them do not make it to the end of the first year, either because they die from the injury even after they survive the ICU course or during the course of the year, or they're not functional enough to come back to work. So the overall cost of survivors for survivors is actually very, very high in terms of the lifetime costs. So we are going to focus primarily on what the big picture principles for managing TBI are. First, we need to understand that in traumatic brain injury, there is no primary cure. So all the things that we're trying to do in the ICU, in the hospitalized setting, is to minimize the secondary damage that actually happens after the initial injury has happened. And very simplistically, if you have to explain it to like a high schooler, what we're trying to do is to maintain oxygen delivery to the affected parts of the brain. We're trying to salvage as much of the injured penumbra as possible. And from an ICU perspective, the things that we primarily are going to be looking for are the most frequent complications associated with TBI, which include the management of cerebral edema, herniation syndromes, seizures, hydrocephalus, ischemia, etc. And we'll come over a couple of these things as we talk about this. So when we talk about level of evidence, this is a chart that is actually very, very helpful. So when we talk about, when published data, they talk about level A or level 2B evidence. What that basically means is when we look at the levels of evidence, we want to look at the higher the level of evidence means, that particular intervention is applicable across a large patient population. It is usually derived from randomized controlled trials, and there's very little bias in that. The lower you drop down on the level of evidence, then it becomes more case reports and isolated cases that you have success with. When you look at the class of evidence, you want to be somewhere towards class 1, which is the benefits far outweigh the risks. And as you move towards class 3, you basically start having issues where you can actually cause more harm than good. So ideally, you want to be somewhere in the top left-hand corner of the evidence chart per se. So with that, I'm going to keep moving forward. So in this particular case, just as an example, we'll talk about a 27-year-old male who's a unrestrained passenger in a motor vehicle accident, actually unrestrained driver in a motor vehicle accident. He was found ejected from the vehicle. When the emergency medical services arrived and they did a quick exam on him, they found him to be unresponsive. His Glasgow at the scene was 9. Vitals were okay. Blood pressure was 110 by 180 by 80. Heart rate was 126. Shallow breaths, only about 8 times a minute. Saturations were about 96 on room air. So far so good. They got him to the hospital. So by the time they got him to the hospital, his blood pressures had already dropped. As we know, in trauma patients, vitals can keep changing, pretty dramatically. His heart rate now was going up, and his Glasgow was also dropping. So at this point, the airway was secured. And now the question we have to ask ourselves is, he's hemodynamically becoming unstable. So what is our strategy for, resuscitation in this particular patient? Are we going to give him more fluids? Are we going to start vasoactive medications? And if you're going to start any one of these two things, what is the endpoint of resuscitation? When do we say we have adequately resuscitated this patient, and when it's time to move on? So some of the principles on this. The first thing we need to know about trauma resuscitation as far as traumatic brain injury is concerned is you need to correct the hypovolemia, whatever the underlying causes. The hypovolemia has to be corrected initially. The patients who are hypovolemic with significant traumatic brain injury, their mortality rate is twice as high as those who did not have hypovolemia. As a rule of thumb, if you need to know a practical blood pressure, what you need to choose, you need to get their hemodynamics stabilized so that you get a systolic blood pressure greater than 100 millimeters of mercury. So if you can get your blood pressure into 3 digits, you're doing okay. And ideally, you want to get your cerebral perfusion pressure greater than 60 millimeters of mercury. Chances are in the emergency room at this point, you don't have an ICP monitor, so you're probably going to go with your blood pressure at this point. And this is backed by data even from the traumatic brain injury guidelines that were revised as late as 2017, 2018. The one thing we need to remember is, in general trauma, if someone comes in with with multiple long bone injuries and a blunt abdominal trauma, sometimes if they're hypertensive in the emergency room, let's say the blood pressure is 170 by 80 or something like that, the surgical teams will ask you to to bring the blood pressures down a little bit, so that way you can minimize the surgical bleeding. That is a strategy we need to be very, very cautious with in traumatic brain injury. It's really not, something that is advocated in traumatic brain injury. We want to keep the blood pressures above 100. So if you want to choose a blood pressure, range, systolic blood pressures between 100 and 140 is what we would look for. So in terms of fluids, so does it really matter what kind of IV fluids we end up using for resuscitation? Yeah, it actually kind of matters. So we need to think about isotonic balanced salt solutions. So plasmolite, etc., can be used. So we need to remember when we use like resuscitative fluids in traumatic brain injury is we want to avoid hypotonic fluids. So dextrose containing fluids are some things that we want to like avoid because they tend to be hypoosmotic, and that can actually worsen cerebral edema as we move forward. What about the role of colloids for like resuscitation? This is an interesting question that has come up with trauma resuscitation over the last like 20-25 years. So the first SAFE trial was actually done in like 2000-2001 that looked at colloid versus crystalloid resuscitation. And in that particular study, it was found that like the colloid resuscitation was associated with worse outcomes. So that actually like was the norm for about 10 years. Before they did the SAFE trial, they did version 2 of the SAFE trial. And even that, like, where the difference was not that significant, but in the subset of patients with traumatic brain injury, the albumin group tended to do a lot worse. And the theory behind that is like, post, traumatic brain injury, like the albumin will seep out of like, the injured vessels into the injured brain, worsening the localized edema as you like move forward. And that was the postulated mechanism that they gave for why, potentially like, the outcomes would be worse when you resuscitate with colloids in patients with traumatic brain injury. So now this patient has like, come to the trauma ICU. It is day 0. He's intubated and sedated. He's on propofol for sedation. He's on, like, say, fentanyl as an infusion at like 50 mics per hour. GCS is still 6. So the team that brings him in puts him flat on the bed, and they basically want to make sure that, like, they can optimize cerebral blood flow. So the first question I need to ask you all is, like, do you agree or do you not agree about the position of the patient? So should the patient be flat? You can text me in the chat thing, and I can see if I can look up the answers. The second question we need to ask ourselves is at this particular point with a GCS of 6 with a known mechanism for traumatic brain injury, does this patient need an ICP monitor? There are places in the world where where you may not have the facility to do this. And people may say no, I do a great clinical exam. I don't necessarily need any other monitors. It may be possible, but what does the evidence actually say? So the first thing, as far as when you look at for ICP monitoring, using the same evidence chart, it's somewhere in the 2B, 2A range. That means there is benefit to actually using ICP monitors for for managing patients with traumatic brain injury, even though the data is in a restricted patient population, as it would suggest, because you cannot put ICP monitors in everybody else. So the Traumatic Brain Injury Foundation guidelines suggest that patients who come in with severe TBI with a Glasgow of less than 9, with a abnormal CT on admission, would benefit from actually having an ICP monitor to guide therapy. The other thing that they talk about is the role of CSF drainage within the first 12 to 24 hours for management of ICP is something that they actually support. In general, the rule of thumb is you want to keep the ICPs less than 20. You want to keep your cerebral perfusion pressure, which is the mean arterial pressure minus your ICP, somewhere in the 50 to 70 range. Typically, you want it above 60 millimeters of mercury. So the one more important thing to that is the higher the CPP is not necessarily better. So that's why they give you that range where you want to try and look for this. To answer the question of the keeping the patient flat, you do not want to lie the patient flat in the ICU with patients with traumatic brain injury. That's one of the worst things that we can do as far as managing ICPs is concerned. You want to have the head of the bed at least 30 degrees. The reason why 30 and not 25 or 15 is at that particular sort of elevation, there is no compression of your neck veins, so there is no impedance to venous drainage. So the chances of having venous hypertension as a worsening factor for ICPs is not really a concern. So what's the next thing that we need to do? Let me see if I can move forward on this. Okay. Yeah. So when you look at ICP monitoring in the ICU, there are several different ways that you can do this, depending on your setup, depending on what you have available. The least invasive and probably the most widely used method is to use an intraparenchymal sensor. It's also called an intraparenchymal bolt. It is a modified strain gauge. It has a fiber optic tip that will give you a ICP number. It does not allow you to drain any CSF, but it gives you an ICP number. The other most common thing that people use is an intraventricular catheter. People call it by different names. It's called a ventriculostomy. It's called an external ventricular drain. So basically, it not only gives you an ICP number, but it also gives you a method of draining some of the CSF for you to better control the ICP in certain cases. So when you look at the bottom left-hand corner out here, like this is what your normal ICP waveform looks like. So you have, it's a triphase peak, you have like P1, P2, and P3. And so P2 is the most important piece of the waveform that you need to be concerned about. That is a measure of your intracranial compliance. So in patients with true increased ICP, you basically have a peak of P2, which is higher than all the other two waves. And that usually is an indication that the patient has increased ICP. Now, at times when where ultrasound is becoming more and more, frequently used, it's almost like a cure that is looking for a disease. Ultrasound is being used for everything. You can use this also for for quick assessment to say if somebody has an increased ICP. You can actually use the 12 hertz probe, the high frequency probe. Basically, you need to decrease the power on the ultrasound, so that way you don't injure the vitreous. You look directly through the lens towards the optic disc, and this is the kind of image that you end up seeing. You see the dark vitreous, and you see this finger-like projection behind the optic disc. And you take a measurement of the widest point of this, this anechoic zone of 3 millimeters behind the optic disc. And if that is greater than 6 millimeters, it indicates that the patient has increased ICP. It's an all or none phenomenon, so it is not a quantitative way of looking at this. It just tells you whether somebody has increased ICP or not. You need to look at both eyes to be able to make a judgment call. So the same patient now, it's hour 14 since admission. So there are new changes in the neurologic exam. The patient has extensive posturing. The pupils are more sluggish based on what your initial assessment was. Your CT scan is back by now, and there's worsening. As you can see out here, there is worsening midline shift. There's compression of your ventricles. There is a small subdural out here, but that has not expanded from the time of the injury. But you can see there is significant cerebral edema. So what is the strategy moving forward from this point? How are we going to manage and stabilize this particular patient? So we're going to look at what the evidence is and what some of the other strategies that we can use. So I'm going to break it down into this matrix. This matrix is probably one of the most helpful things that you can have when you're actually having trainees who have to manage some of these patients. So it is a matrix between your ICP and your cerebral perfusion pressure. So you have an ICP monitor in, and you look at if your ICP is less than 20 and your cerebral perfusion pressure is greater than 60, you're doing great. Keep going. You don't have to do anything else. So the question then becomes when you come to the red part of the matrix, this is the point where you have the highest potential for deterioration and for worse outcomes. These are patients where their ICP is greater than 20, and at the same time the cerebral perfusion pressure is actually dropping. So this is somebody that you need to aggressively manage from an ICU perspective to see if you can optimize things to to save this particular patient. So one of the things that is suggested in the sort of a new way of approaching patients with traumatic brain injury is to do what is called the mean arterial pressure challenge. Basically, you have an ICP monitor, you have a CPP, and you have an idea about cerebral perfusion. So you increase your mean arterial pressure by 10 to 15 millimeters of mercury using vasoactive medications, and you keep the mean arterial pressure higher for about 10 to 15 minutes, and look at what happens to your cerebral perfusion pressure parameters. If you are able to make a difference, if you're able to achieve your targets, then that would be the new blood pressure goal that you will actually choose for this particular patient. At the same time, all the routine things that we would do, in terms of making sure that the head of the bed is okay, we have augmented hemodynamics, we have treated any underlying anemia if that is an issue. If the patient is on mechanical ventilation, we can minimize the sort of the role of neuromuscular activity by putting them on muscle relaxation to do this. In this highest risk group, the two other things that people talk about, which are actually life-saving, can be potentially to induce a barbiturate coma. Basically, that way you decrease the cerebral metabolic rate in an effort to decrease ICP. And obviously, the last thing that they also talk about is an early decompressive craniectomy in these patients. And we will look at some of the evidence on some of these things. So I just put this slide out here looking at these number of studies that have looked at cerebral perfusion pressure-based therapies. I want to give you a word of caution on this because there's always a question that comes up. What is more important to address? Is it the ICP, which is the more important thing to address, or is it the cerebral perfusion pressure? So the answer is it's a trick question. Both of them are important. What is important is to make sure that you're able to balance the two out, because cerebral perfusion pressure theoretically can be reached. So let's say the ICP is like 35. We know that it is high. You can theoretically reach a cerebral perfusion pressure greater than 60 by just ramping up your blood pressure and your mean arterial pressure. So by ramping up your norepinephrine dosing, you should be able to reach that goal. But that does not necessarily make a positive outcome. So we need to make sure that we are able to balance and keep the ICPs less than 22, and we need to make sure that we're able to reach the goal of cerebral perfusion pressure greater than 60 by balancing these two out. The same patient. Okay, now we have, this is hour 18. We still have a new neurologic change. The pupils are becoming more sluggish. The ICPs are continuing to rise at this point. They're like more than 35, and they're sustained now for about 35 to 40 minutes. You've already gone up on your vasoactive medications, namely your norepinephrine, like we talked about. Now, what are the things that we need to be doing? Most likely, you would have already done some of these things by the time you get here. But if you had to go by a stepwise method, what is it that we're going to do at this point? So at this point, what you need to remember about acute head injury is this. And for routine, for patients who come into the ICU, routine, hyperventilation is not recommended. The only possible time that you hyperventilate somebody is if you're taking them to an operating room for acute decompression or if they're acutely herniating right in front of you. Routine, hyperventilation is not recommended. And part of the reason for that is this. We know that with hyperventilation, you change your CO2 in the blood, causes cerebral vasoconstriction. Yes, it does all that. We know that. What you don't have control over is which blood vessel in the intracranium are you actually constricting and which one are you not. And usually in patients with deranged autoregulation, the poor get poorer, the rich get richer. So actually the areas that are already damaged tend to get worse. So that's the reason why we don't routinely hyperventilate patients. Head of the bed 30, like we talked about. And then we come to hyperosmolar therapy, which is basically a way of shrinking the brain. So these are the mainstays of therapy, like we know about, mannitol, hypertonic saline. The key thing to know is hypertonic saline is not a single concentration. So the most common concentrations in North America that we use are 3% hypertonic saline, 7.5%, and 23.5%. 23.5% is basically used in in acute herniation syndromes. 3% is the most common one that people use across the board in hospitals in North America. So what is the data? What does the data say about using hyperosmolar therapy for management of intracranial hypertension? So if you look at the evidence, it's actually in the 2C level, which basically means there is some data to support this, but it is not in a wide patient population. Again, it makes sense because we are not giving hyperosmolar therapy to a broad patient base. It's a very specific group of patients who end up getting hypertonic saline. So it is still recommended for you to go ahead and do this. So what we do not want to do for the management of acute cerebral edema in the setting of traumatic brain injury is to give patients steroids. Steroids have no place in the management of cerebral edema secondary to traumatic brain injury, because the primary mechanism of of cerebral edema in these patients tends to be cytotoxic cerebral edema. There's a small component of hydrostatic cerebral edema, but most of it is cytotoxic, and steroids really don't work for that. So some of the practical points when you use mannitol. So when do we know that we have given somebody too much mannitol? So we just can't, there is a definite ceiling to how much mannitol we can use. You need to be, monitoring what's called the osmolar gap. So it is the measured osmolarity, serum osmolarity versus the calculated osmolarity. And if that gap keeps increasing beyond 15, what that tells you is you have an osmotically active compound in the bloodstream that is contributing to that osmotic gradient. And that's the time for us to stop using mannitol. Similarly with hypertonic saline, so it's really important to know that the osmolarity of of hypertonic saline is very, very high. You need to have central access when you're giving this. It'll basically thrombophlebitis of the peripheral veins is very common. So that's the reason why we end up using central access for for using hypertonic saline, anything that is greater than 3%. So rebound cerebral edema is common. Hyperchloremia obviously is common. Exacerbation of CHF, etc. Another key important thing is because of the chloride load and because of the sodium load, delayed acute kidney injury is also a concern in patients who get a lot of hypertonic saline. This is something to think about as well. So when we talk about advanced monitoring for the injured brain, there are multiple other things that have come up in the last 10 to 15 years. And some of this is is more applicable in specialized centers. Some of this is not going to be something that you can use in every single place around the world. And frankly, like some of these more advanced monitoring mechanisms don't have a lot of the data to support it as being one of the things that we need to do for all head injury patients. So the things that we use right now commonly that are still actually applicable across the world would be ICP monitoring. We know that. We can also look at brain oxygen tissue monitoring. That is something that is becoming more and more widely available. And in certain specialized centers, people also use microdialysis for head injury patients. Again, this is not something that is required. So the brain tissue oxygen saturation is something that is interesting to note. That it is the partial pressure of oxygen in the brain interstitium. It is not a direct measure of oxygen delivery. Okay? It is a surrogate measure of the amount of oxygen that shows up in the interstitium after cerebral metabolism. So it has a sort of like a parabolic relationship between oxygen delivery. So you got to interpret that information with a grain of salt. It is not a direct correlation. So similarly, when you have patients with with increased ICP and who also have this tissue oxygen monitor, you really want to concentrate on the areas of the scenarios where you have uncontrolled ICPs at the same time where you have the tissue oxygen numbers that are beginning to drop. Those are the ones where you actually end up needing to do something. And similar to what we talked about in the initial evidence-based approach is you would do a MAP challenge, a mean arterial pressure challenge, to see by if increasing the cardiac output and increasing the flow, you're able to increase oxygen delivery. You're able to do that. Second thing is if the patient is borderline anemic, let's say the hemoglobin is in the 7 to 8 range, this is one of the few scenarios where they may actually benefit from transfusion at this point to increase the oxygen carrying capacity. We typically, are conservative as far as transfusions are concerned, but this is one place where you may want to think about it. And you obviously want to decrease the sort of the oxygen consumption, and you can do that with neuromuscular blockade, barbiturate coma, etc. And now we come to the big, the elephant in the room, which is about the surgical options for traumatic brain injury and decompressive craniectomy. So for the longest time, so decompressive craniectomies have been around for thousands of years, right? So right from the time of Shushruta and from our ancient surgeons, it's gone through multiple variations. It used to be a thing in the 1940s. It went away, came back in the 1970s, went away, came back in the 2000s. And we have different variations of technique, but the basic surgical, approach has not gone away completely. So is it helpful? Is there any data to back it up? There were 2 randomized trials in the last 20 years in the neurosurgical literature, which itself is amazing to do randomized control trials in the neurosurgical patient population. The first trial was called the DECRA trial. It was done in Australia and New Zealand. And basically what they found was in patients who had sustained rise in ICP over a window of time, if you sent them for a decompressive craniectomy, basically taking off half their skull and allowing the injured brain to swell, you were able to save patients' lives by doing that early. They redid that same trial with the same kind of patient population, but with tighter sort of statistical analysis and tighter design control, and that was called the Rescue ICP trial. That's the most recent one. The Rescue ICP trial, it did not necessarily show a true survival benefit across the board, but what it did show was actually I should take that. It showed a survival benefit. People would survive, but not necessarily with a great quality of life. So that was the sort of the secondary aspect that came up with the Rescue ICP trial. So in selected patients who have medically refractory ICP control, decompressive craniectomy may be actually helpful. And this is what the data from the trial actually showed. So when you look at the Glasgow outcome scales, so you want the scores to be as much in the green and the blue as possible. The more you start getting towards the darker parts of the graph, that means more patients basically died. If you're in the red and the orange, these were patients with significant disability. They were essentially they were nursing home bound. They needed 24/7 care. So you have to ask yourself, just because you save a patient's life, and if you put them into a vegetative state or a high dependency state, was it actually worth it? So that is the dilemma that that people have with offering decompressive craniectomy across the board to all patients. So you want to choose your patients, successfully or carefully when you give them the option of doing a decompression. So in summary, we know what actually works. What works is head of the bed greater than 30, ICP management, whether you actually use cerebral perfusion pressure or use an ICP monitor to help guide your therapy. Airway management. In airway management, what we talk about is early tracheostomy in patients who have significant traumatic brain injury. The reason is, significant traumatic brain injury, the timeline for recovery is weeks to months. So you have not changed the underlying airway, concern. So doing the tracheostomy early would be helpful. Nutrition, like with all ICU patients, that's extremely important. Seizure prophylaxis, extremely important. It's for 1 week. It's 7 days of seizure prophylaxis from the day of injury. If there's no seizures after 7 days, you can stop. Otherwise, they need to continue with it. DVT prophylaxis, we know that. Patients in the ICU require DVT prophylaxis, even if they have bleed in the brain. Surgical options, like we talked about, decompressive craniectomy. What does not work? This is the key things. So we do not want to do any harm. You want to avoid routine hyperventilation on all patients. Okay, your hyperventilation is only advocated when you're taking them to the operating room for a decompression. No steroids. So steroids for cerebral edema in the setting of traumatic brain injury is an absolute no-no. So prophylactic hypothermia. This is like one of those things. People have come back to hypothermia over the last 50 years. Because theoretically it seems to make sense, but it has never really worked for traumatic brain injury and for a lot of the other neuro things as well. So prophylactic hypothermia for the management of routine ICP control is not advocated. And I put that last one in there because oral care is really important because ventilator associated pneumonia risk is very high in patients with severe TBI. And the combination of using povidone iodine as the decontaminant for the oral cavity is something that is not recommended anymore. So these are some of the do's and don'ts when you think about what we need to do for patients with traumatic brain injury. So I'll open this up to questions at this point. I just tried to summarize the useful information that will be helpful across India. I'm happy to take questions.
Hello.
So, thank you, Dr. Avinash. We have chairpersons in the virtual gallery as well as physical. So if virtual gallery people want to initiate, otherwise I'll ask our Dr. Apinderjeet, our neurosurgeon, to initiate the interaction.
Yeah, thank you, ma'am. Thank you, Dr. Avinash. It was really nicely summarized. Yeah, I agree to some points of yours like normotension, normovolemia, normocapnia is the key at this point of time. Colloids, obviously, they're not the recommended first-line treatment for management of the head injury patients. Regarding the ICP monitoring and CT-guided management. So yes, Brain Trauma Foundation guidelines have found that ICP-guided treatment and CT-guided treatment, the hospital stay and the GCS at discharge was better in ICP-guided managements, but the Glasgow outcome scale after 6 months was same in CT guided as well as ICP guided management patients. And there are some pros for ICP guided management, like you can drain the CSF, you can real time manage the ICP, and time taken to shift the patient to CT scan and to know the deterioration is shortened away. Absolutely. The cons, there are some problems with this ICP guided because see, you want to drain the ventricle to drain the CSF, but in trauma patients, sometimes you are not able to hit the ventricle because of the edema. The ventricles are chinked, you are not able to go there. There is midline shift, you are not able to hit it. You can go to the wrong place and cause added deficits. The other point is an injury like acute SDH, is a pure SDH or there's an EDH. If you drain the CSF too much, it can cause further increase in the hematoma formation. And then there's an infection also, which is there in the ICP invasive monitoring. But yes, ICP monitoring decreases the time for deterioration, picking up the deterioration. And so it's still a matter of debate I would like to guess upon. Any questions from the, yeah.
Good morning. This is Dr. Amiya Kumar Barik, Assistant Professor in the Department of Anesthesiology, PGI. Sir, I would like to know what is the role of TCD in TBI patients. I have two queries. One is the role of TCD in TBI patients. Another one is if the patient is chronic hypertensive and that patient comes to us with trauma, what should be the CPP goal? Whether we should keep in higher range or the range which you have already mentioned.
Great questions. TCD is again something that there are very specific and useful indications for TCDs, especially with subarachnoid hemorrhage when you're following patients for vasospasm, etc. In the setting of of traumatic brain injury, specifically if you're going to use that for ICP management, there are better ways of doing it, and again it depends on your setup. So here in my institution, they put the parenchymal bolts more commonly, more than the ventriculostomies, and what our esteemed chairperson was also talking about. Yeah, a lot of times in traumatic brain injury, because of the diffuse swelling, the ventricles may be slit-like, you may not actually get a target at all. The second question, as far as the CPP goals are concerned, again, there is data to say that higher CPPs, just chasing a number, keeping more is not better. So 60 and above, 60 to 70 is probably the highest that you want to keep that. Because the secondary complications associated with trying to keep the cerebral perfusion pressure at a higher number is associated with worse outcomes, because the secondary respiratory risk is higher, respiratory complications are higher, hemodynamic complications in terms of requirement of vasoactive medications, etc. are higher. So and there is no benefit of keeping it higher at that particular point. So as far as patients coming in with what the normal blood pressure is, when they come in as a trauma, we really don't know what they're what they live at home, right? So we go with our best estimate of what we have in front of us. So so using that as sort of the goal, 60 probably is going to be like a ballpark number that is easy to to shoot for. Does that answer the question?
Yeah, may I add something more, please? Dr. Avinash, it was a wonderful lecture. Very nicely, you brought out all the points, the do's and the don'ts. There was one concept for the person who had asked the question just now. There was a concept called the TM50 concept about ICP, the perfusion pressure, the difference between the perfusion pressure and the ICP. So that was what was to be maintained. So if the CPP goes higher, obviously, and the ICP goes higher, we have to take a round figure of approximate figure of 50. So that is what generally helps, because the management keeps changing at minute by minute. You will have to keep re-evaluating the patient, especially traumatic brain injury with the secondary effect coming on soon. So this concept of TM50 is something which has to be thought about.
Sure.
Absolutely. I would like to add to, sir. Excuse me, chronic hypertension and acute hypertension I would like to add.
Chronic, sir.
In acute hypertension, whenever there is sudden rise of blood pressure, there is protein leakage from the vessel wall to the brain. So there is raised ICP. While in chronic hypertension, the vessel wall is thick. So there is no sudden increase in ICP if you keep the blood pressure high also. So that is the point. If the patient is chronically hypertensive, there is no need to decrease the blood pressure beyond a certain point of time. You can keep it higher also. There is no problem in that. That's the point.
Fine, sir. Thank you.
Thank you, Dr. Avinash. Now we will move on to the second presentation, which is by Dr. Radwan Safa. Radwan Safa is assistant professor at Department of Anesthesiology, Albany, USA. Dr. Safa, please start.
Yes. Can you hear me?
Dr. Safa is going to discuss about the damage control resuscitation, where main focus will be to prevent the coagulopathy, acidosis, hypothermia, which is a lethal triad. So, Dr. Safa, can continue.
Hello, are you able to hear me?
Yes, we can.
Okay, great. Thank you so much for the invitation. Thank you to the organizers. When I agreed to give this presentation, I didn't fully appreciate the time difference between New York and India. I find myself on call actually tonight, and my call partner is weathering the storm here. So I apologize in advance if I get any calls here during the presentation, but we'll try to make it through. So let me share my screen. Are you able to see the slides? Yes, okay. I only have the slides showing to me. I'm not able to see the audience or myself, but we'll just move through here. So this is Albany Medical Center. We are a level 1 trauma center. We have approximately 700 beds.
We can see, we don't see your video, but we can see your name in the, so is your video on?
You can change the settings in the gallery and
yeah.
It says that I'm sharing. Let me start my video.
You can have side-by-side gallery and then you will see yourself.
Okay, we see you now. Yeah. So,
So if I press screen share, entire screen, window.
Yeah, we are not seeing you.
Yes, doctor. Yes, doctor.
Side-by-side you can have.
Chetan, we request
Yes, I'm
you.
helping. I'm helping. Dr. Safa, yes, please select. Yeah. Great. Put it on a slideshow mode. Thank you very much.
Will do. Is that better?
Perfect, sir.
Is that better now?
Okay.
Is that better now?
So you can.
Yeah.
Well, I can only see the slides. I can't see the audience or myself, but that's fine as long as you can see the slides. Are we okay?
Yes, sir.
Okay. All right. So this is our institution. As I was saying, we're a level 1 trauma center. We have approximately 800 beds. In a typical year, we will have close to 4,000 trauma admissions. And typically in a year, we have about 100 patients proceeding directly from the emergency department to the operating room. So these are typically our more injured patients, our level 1 trauma patients. So approximately 2 patients per week coming directly to the operating room from the emergency room. Now, as I'm sure most of you are aware, trauma is the leading cause of death in younger patients, so under the age of 50. And uncontrolled hemorrhage is the leading cause of preventable death in that population. So I'd like to just start with a case here to help organize our discussion. This is a typical patient that we might see in our emergency room on a summer evening. This is a young gentleman, JM, sustained a gunshot wound to the abdomen, not far from the hospital. When EMS arrived on the scene, they found him agitated and pale, with the vital signs listed here. He had a tense and expanding abdomen. So considering the clinical context here, the explanation for this patient's hypotension is not a mystery. This patient is bleeding, and bleeding trauma patients represent a unique population in that it's unreasonable and perhaps unattainable to target normal physiology in these patients until surgical hemostasis is achieved. And so these patients require a different management approach, and that approach is a bundle of interventions referred to as damage control resuscitation. So what are the components of damage control resuscitation? They include the minimization of crystalloid, permissive hypotension, the prevention and treatment of coagulopathy, and arguably most important, rapid progression to damage control surgery. So the goal here is surgical hemostasis. We should not lose sight of that. This is the most important component, although we won't spend much time discussing that. So as a term, damage control originated during World War II in the US Navy, and it referred to a set of interventions that were undertaken to salvage a damaged vessel, a battle-damaged vessel. And there were 3 phases. They included immediate repairs to keep the vessel afloat, return to port, and that was followed by definitive repairs. So the analogy here fits very well. And in fact, in the US Navy and Coast Guard, a damage controlman is a designated rank, and they wear this insignia here on their shoulder. And here's an example of a damage controlman trying to repair a ruptured bulkhead on a ship. So in medicine, damage control referred to the notion of abbreviated laparotomy in the face of uncontrollable hemorrhage. And it was first introduced by this gentleman, pioneering surgeon, Dr. Pringle, also of the Pringle maneuver for our hepatobiliary surgeons. And this gentleman, as I said, managed uncontrolled hepatic hemorrhage with abdominal packing and abbreviated laparotomy. As a surgical technique, damage control surgery crystallized in the 1980s, and this is the first publication evaluating damage control surgery and the first kind of mention of it in the literature. And this happened, as I said, in the 80s. I don't want to go into the small details of this study, but it was a very small study, approximately 30 patients, and they compared standard of care at the time, which was completion of surgery, versus the damage control approach, so the abbreviated laparotomy, and they were able to show a significant mortality benefit in patients that were managed with damage control surgery. So again, this is more of a marker just in terms of when this technique began gaining acceptance in literature. Now, as I mentioned earlier, hemorrhage is the leading cause of preventable death in these traumatically injured patients, and a major driver of that is coagulopathy. So what are the main mechanisms contributing to coagulopathy in trauma? And there are really three main mechanisms with some interplay between them, three main drivers. They include environmental factors. So these include many medications that the patient may be on, any underlying diseases. The second is resuscitation induced, also known as iatrogenic. So this depends on the quality of the resuscitation that we provide to these patients. And finally, arguably, most importantly, oxygen debt has a direct impact on dysregulated coagulopathy as well as endothelial dysfunction. And so this phenomenon is termed acute coagulopathy of traumatic shock. It may also be seen in literature as ATC, or acute traumatic coagulopathy. So let's look at each of these components in a little more detail, starting with the minimization of crystalloid and colloid. Prior to the advent of damage control resuscitation, large volume crystalloid resuscitation was ubiquitous in medicine, used to treat all varieties of shock, particularly hemorrhagic shock, and that management strategy was supported in part by this trial. And this is we point to this trial a little bit for originating that approach. And without going into the small details, what this group did was to take high-risk surgical patients with pulmonary artery catheters and randomize them to two groups. One was a supranormal group where they targeted a supranormal cardiac index in the range of 5 liters per minute. And they used, as I alluded to, large volume crystalloid as well as pressors to achieve that. The second group was a more normal cardiac index in the range of 2 liters. And what they were able to show was a mortality benefit in this supranormal group. So this trial was also published in the 80s, and this began to gain acceptance in the medical community, and kind of combining this notion with the idea of damage control surgery, which I also was gaining acceptance in the 80s, what surgeons began to notice was an inability to close the abdomen in these patients that were treated with a combination of these techniques. And so this led to researchers to take a closer look at crystalloids in trauma resuscitation. Subsequently, multiple observational studies were published that showed an association between large volume crystalloid resuscitation and multiple negative outcomes, including impaired wound healing, coagulopathy, cardiopulmonary complications, as we mentioned, intra-abdominal hypertension, and ileus. So this is a human study looking at crystalloids in trauma resuscitation. This was an interesting study, a single center study, approximately 600 patients with penetrating injuries, stab wounds or gunshot wounds, and they were broken up into two groups. The first group was standard of care, and these groups received immediate crystalloid resuscitation upon arrival of emergency medical services on the scene. So they placed an intravenous catheter, began resuscitation with crystalloids. The second group, the delayed fluid resuscitation group, crystalloid was withheld in the preoperative phase as well as the initial emergency room. And so these patients had crystalloids withheld until they made it to the operating theater. So what were the differences between these two groups? So upon arrival to the emergency room, not surprisingly, the delayed resuscitation group, here the approximate difference in crystalloid between the two groups was close to 3 liters. So patients in the immediate resuscitation group received approximately 3 liters more crystalloid than the other group. So how do we operationalize this notion of minimizing crystalloids? And a systems level solution to this problem is to have a well-developed massive transfusion protocol at your institution. So with a mature massive transfusion protocol, rapid activation and arrival of blood products at the bedside, there's really little indication or reason to even consider crystalloids in a hypotensive trauma patient. This quote by Dr. Philip Spinella, who wrote one of the textbooks on damage control resuscitation, sums it up very well. He says that blood is for bleeding and salt water is for cooking pasta. Now, I've not had the pleasure of meeting Dr. Spinella, but I'm guessing that he is of Italian descent. So if we return to our case here, JM is in the emergency department. He's becoming agitated, combative. He's intubated with a combination of etomidate and rocuronium. A femoral cordis is placed, and a bedside fast exam is grossly positive. He receives 1 unit of whole blood, a gram of TXA, and he's transferred emergently to the operating room. So what should our blood pressure targets be while caring for JM in the operating room? Permissive hypotension as a concept originated in the early 20th century. This was the first mention of it. This is Walter Cannon, who is a famous World War I surgeon, who said that injection of a fluid that will increase blood pressure has danger. A very prescient quote from this gentleman. Do we have any data to support this notion? So this is an interesting study. What I'd like to do, because I think the figures may be a little confusing, is just to spend some time on the experiment itself. So this is an animal study, a pig model of hemorrhage. And what they did was to take these animals, perform an X-lap, and using a biopsy punch, basically make an aortotomy in these patients' in these animals' abdominal aortas. And what they did after that was to wait, essentially, wait until the bleeding either stopped spontaneously or the animal passed. And there were some animals that did pass, but in the animals that survived, so their bleeding resolved spontaneously, they initiated crystalloid resuscitation at the rates listed here above. So 100 mLs per minute and 300 mLs per minute. And those were initiated at certain time points after the resolution of bleeding spontaneously. So if that's clear. So the x-axis here is in minutes, and these are minutes post spontaneous resolution of hemorrhage. And what we're looking at on our y-axis here is the blood pressure at which bleeding resumed. And the way that they measured this was to place suction catheters in the paracolic gutters of these animals and connected those catheters to suction. Basically, the blood was collected and weighed. So in this way, they're measuring hemorrhage in real time. Hopefully that's clear. So again, our x-axis is minutes after the resolution of spontaneous hemorrhage, and our y-axis is the blood pressure at which bleeding reoccurred after the delay, after they initiated this crystalloid resuscitation. So what they were able to show here is a consistent systolic pressure, mean and diastolic pressure at which bleeding recurred. And if we focus on our map here, we can see that that map is in the range of 55 to 65. So this is typically the map that we target until surgical hemostasis is achieved. Are there other data to support this? So this is a meta-analysis of 9 animal studies, again, comparing hypotensive versus normotensive resuscitation. And our main outcome here is death. And we can see that the pooled risk of death in animals treated with hypotensive resuscitation was 0.37. So statistically significant decrease in the risk of death. What about in human studies? This is a meta-analysis of human studies, again, looking at the same endpoint. And in the permissive hypotension group, if we looked at the pooled risk of death, again, statistically significant decrease. So there are really 2 techniques to achieve targeted hypotension in our patients. One is a vasoconstricted technique, and this is achieved with fluid restriction. This may be what happened in that first study that we discussed, where they were withholding products. And the second is a vasodilated hypotension, and this is the more favorable subtype of the 2. This promotes flow, and in practice, the way that we achieve this, if we are in the operating room and we find our blood pressure targets are above where they should be, then we can administer a small dose of analgesic or very low dose anesthetic to facilitate a vasodilated state. And this is, of course, combined with blood product resuscitation. So we have reassuring data in animals and humans that permissive hypotension is effective. Unfortunately, and as Dr. Kumar, I'm sure would agree here, there is a major problem with the widespread application of this technique, particularly in trauma patients, and that is traumatic brain injury. The majority of trauma patients here in the States, the vast majority are actually blunt trauma, and traumatic brain injury should be suspected in all of those patients, particularly if they're coming to the operating room directly without any imaging or further workup. And so how do we manage these patients? And the short answer is it's controversial. There's really not a good answer to this question. These are the recommendations from the most recent iteration of the Brain Trauma Foundation guidelines. And they recommend in patients with traumatic brain injury to target a systolic blood pressure of 100. Targeting that blood pressure, the specific wording here is highlighted, may be considered to decrease mortality. So one point that I'd like to make here is that the level of evidence supporting this is not very high. And we just had that refresher from Dr. Kumar. So level 3 evidence supporting this recommendation. And the other point worth making is that if we agree that permissive hypotension is impacting mortality, and we know that hemorrhage is a short-term cause of death, so we're talking in the first hours of a patient's course, that perhaps it's not unreasonable to focus on preventing death from hemorrhage, perhaps at the expense of this data. And again, Dr. Kumar may have some other thoughts on this, but definitely a controversial topic without a clear answer. So back to our patient. He is in the operating room now. They perform an XLAP. They find a renal pedicle injury and a small bowel injury, and unfortunately they're unable to salvage the kidney. He has a nephrectomy. They staple quickly across the bowel injury. He receives the products listed here, and maps are maintained around 60 millimeters of mercury, again, kind of targeting a vasodilated approach to meeting that goal. He's left open and transferred to the surgical ICU. But to finish here, I'd like to discuss the prevention and treatment of coagulopathy, and we'll return to this figure here. Again, we mentioned the 3 main drivers of coagulopathy, so environmental, resuscitation-induced, and oxygen debt-induced. And we'll focus here on resuscitation-induced coagulopathy. We've already discussed that minimizing crystalloid has an impact on minimizing trauma-induced coagulopathy. The other important driver is the ratio of blood products that are administered. This was a landmark trial. This was the PROPER trial, published in JAMA in 2015. This was a multi-center prospective randomized trial, approximately 700 patients with massive transfusion protocol activated in these patients, so traumatically injured, bleeding patients, randomized to two groups, one to receive a low ratio resuscitation, so they received 1 to 1 to 1, and that's platelets, plasma, PRBCs, platelets, plasma, 1 to 1 to 1, versus a higher ratio of 1 to 1 to 2. So these were, PRBCs were 2, the other products were 1. And their main outcome was, their primary outcome was mortality, both early at 24 hours and at 30 days. And so what were they able to show? What they found was a trend towards a decrease in mortality between these two groups. So that trend did not reach statistical significance. It was about a 4% absolute difference in mortality, favoring the low ratio group. It's worth pointing out that this study was powered to detect a mortality difference of 10%. And so perhaps there is a signal here that didn't reach statistical significance because the recruitment was not sufficient. So the main takeaway here is a non-significant trend towards decreased mortality in the low ratio resuscitation group. They went on to look at some secondary endpoints, including the cause of death in these patients. And what they were able to show was a statistically significant decrease in death caused by exsanguination in patients treated with the low ratio resuscitation. So excellent. So if we have these patients in the operating room, if we just treat them with low ratio resuscitation, 1 to 1 to 1, we should be fine. Unfortunately, not that simple when we're dealing with fractionated blood products. And so if we just take a look at this figure here, if we take a unit of whole blood, we add anticoagulant to it, we spin it down, fractionated into our components, and if those are transfused at 1 to 1 to 1, low ratio, we can see that what we're left with is an anemic coagulopathic patient. So in fact, even a low ratio resuscitation promotes coagulopathy in our patients. And so how do we deal with this? What is a perhaps more tailored approach to resuscitation in these patients? And this is where bedside monitoring comes in, both of whole blood clotting, so techniques such as thromboelastography and rotational thromboelastometry. Here in the United States, we use primarily thromboelastography, or TEG, and coupled with bedside monitoring of standard lab tests. So using these techniques, we are able to better tailor our resuscitation. And is there any data to support this notion? And this is a meta-analysis looking at the use of whole blood clotting measurement in trauma, and they were able to show a decrease in mortality in patients that were treated with these techniques. So to summarize, we discussed minimizing crystalloid and colloid in these patients. The data suggests that crystalloids are harmful and really should not be considered in a hypotensive trauma patient. We discussed targeting a MAP of 55 to 65 in these patients. And the favorite approach to that is a vasodilated hypotension, one that combines appropriate resuscitation with small doses of either analgesics or anesthetics. As far as the issue of traumatic brain injury in these patients, controversial. It's unclear, but I would suggest that if we believe permissive hypotension is contributing to improving mortality, that we should focus on the short-term cause of death, perhaps at the expense of others. And finally, we discussed the prevention and treatment of coagulopathy. And we will use empirically low ratio blood product resuscitation, 1:1:1, and we'll further tailor our resuscitation if we're able with real-time monitoring of whole blood clotting at the bedside. So to return to our patient again, JM came back to the operating room on hospital day 4 for anastomosis and closure. They were able to close his abdomen without any difficulty. A diet was initiated on hospital day number 6, and he was discharged on hospital day number 8. So unlike the leading causes of death in this country, things like heart disease, cancer, lung disease, trauma is a disease of generally the young and healthy. And if we are able to help our patients make it through those crucial first hours after traumatic injury, they can potentially regain long, productive lives. That's all I had. I'm happy to take any questions.
Thank you, Dr. Radwan. I have a question.
Yes.
What is the role of hemostatic agents in damage control resuscitation, like tranexamic acid?
Yes. So tranexamic acid, the data suggests that giving tranexamic acid empirically to all trauma patients, as long as it's within the first 3 hours of injury, is reasonable. I think there is some more data coming out now that is arguing that some of these patients may be hypofibrinolytic. So there may be a subtype of patients that may be harmed by tranexamic acid, but that data is not convincing, in my opinion. And my practice, if a patient is within 3 hours of injury, is for them to receive tranexamic acid. Of course, unless they have known PEs or DVTs or things like that, but we typically don't have the luxury of that information. As far as other factor concentrates, this is an evolving area. There's still data coming out as far as factor concentrates versus FFP.
Thank you. Dr. Rashmi, do you have any questions?
Dr. Rashmi is not there. I have 2 quick questions from each speaker. Dr. Rizwan, can I ask you, is there any role for whole blood in damage control, or do we go on the low ratio products as you had suggested?
Yes, that's an excellent question. So the data on whole blood at this point is retrospective and from the military, at least here in the United States, but it is very encouraging. We're still kind of waiting for a prospective trial looking at whole blood versus components. We have implemented it here at our institution. So there are a few units of whole blood that are available only for traumatically injured patients, and these patients will receive it in the emergency room and nowhere else in the hospital. So we have implemented it again based primarily on retrospective studies for now, but it's probably the better resuscitated fluid. Yeah.
Thank you very much. We have a debate also coming up in the later half of the session, but I know the time zones are not allowing you to keep awake. We are very, very grateful that both of you have been, up at this time of your at your place. I also have another question for Dr. Avinash.
Yes.
Can we have, Dr. Avinash, just one quick question to be asked from you is, if the brain is in trouble in your intensive care and you have residents, what would be your bedside instructions to the resident in the absence of ICU monitoring?
So in our general practice, patients who come in who have a low GCS in the first 12 to 24 hours, they end up getting an ICP monitor very early. Most of the time, it's the intraparenchymal monitor, like I was mentioning. So that makes the decision making a little more easier. May not always improve outcomes, depending on the severity of the injury, depending on whether you're able to actually drain CSF or not. So having the ability to drain CSF is always a useful strategy where where the cerebral perfusion pressure strategy may not always work. So that is one thing. The second thing is there's usually senior person available to help out the residents. So we usually don't have like junior residents at the bedside, with critical cases. If things are going wrong, there's usually like an attending who will actually be available to help out. But to answer your question, I think like we tend to move towards putting an ICP monitor in early in our practice here.
Thank you very much, because this is one problem which we face. Say a patient is sedated, as we all know, we sedate them, and then the patient has got a big contusion. Patient comes to us, patient is without ICP monitor, and we do not have always attendings in the intensive care. So we just advocate them to monitor on neurovitals very heavily, and if there is any drop in GCS, even if one notch is getting down, so we ask the neurosurgical colleagues to come down and help us in the absence of the expert advice at late hours in the night. So I hope that agrees with you all also.
Absolutely, ma'am. I think this is a common scenario with the availability of like have a 24/7 coverage of neurosurgeons. Now, with the Society of Neurocritical Care, one of the sort of like training that they're offering is like for intensivists to be able to put the intracranial the bolts, which are like which are reasonably easy to do. There's less chance of like causing severe like damage. So they're actually like training intensivists to actually do this. So that is one thing. The second thing is like to help you with the decision making. Your residents can do if there's ultrasound available, you can actually do the optic nerve sheath diameter, which is actually, there's a lot of studies on that. It's quick. The time of onset for dilation of your optic nerve sheath is like is 5 minutes after the ICP spikes. So you can actually make a secondary argument saying that we have additional information to say this person has increased ICP, so we really need the ICP monitor. So if that's a decision making that like that needs to convince the neurosurgeon to come in to do the procedure, or whoever has to come and do that. So that's another piece of information that will be helpful. The other thing is lumbar drains. Like I know there are a lot of pluses and minuses about lumbar drains. Again, like depending on like the initial CT, depending on like mass effect. If you need to have a way of like draining CSF, that's an alternative if you can't put a ventriculostomy catheter, and so that's another option as well.
Thank you very much. I think this clinical tips will help our residents who are viewing your this virtual talk. And I must tell you that we have more than 300 people logged in from various devices. So despite your time zones, I'm very, very thankful for you for giving your talk on a live at this point of the time. Thank you very much. And we I think hope to see face to face each other next year when plan to host an international conference. We'll get you here, and all the residents can ask their heart desired questions, because the time is not allowing us to ask too many questions. Maybe in the chat box, or they can mail you if there are some questions, and I'll be very happy if you can answer them at your spare time.
Absolutely, we would love to. I'd really appreciate all of you all for being here, and thank you so much for the opportunity to meet all of you all, and to be able to share.
One last thing, Dr. Pinder is sitting here. I think we have made a case for having an ICP monitor. We are already pursuing one for the last 2 years. Somehow we are not able to convince our first neurosurgeons, and now the institute, and finally the government, because government wants make in India products, and we don't have make in India products for ICP as yet. So we are struggling to have them in our intensive care. So nevertheless, you have made a point for us. So I'll follow it up further. Thank you very much. Thank you very much, Dr. Radwan. Thank you so much for staying back with us.
Thank you. Thank you for having me.
Thank you.
Thank you, Dr. Avinash and Dr. Radwan. Now we conclude this session. Thank you.
Thank you so much. Thank you.
Thank you so much, everyone. Now we start with our third session, Trauma Way. What you do matters. In this session, we will have 2 lectures, traumatic cardiac arrest and early analgesia for acute injuries on arrival to emergency trial room. Now, I would like to introduce the chairpersons. First, I would like to introduce Dr. Sandhya Yadanapudi, Professor, Department of Pediatric Anesthesia, PGI Chandigarh. Her areas of interest are pediatric anesthesia, resuscitation, research and methodology, teaching and training. Next, I would like to introduce Dr. Sunil Gaba, Additional Professor, Department of Plastic Surgery. He has received various awards and has various publications. His area of specialty is plastic reconstructive and aesthetic surgery. Next, I would like to introduce Dr. Kapil Gupta, Professor, Department of Anesthesiology and Critical Care, Vardhaman Medical College and Safdarjung Hospital. His special area of interest is focus ultrasound guided blocks, transplant, trauma and obs anesthesia, and cadaveric organ transplant. Next, I would like to introduce our virtual chairperson, Dr. Vishal Uppal. He is Associate Professor, Department of Anesthesia, Pain Management and Perioperative Medicine, Dalhousie University, Canada. He is also Associate Editor of Regional Anesthesia in Pain Medicine. He has more than 50 peer-reviewed papers and book chapters. Now, I would like the chairperson to introduce the speakers. Thank you.
Good afternoon, everyone. It's my pleasure to introduce the first speaker of this session. Dr. Dinesh Bagaria is an Associate Professor of Surgery at the Trauma Surgery and Critical Care Division in the JPN Apex Trauma Center, AIIMS, New Delhi. So, Dr. Dinesh is going to speak on traumatic cardiac arrest, code red.
Thank you, respected chairpersons. Am I audible? Hello, am I audible?
Yes, you are audible.
Okay, I think screen is also visible to all the participants and faculty members.
We're not seeing the screen as yet. Yes, now the screen is visible.
Okay, thank you. So, greetings and good afternoon and good evening to all the respected faculty and participants. And at the outset, I would like to congratulate Kajal ma'am and Jitendra ma'am and all the team members of Trauma Anesthesia Group for organizing this academic extravaganza. And in the next 15-20 minutes, I would be sharing with you my understanding of traumatic cardiac arrest, code red, where we expect survival at all cost. So my discussion will be focused primarily to answer these three questions: what it is, and how we diagnose and how we treat it, and the last but not the least, is it really rewarding to treat it? Before proceeding further, I extend greetings to all the faculty and participants on behalf of my Division of Trauma Surgery and Critical Care at AIIMS, New Delhi. So, sudden cardiac arrest is the entity which I admit that I am the least knowledgeable in the august gathering of critical care physicians. And since the identification of this entity in the medical science, people are trying to find way to get best management out of it. And the very first attempt, which was fruitful, made by Peter Safar in 1960, who is also called the father of modern CPR. And in his landmark paper, he showed us the way that few manures, medications, and the support can help us getting good recovery among cardiac injury, among cardiac arrest patients. And since then, the chest compression medications, especially the adrenaline and the defibrillation, has been the integral part of any guidelines who are being provided for the management of cardiac arrest patients. If we dig down the etiology, most of the time it is some pathology, underlying pathology of the heart. It might be the channelopathy, it might be the ischemia or valvular disease, which ultimately causes the cardiac arrest. And the second most common cause is the lung diseases, which ultimately lead to the hypoxia. But these things are not present in the traumatic cardiac arrest. The traumatic cardiac arrest, most of the time these patients are young, healthy and hearty, and the primary etiology is not itself related to the heart. It is the secondary pathology which ultimately put the burden on the heart, and it causes the ultimately demise of the patient. The most common etiology we very well know is the hemorrhage in the 60% patients. Second is the tension pneumothorax, cardiac tamponade, and in very few patients it is the airway obstruction. And that's why the conventional methodology of CPR in the form of chest compression, use of drugs, and defibrillation doesn't work in the traumatic cardiac arrest. Why? Because the chest compression may not be effective at all in these patients because they are hypovolemic. So there is no circulation at all. Even after we get the beating heart, it is not going to help the patient. And if the bleeding source in the chest, it might worsen without chest compression. The studies shown that only using the conventional CPR techniques has not resulted into better chances of survival. And if someone is using these methodology, our helping hands, they are kind of diverted to do these maneuvers. So we will be having less people who can help us in correcting the cause which we can correct easily, and it will hinder the resuscitation and correction of the reversible causes. If we talk about the shockable rhythm, it is around 7% in the trauma patients. That's why all these maneuvers are not primarily being followed by managing the trauma cardiac arrest. And that's why our priorities are changed if we are managing the trauma cardiac arrest. So our priorities in these patients are first to correct the correctable causes, which are the hemorrhage control, maintain the oxygenation, bilateral at least finger thoracostomy in initial stage, so that if there is any massive hemothorax, we get relieved of it, we know about it. If there is tension physiology developing due to tension pneumothorax, we get rid of it. We start the massive transfusion protocol, measure hemorrhage protocol in our institute if have. Use of ultrasound, I think in the morning, Dr. Sudhir has very well threadbare this part. And last but not the least, the thoracostomy. And once we have corrected these causes, which are correctable, reversible causes, then we resort our effort to this, conventional CPR. So our priorities, as I said, that are changed. So first we have to do the hemorrhage control. The source of hemorrhage, we know that it is one on the floor and four more. So it is the external bleeding or in one of the cavity. If it is external bleeding, we use compression. If it is not getting controlled, use the tourniquet. It may be in the chest, so use the tube thoracostomy to get about it, know about it, and manage it. If it is the pelvis, use the pelvic binder initially. If we consider that there is maybe some issue with the airway management, so we have to oxygenate the patient properly, get control of airway early, start the major hemorrhage protocol, early use of tranexamic acid if the patient is coming early, and then the use of ultrasound. Ultrasound is also a good modality to get us idea about the cause and sometimes about fruitfulness of our effort. So I, being a surgeon, primarily will be kind of focusing my discussion on the thoracotomy part. The thoracotomy part in a trauma cardiac arrest patient, we said that it is the emergency department thoracotomy or resuscitative thoracotomy. So the notion is the emergency department, but it doesn't the physical location of the surgery itself which define it. It is the execution and the decision making which ultimately define the outcome. So whether it is being done in the emergency department or if your OR is nearby and you can roll in the patient within next 1 or 2 minutes, you can even shift the patient in the OR table and there you can perform the thoracotomy. So whether it is being in the ED or whether it is in the OT, it is not the physical location, but the decision and the execution which ultimately make the difference. So what is our objective is to release the cardiac tamponade if we suspect it. If there is stab injuries, most of the time we will find that there is cardiac injury, we can repair it. If the source of the bleeding is extracardiac, control it. During the process, if unfortunately our patient experience cardiac arrest, we do open cardiac massage. And in few patients where the bleeding is subdiaphragmatic, we do the aortic cross clamping so that whatever blood is there in the body, it primarily is being used to perfuse more vital organ, that is the heart and the brain, rather than the subdiaphragmatic space. There are two approaches we use for the ED thoracotomy. One is the clamshell thoracotomy, which is bilateral submammary incision in between two anterior axillary line across the sternum, and even the sternum we divide. And another approach is left anterolateral thoracotomy. Which approach is better? There is no clear-cut evidence about it. It is generally the institute and preference of your department or your protocol which you follow. Our preference is definitely the clamshell thoracotomy. We think that it is gives a better visualization and better control in our hand to do the procedures. So we give a bilateral submammary incision across the both axillary line across the sternum. We divide the sternum, and once we are in the chest, we have a total open up bilateral pleural cavity and mediastinum in front of it, just like a clamshell. Once we have done it, we can release the cardiac tamponade in penetrating patients if there is cardiac injury suspected. So we take control of that, and once we have done that, then if there is any other source of bleeding or the primary source is the extracardiac, we do control that. Other is the left anterolateral thoracotomy. This procedure primarily is being done for aortic cross clamping rather than taking control of cardiac and extracardiac bleeding. But again, as I said, that it is the institutional preference that you go primarily with the clamshell or with the left anterolateral thoracotomy. It depends upon your institutional preference. So there must be some indication and some prerequisite to proceed with the procedure. And in the indication, one term which we will come across frequently is the sign of life. And these sign of life, these are these signs which we present in our patient. We consider that our effort putting in the saving of this patient might be fruitful and we might get a good outcome. And these are the pupillary response, if there is any spontaneous ventilatory effort, carotid pulse palpable, any recordable BP, any spontaneous extremity movement. And last is the cardiac electric activity, pulseless electric activity. There is some kind of confusion, or I would say argument against and using it pulseless electrical activity as a sign of life. But till as of now, it is being used as a sign of life. And if the patient is having at least one of these sign of life, it clearly has a survival advantage over the patients who don't have it. So the very clear-cut indication of thoracotomy is the penetrating cardiac injury in the area of cardiac box. The cardiac box is area which is roofed by bilateral subclavicular line and longitudinally between the transmammary line and lower line horizontally between the G-sternum and the umbilicus. So in this area, if there is any penetrating injury with suspected cardiac injury and there is profound shock, patient is not responding to our efforts, and he is showing some sign of life, then this patient definitely deserve a emergency thoracotomy. Besides that, there are certain, I would say, prerequisite or certain points which we should consider before proceeding to the ED thoracotomy. And Western Trauma Association guideline is very good, giving us insight into that if the penetrating injury with there is no sign of life, but the CPR is less than 15 minutes and we can able to get some sign of life, or in the blunt injury, if the CPR time is less than 10 minutes and we are able to get some sign of life, we should proceed with the ED thoracotomy. Sometimes, if the patient is exsanguinating intra-abdominally, then in that patients also, as I said, for aortic cross clamping, as a preliminary procedure, ED thoracotomy can be used. EAST is the Eastern Association of Society for Trauma, and they clearly shows in their meta-analysis, and which ultimately presented as a practice management guideline, that if the patient is having sign of life after penetrating thoracic injuries, the chances of survival are 21%, which continuously dipping down to even less than 1% if the patient is having blunt extrathoracic injury. And that's why they specifically recommend against using ED thoracotomy in the patients who are pulseless without sign of life after blunt injuries. Ultrasound is good modality. Dr. Sudhir has already said that it can give us a idea about the reversible causes, and while putting our resuscitative effort, we can distinguish between the patients who are having actual electromechanical dissociation or the patients who are in PEA and there is a pseudo EMD only, so that we can have an idea whether there is a cardiac motion or not, and we should proceed with the resuscitation or not. The cardiac motion presence is having very good sensitivity and specificity to the tune of 90% for predicting survival to the hospital discharge. That's why the algorithm management for the trauma cardiac arrest patients nowadays are having integrated the eFast part also, that if your patient is fulfilling the criteria, indication and the prerequisite for ED thoracotomy, we can use the ultrasound and to assess the cause, to assess the cardiac motion, and we can decide whether we should proceed with the ED thoracotomy or not. And it can avoid us doing futile EDRT. Emergency thoracotomy is a very complex procedure, and most of the time it is unplanned. We don't know what time and how we will be able to do it, and that's why the occupational exposure is very high to the tune of 7.2%, and the procedure performer has high chances of getting injured by using sharps, by the fractured bones, ribs during the thoracostomy, and that's why there is clear debate that if ED thoracotomy should be used as a indiscriminate fire drill, or it is the only chance of survival of such patients, because it is being done in a complex milieu. The ED department is already very stressed, stressed space of the hospital, and doing such a stressful procedure there again put a very physical, mental and psychological toll on the residents as well as the staff. It is very resource demanding. Most of the time the outcome is not as expected. That's why the psychological part is also important. There is high risk of occupational exposure, and although no finances is better can be compared with the life, but definitely there are finances burdened by using this procedure. There are some special circumstances where the indication of discussion of using whether we should proceed with the traumatic cardiac arrest management or not. And one is the severe traumatic brain injury. So whether we should proceed with the resuscitation in the patients who are also having traumatic brain injury. And one studies recently published showed that if full effort is being put, even the patient who are having low GCS, they can yield good neurological outcome. And that's why good neurological outcome is expected in these patients. And that's why we should not refrain ourselves from putting our resuscitative effort in these patients who are even having severe traumatic brain injury. If there is suspected CARE syndrome, then besides using these maneuvers, we also need to take care of management of hyperkalemia. So we should use whatever measures we have to treat the hyperkalemia. All these, if we come together, then we make a trauma arrest guideline that if our patient is having traumatic cardiac arrest and the CPR time is less than 10 to 15 minutes, depend upon the mechanism, first we should rule out and treat the reversible causes. And once we have done that, we should proceed further with the conventional cardiac arrest management. As of now, it is now being considered that whatever effort we put in the ED department, we are almost, in developed countries, we have reached at a level where probably the more effort are not going to make much difference in the outcome. And that's why nowadays all effort are being used in the pre-hospital resuscitation. So whether the thoracotomy should be used in the pre-hospital also, London Royal Hospital pre-hospital department is pioneering in this field, and they have shown that in 15 years, out of 71 patients, they were able to survive 13 patients, and out of them, 11 were having good neurological outcome. And they recommended that if you have good protocol in place, it is prudent that we should use thoracotomy even in the pre-hospital. When to resuscitate, when to terminate the resuscitation, because resuscitation cannot be an ongoing process. There is no clear-cut, I would say, guideline or protocol, but whatsoever evidence we have, it suggests that if after starting our resuscitation, if 15 minutes of resuscitation process, including the CPR, we have done, and we are not able to get back at least sign of life or good pulse or BP in these patients, probably this patient is not going to survive, and we should terminate our respiratory effort. But again, as I said, that science is not clear, and what we should use, it is a matter of debate, and we should decide our own bespoke, protocol. Ribova, that is a resuscitation endovascular balloon occlusion of aorta. It is a very new modality and is extensively being studied, extensively being used nowadays in trauma management and various aspects, and it has found its role in management of trauma cardiac arrest also. So it is being used as an alternative of aortic clamping. So if our indication is only the aortic clamping due to subdiaphragmatic bleeding, if it is possible, if we have it, we can use it rather than doing thoracotomy and aortic cross clamping. In India, unfortunately, as of now, we don't have Ribova catheters available, and trauma center aims trying to get it in the India. And during this effort, recently we also had a live workshop of EVTM, that is endovascular treatment in trauma management, in collaboration with the Örebro University, Sweden. And we hope in the next few years, probably we will be able to have Ribova catheter available in our country also. Few novel advances which are recently came into the picture. One is the selective aortic arch perfusion, which has shown very good outcome in animal models. And recently a trial in the name of EPR-CAT, that is emergency preservation and resuscitation for cardiac arrest from trauma, is ongoing in the UK. Results are awaited. After that results are out, we probably will have idea whether this procedure is also going to help us or not. Our experience as far as the trauma cardiac arrest per se is concerned is very limited. But if we talk about the cardiac injury management, this is one article which published in 2019, and we presented 2-year outcome where there were 17 patients who had cardiac injury, and for them they underwent ED thoracotomy as well as thoracotomy in the OR, because our OR is very nearby to the ED, and we can roll in the patient in the next 5 to 10 minutes. That's why these patients, some were specifically underwent thoracotomy in the ED, 6 patients, and rest patient underwent thoracotomy in the OR. And out of them, 17 patients, 10 patients, we were able to save them. Specifically cardiac injury patients, this is another paper. In this 21 patients of cardiac injury, we analyzed our data, and in this patient also the mortality was 30%, and most of these patients again were having penetrating injuries and blunt injuries. So I would like to conclude my talk with these take-home message that trauma cardiac arrest and cardiac arrest, they are not same. We need to identify the difference between them. We need to realize, and based on the realization, we should guide, we should follow our strategy. The emergency department thoracotomy, ED thoracotomy, I would say, is sometimes one and only chances of survival of these patients. So whether it is the physician or the surgeon who is present in the emergency department, we should take lead and should not hesitate to perform these procedures. And last but not the least, that never lose hope. Definitely the outcome is not very rewarding of managing such patients, but if even after our effort, if we are able to save one life, the joy of getting the take care of all our efforts.
Area, the differences between how to manage dramatic cardiac arrest and what are the differences between dramatic cardiac arrest and cardiac arrest due to other medical reasons. So this is something we all must remember, and because the management is entirely different, and that leads to a difference in the outcome. So to start with, I'll just try to find out from you, because you're working in a trauma center. So how many patients who require ED thoracotomy come to you? Most of the times there is a lot of delay in transfer of patients in our hospitals. So what is your experience regarding that?
You rightly said, ma'am, because our pre-hospital transportation and hospital care is not up to the mark. So the patients who require ED thoracotomy, the number of them is quite high. At least 2 or 3 patients per month. We can, retrospectively we can identify that if this patient would have come within stipulated time, we could have done ED thoracotomy in this patient. But as far as the practical number is concerned, annually 5 or 6 patients are such patients where we do ED thoracotomy.
Okay, thank you. Any other question?
Actually, ma'am, more than incidents, I think there is failure to recognize also. In our center, there was a time when one of our patients arrived in trauma bay. Patient had suffered a high impact injury. Patient was brought to the hospital within 5 to 10 minutes. All our residents were working hard, but there was a failure to recognize. So first, I feel that they should be able to differentiate between the various causes of cardiac arrest, and that is why we had placed this talk, because we want our residents who are the first responders in our setup. In our country, mostly our residents are the ones who are the first responders, because patients are brought by lay persons to the hospital. So what do you say about that, Dr. Bagaria? And then we can have Dr. Vishal Uppal, who is with us all the way from Halifax. Is this good morning to you, or what time of the night is there? Is it there?
It's 4 o'clock in the morning, so it is morning. Yes, it is good one.
So nice to see you, and so sorry to keep you awake at this time. So, Dr. Dinesh, what would you say on that, on the awareness part of it?
Yeah, I totally agree, ma'am, with you, because whatever structured, practice or structured courses we have for management of cardiac arrest, most of these structured courses don't have any effort for considering the trauma patients. And most of the time we put our energy, we put our understanding on the management of myocardial ischemia or channelopathy, whatsoever the medical causes are there. Until unless we specifically suspect that this patient is having trauma, and we should first rule out the reversible causes. I can personally remember 2 or 3 instances where, because of tension pneumothorax, patient was in the arrest, we relieved that, and we did the CPR and patient get revived. So that's why one of the most common source, I would say, is the chest. I would recommend and I would request all the residents who are working in the ED department that don't afraid of putting your needle in the pericardium, don't afraid of putting your finger in the chest. If patient is in the trauma cardiac arrest, whatever effort you are putting, whatever effort you can put, you should put, rather than deferring yourself and doing the conventional CPR.
Any comment you would like to add, Dr. Vishal?
No, it was an excellent talk. It was very enlightening for me, I must say. Yeah, thank you so much.
And Dr. Bagaria, what is holding AIMS back from getting Riboa? Okay, we are also finding ways to have that catheter. Is it a single time use and the cost which is, preventing it from having us in the ED rooms? Is there any substitute? Is there anything like Corda balloon also, which we can use as a, poor man's show here? Is there something else?
So what is first, as you said, what is refraining? The refraining is that I personally discussed with the Japanese company which is making balloon Tokoi, and the Prime American company, and both did their marketing here, and they ultimately found that probably 2 or 3 institute, AIMS or PGI and SGPGI and Sri Chitra, they named 4 or 5 institutes who are probably will be able to use it and will use it. So ultimately, whatever effort they will put getting this catheter here, they probably are not going to financially worthy for them. As far as the other substitute is concerned, we try to use aortic balloon, which is being used for aortic stent deployment. But the problem with that balloon is that the sheath diameter is quite large. What is the conventional diameter for the sheath while putting Riboa is 7 French, and now even for the 4 French sheath catheter also Riboa is available. But for putting that catheter, you need 12 French, and that probably will have high chances of injury to the femoral artery in such patients, and that's why that is probably something which is holding us. Few companies or few startup recently I came across, they are trying to do something, if it is possible to substitute it. Let's see how it goes next 1 or 2 years.
That's very nice of you. Thank you very much. And I'll pass it on back to chairpersons. And
If there are no other questions, we'll go to the next.
Dr. Vishal will introduce Dr. Venkat. Dr. Vishal?
Yeah, it's my pleasure to introduce Dr. G. Venkateshwaran. He's a senior consultant at Ganga Hospital, Coimbatore. He's also been instructor for comprehensive life trauma support for 12 years, a teacher for DNB anesthesia for past 13 years, and invited faculty to various conferences, including IORA, ISA, for past several years. His interest is in trauma resuscitation, preoperative management of polytrauma, and pediatric regional anesthesia. I've had a look at his talk and some amazing pictures. So I look forward to hearing what you have to say, Dr. Venkateshwaran. Thanks. I'll let you carry on.
Shall I start my screen sharing?
Not yet, sir.
Yeah. Am I audible and visible?
Yes, you are audible and your screen is visible.
Thank you very much, sir, for my introduction. And it's a great privilege to be here, and thanks for the opportunity given by the organizing committee of PGI Chandigarh for giving a talk in this CME. My topic is early analgesia for acute injuries on arrival to the emergency trauma room, the time for reappraisal. First of all, I have no conflict of interest, and my presentation has got a lot of photos, and we usually get consent from the patients for using their photos for academic as well as for the medical legal purposes, and that is the consent form as you get for the photos. First, I would like to, before going into my presentation, I would like to start with a small case scenario which happened in the year 2003. Here is a 35-year-old male who accidentally fell off the tractor while he was tilling the fields, and he suffered an impalement injury over the running blades. And as you see that, you can penetrating the anterior abdominal wall. This happened in a place about 60 kilometers from our hospital, and this patient was dismantled from the tiller, and he was brought in a vehicle. And throughout the journey of 60 kilometers, he was having a lot of pain and agony. And the problem with him is he could lie in this position, that is sitting and leaning forward, and any type of change in position caused him a lot of pain. And the part was weighing around 75 kgs. And as soon as he reached our casualty, our chief anesthesiologist, late Dr. Ravindra Bhatt, was informed, and he ran down to the casualty. He examined the patient, and he gave an on-arrival supraclavicular, and he could give a block by standing over a stool. And you can see, and after 5 minutes of the block, the patient had a complete pain relief, and this hardware was dismantled from the patient, and he was shifted to the operation theater for debridement because the wound was badly contaminated with muds. And after 1 or 2 procedures, this man regained the upper limb without any infections. And this happened in the year 2003, and it was also published. And coming to the introduction, the trauma represents the major global health burden, and it is the leading cause of death in all age groups. In acute trauma, pain is very severe, and it is often undertreated. Early analgesia for acute injuries on arrival to the emergency trauma room in the form of regional blocks, like what we call by the injuries like brachial plexus injuries and the peripheral nerve injuries. So as you say, this acute trauma, we can divide it into hemodynamically stable and hemodynamically unstable. So for those who are hemodynamically stable, we can give an early analgesia by peripheral nerve block, what we can call it as an on-arrival block. And for those who are hemodynamically unstable, the patient has to be shifted to the operation theater, and the general anesthesia has to be given, and the damage control surgery has to be done. In which kind of patients will you prefer on-arrival block? It is, you prefer in upper extremity injuries, hip and lower extremity injuries, and chest injuries. First, we'll come, whenever they come to the casualty, it is a dictum in our hospital, they will be shifted directly to the resuscitation room, which is the ante-room of the operation theater, where the anesthesiologist examines the patient and rule out brachial plexus injury and gives an on-arrival supraclavicular brachial plexus block. And the moment after the block, the patient will have a complete pain relief. So this complete pain relief gains the confidence of the hospital, gains the confidence of the patient over the hospital. That is how the concept of on-arrival block came to our hospital. You should never do this on-arrival block in a place where there are no facilities to resuscitate the patient. So why only regional anesthesia for these type of injuries? It is because the conventional pain management with opioids will cause drowsiness and respiratory depression. This drowsiness poses a problem in getting an informed consent during surgery, whether it will go in for an amputation or reconstruction becomes difficult. So there stands the on-arrival block where the patient is conscious and we are able to discuss with him regarding amputation or reconstruction during the surgery itself. How an on-arrival block is being done? So it's done after getting an informed consent. We do it with all aseptic and universal precautions, and the monitors has to be attached, and a supraclavicular brachial plexus block is given with ultrasound guidance. So this is given before opening the wound, which has got a lot of dressing soaked with blood. So this is how an ultrasound guided supraclavicular block is being given, and you can see it is done with an ultrasound guidance with an in-plane approach where we introduce the needle and the lateral aspect of the brachial plexus where we give about 5 to 10 ml of local anesthetics, and then we move the needle towards the just above the subclavian artery and give around 5 to 10 ml of local anesthetic. We usually give around 20 ml of 0.5% bupivacaine as a block. So what are the benefits of this on-arrival block? So moment after the block, we can apply a tourniquet, inflate it and stop the bleeding. As you say, in trauma, it's very important that we have to resuscitate. Resuscitation is stopping the bleeding. So this on-arrival block should always be a part of resuscitation. And you can see only after the block, the patients will be taken off for x-rays, and multiple x-rays with multiple views can be done without any pain. And this is the quality of the x-rays are also good after the block. For example, you can see this is the x-ray which is taken before block, where the hand was bundled with bandages. And the x-ray, in this x-ray, we can't see the thumb and the carpal bones are not very clear. Whereas this is an x-ray which is taken after the block, where you can see the bandages are removed, the hand was kept in the anatomical position, and an x-ray done which shows the thumb as well as the carpal bones. So in this way, this type of x-rays after a block gives a very good reconstructive option for the hand surgeon to operate. And the same anesthesia is used for the immediate surgical intervention. So for these type of injuries, as you see, this on-arrival block help to keep the arrival to the on-table time as short as possible and reducing the ischemia time. That is very important for these type of amputations for doing re-implantation. Not only for this, so this is a patient with a printing press injury where all his 5 fingers has got amputated. So we did a 5-finger re-implantation which took almost 17 hours. This was done with a on-arrival brachial plexus block. When the block got weaned off, we gave a repeat block, and this is how we are able to do for a long period of time. Not only for this, the advantages of this brachial plexus block in the microsurgery is the duration is not at all a problem. And more important thing is it produces what is called chemical sympathectomy, which prevents vasospasm. So whenever there is no vasospasm, my operating on a microscope on the small blood vessels, which almost looks like a size of the hair, becomes very easy when there is no vasospasm. And most of these patients under block, they are hemodynamically stable. The chances of hypothermia is less. And more important thing, it's very cost effective. not only for the fingers reimplantation, but also for the proximal level amputations, where we did, this is an accidental injury happened in a textile where his hand in upper limb got amputated. So we reimplanted this patient, and this is how the reimplantation was done at the arm level. So when you can see, moment after this reimplantation, there is something called as, and once you release the clamp, that is the vessel clamp, both arteries and veins, the patient may develop something called as reperfusion injury. The early symptoms of reperfusion injury will be extreme anxiety, profuse sweating, restlessness, and they can't lie on the table. Think of if you are given general anesthesia, all these early symptoms of reperfusion injury may be masked. Therefore, with regional anesthesia, we are able to identify all the symptoms of reperfusion injury, and you can see what happened to the patient next. So immediately after that, we can see the patient developed hyperkalemia, and these are all the tall T waves which has happened in the ECG monitor, and there is a tachycardia and then hypotension which has started developing. So moment all these things happen, what we did state is we just removed the reimplanted limb. So moment we removed the reimplanted limb, the tall T waves disappeared, and the blood pressure also improved, and the tachycardia also came down. And this patient was even going in for myoglobinuria. So that's the reason which may lead into acute renal failure. So we just stopped the reimplantation and saved the patient's life. This is how it goes on. And the greater advantage of continuous peripheral nerve blocks for these type of major arm level, the proximal level amputations is, if you give a continuous peripheral nerve blocks, according to the study, they are given a continuous infraclavicular brachial plexus block. This gives a very good vascularity due to vasodilatation following the block for the reimplanted limb. Not only that, it takes care of the severe acute postoperative pain in the early postoperative period, and it also which helps in prevention of the chronic pain associated with the transected nerves. That's how regional anesthesia helps. Not only for one limb, but also for both limbs. So this is a patient who's an engineer who had both upper limbs damaged, that is amputated within a railway track accident. And this patient, when he came to the hospital, so we were able to reimplant both the upper limbs by giving an on-arrival bilateral brachial plexus block. So that is also possible. It's important that as bilateral blocks are always possible. Most important thing is we have to discuss with the surgeon and plan accordingly which one they want to do first. So suppose if they want to do simultaneously, we can give a supraclavicular block on one side and a costoclavicular block or an axillary block on the other side. We can do it simultaneously. So with this on-arrival block, we did a retrospective study in 100 of patients. In 100 patients of on-arrival block over a period of 2 years, we found that after on-arrival block, the patient will have a conscious state with a 0 VAS score. So because of this 0 VAS score and without any hemodynamic compromise is possible with a non-arrival block. Not only that, the hemorrhagic control with a tourniquet and a quicker shift to the OT is possible in case of on-arrival block for this major limb injuries and amputations. Therefore, we can say that on-arrival block is safe and effective. Not only for upper limbs, but also for the bleeding lower extremities. Like this is a patient who has got a crush injury of the leg and he has got a lot of bleeding. And this patient, when he came here to the resuscitation room, we gave an on-arrival femoral nerve block. After a femoral nerve block, we applied a tourniquet, inflated the tourniquet, and thereby the bleeding has stopped. So this is very effective for lower limbs also. Not only that, so this is a patient who has got a fractured femur as well as the compound tibia, where we gave an on-arrival femoral nerve block, which take care of the pain of the fracture of the shaft of femur. And after that, we are able to give anesthesia by making him sit up and give a neuraxial block like a spinal anesthesia for doing the surgery itself. So not only that, it's also for elderly patients with fractured neck of femur, which is quite common. When they come to the hospital, they have a lot of pain. So these type of patients, what you can do is we can give an on-arrival PENG block. That's a pericapsular nerve group plexus block. Once you give, the patients will have a complete pain relief and they will have a very good preoperative period. We can take him for surgery on the next day itself. Not only for the limbs and also for the chest injuries. Like these are all the multiple rib fractures with the flail chest. we can go ahead and give what is called as an on-arrival erector spinae continuous plane block. So this is possible that we can do it in the aseptic precautions, and we can do this continuous erector spinae block in the lateral position, and with the help of an ultrasound guidance, we can do it. And so once you do it, we have to identify the T5 transverse process, and this is the epidural needle which is hitting the T5 transverse process. You inject about local anesthetic in this level, and you just enlarge the erector spinae space with the drug, and then following that, if you insert the catheter, epidural catheter in this erector spinae plane to about 5 to 8 centimeters, and give a good analgesia with a bupivacaine or a ropivacaine. This is very effective, and it gives a very good analgesia for these type of chest injuries, which make them to do the incentive spirometry very well. So when they do the incentive spirometry, and when they are able to bring out all the secretions which they have in the chest by doing this, and also by coughing and deep breathing exercises, when you take care of the analgesia, this gives a very good response to the chest injury without having any lung complications like pneumonia or the going on for the ventilator support. So as in chest injuries, we just prefer what you can call it as an erector spinae block or serratus plane block, because as a single shot erector spinae block or serratus plane block is quite safe in coagulopathy, and there is no complication associated with any of these blocks. And this erector spinae plane block is very good for the posterior fractures, and the serratus plane block is very good for the anterior fractures. Whereas we can also go for a thoracic epidural or a thoracic paravertebral, but it's always important that these two blocks, a thoracic epidural and paravertebral, are contraindicated in coagulopathy, and you can see there is various amount of complications associated with thoracic epidural in the form of hypotension, urinary retention, and weakness of the lower limb. Whereas with thoracic epidural, thoracic paravertebral, we have got chances of pneumothorax and epidural spread. So in this way, this erector plane block and serratus plane block is very effective in managing the chest injuries. So like you can see in our hospital, regional anesthesia is the biggest cost saver. You can see in the 2020 statistics, more than 70% of the work is being done under regional anesthesia, and we can see only 25% is being done under general anesthesia. Therefore, we can say that regional anesthesia in our hospital is the biggest cost saver for the patients. And there are certain limitations for regional anesthesia in acute trauma, like the patient who comes intoxicated or the patient who is uncooperative or with drug abuse. It's very difficult to give a regional anesthesia. So in such patients, we can go ahead and give a general anesthesia. Not only that, there is one more limitation. What they say is, if a patient has got a proximal tibia fracture, they got a high chance to develop what is called acute compartmental syndrome. This is because this is quite common with epidural anesthesia when you give, and the continuous epidural anesthesia. The early onset of acute compartment syndrome, that the symptoms like pain and paresthesia can be masked because of the epidural anesthesia. So this is such a paper which shows that epidural masks the pain and paresthesia. In such way, we can, in this case, that we should try to avoid this, because the chances of getting into compartment syndrome may be missed in the epidural anesthesia. Whereas another paper which shows that whenever you give a regional blocks like a femoral or sciatic nerve block for these type of surgeries for the postoperative pain, by using less concentration of local anesthetic without an adjuvant, even the pain and paresthesia will not be missed, and we are able to diagnose the early acute compartmental syndrome in such type of injuries with the regional blocks. And what about these type of proximal level injuries? It's always better to avoid brachial plexus block in this type of proximal level injuries, because whenever they have these injuries, there may be an avulsion of the root of the brachial plexus. And because of that avulsion, what happens is there's a formation of a myelomeningocele in the neck itself. So moment you give a brachial plexus block for these patients, so the drug enters into the myelomeningocele, which gets communicated with the subarachnoid space, and it causes what is called as a total spinal anesthesia, which can even lead to respiratory arrest and cardiac arrest. So therefore, in acute brachial plexus injury, please never don't give any brachial plexus block. And so in the pre-ultrasound era, giving a block was an art, where it is done by the senior anesthesiologist who knows about the landmark and the anatomy. He gives a block nicely. That is called giving a block in pre-ultrasound era is an art. Whereas with an advent of ultrasound and the nerve stimulator, now giving a block has become a science, because even the residents who keep on watching how we give a non-arrival block, they were able to do with the help of this ultrasound and nerve stimulator. Now giving a block is always a science. So with this in mind, we just published an article in the, there's an article on the on-arrival block, which was published in the Plastic and Reconstructive Surgery, Plastic and Reconstructive Surgery 2020 as a special issue, which showed that, and which has got a very good response in 2020 as a special issue in the Plastic and Reconstructive Surgery. So following our publication, even the government, that is the government Madras Medical College, has approached us, and they also want to do a pilot study of the on-arrival block for pain relief for the victims of upper limb and lower limb injuries who come to the casualty. So as an interest of scaling up the on-arrival block, this article has produced a lot of responses from the other hospitals, and now this National Health Mission of the State Health Society of Tamil Nadu, that which you can call it as a Tamil Nadu Accident and Emergency Care Initiative, and they have given a proposal to the Director of Medical Education to do on-arrival block for all the patients with upper and lower limb injury as a TAEI protocol for pain relief, to include on-arrival block to give early analgesia to the patients who are coming to the casualty with upper and lower limb injuries. So as it is a time for reappraisal of this on-arrival block for this early trauma. And finally, the take-home message is the primary survey should be done in acute trauma before you give a regional block. And regional anesthesia provides an excellent site-specific pain relief, and it is very cost-effective. On-arrival block provides an excellent analgesia and should be used along with the resuscitation to stop the bleeding. And regional blocks in chest injury provides an excellent pain relief, and it reduces the incidence of lung complications. Thank you very much for your patient listening.
Thank you very much, Dr. Venkateshwaran, for an amazing talk. I should have warned people about the graphic images, but I was scared they might run away if I warned them. But I was so pleased to see that you consent everyone before taking the images, or at least whenever possible. So that's a great practice. You've touched on everything. I think while we're waiting for a question, I might just ask you a quick question. I was just quite intrigued by doing multiple brachial plexus blocks for the patient who had long surgery. Would you consider putting like continuous catheters for this kind of situation? Especially like you can run them post-operatively for what you talked about, improving perfusion, microcirculation in the reimplanted limb. Would you consider doing that, or do you not?
Yeah, we also consider that. We also consider that we can also give a continuous infraclavicular brachial plexus block where the catheter placement is very good and it won't get dislodged. So these type of patients, when you give an either infraclavicular or for a continuous axillary block, where with an infusion pump or with you just set a connection with a ropivacaine or a bupivacaine with the narcotics, it gives a very excellent analgesia that not only helps them in giving a very good analgesia. Suppose if they take in for a re-exploration after 6 or 8 hours following the surgery, we can use the same catheter, give a bolus injection and take him for a surgery. So in this way, we can give a very good pain relief for 3 to 5 days following the surgery, where the improvement is it maintains a very good vascularity because of the vasodilatation where we use with the block, and also the continuous pain relief, and the patient becomes very comfortable. So we also following the continuous brachial plexus block.
And thanks for touching on the controversies about compartment syndrome and more like a fallacy rather than facts. I would just see if the in-person chairs are interested in any questions, or is there any questions from audience they want to talk about?
We'll just go for one quick question from the audience in the interest of time. Any question?
I would like to ask you one question, Dr. Venkateshwaran. So
Yes,
when you say that to control bleeding, you put the tourniquet on. So what is the time for which you allow the tourniquet to be there? Because, are the immediate steps taken to find out the cause for bleeding in those patients? Because is there any safe period for which you can leave the tourniquet on once you have given analgesia to the patient? Because the perfusion to the rest of the limb is also impeded now.
Suppose if you apply a tourniquet, it is an isolated limb injury, and we are going to operate on him, you can maintain the tourniquet time for almost about 2 hours, 2 to 2.5 hours for the upper limb, and 2.5 hours for the lower limb. And with that, we can use for the surgery. Suppose we want to stop the bleeding and we want to identify whether the patient has got any other injury, like in the leg or somewhere in the abdomen or in the chest. So we can apply a tourniquet, stop the bleeding for 15 to 20 minutes. So that thereby we can identify the bleeder which is there, which is causing a lot of bleeding. So we can get the help of the surgeon which is nearby in the theater, because it's already done in the theater, where they can come and clamp the vessels as a temporary mechanism and identify the other injuries. But that time we'll be able to do either an X-ray, or we'll be able to do a CT scan. For a CT scan, we have even shifted the patient along with a tourniquet for doing a CT scan to find out other injuries. And when you see that there is no injuries there, then we can take him into the OT for surgery. So this way, tourniquet helps a lot in preventing the bleeding.
Yeah, I agree. It is just that we have a number of residents in the auditorium sitting. So the carry home message for them is that once the tourniquet is there, you don't leave it because the bleeding has stopped. You need to find out the cause of bleeding. So, and be careful that you do not allow it for more than 2 hours. Because if you do it in ED, then the management has to be done in next 2 hours, or you...
Yeah, yes.
Yeah.
Just one small comment. Dr. Vishal, across the 7 Cs, we know this program is very well functional. Arrival blocks. Do you have any recommendations for us here to implement it as an ERAS protocol, which is, I'm sure, that is being done over there?
So in general, ERAS for trauma is usually not something we have implemented because of unpredictability of the trauma, which but what we have implemented is the home regional program, wherein we insert catheters and people go home with their elastomeric pumps and they just take it out. Because a lot of these patients are staying in the hospital just for pain control. In the case of trauma, usually the surgeons want to monitor them more closely for perfusion, so they have to stay in for a few days. But for more type of elective situation, they can go home with the catheters. I think that's what we have been doing. I'd be interested if the in-person chairs have any insight into ERAS about it.
Like our iconic picture for Thomas, I asked him to visit.
Yeah, it was an excellent presentation, and I think excellent idea of arrival blocks. We are already doing a study on this, and my only concern is, because if we are talking about the continuous block, we are blocking the motor as well as sensory both. So how will you manage that limb in that 3 to 5 periods, long periods? Because if we talk about replantation, yes, we splinted it. But if we are doing some small surgery, so it is difficult to explain the patient not moving the limb because he won't have any feeling, and that how can we address that part?
Generally speaking, if the patient feels that that block is going to help with success of reimplantation, they would take that extra side effect of motor weakness. And also, sometimes excessive movements can actually cause damage to some of these anastomosis. So explanation of this, to my mind, in my practice, I've never had any problems with patients not accepting a catheter. Dr. Venkatesh, have you had any?
We don't have any problem of using a catheter. So all these patients will be, all the reimplanted limb will not be left open. It will be put a POP. So POP will be put, and it will be very stiff enough. They can't be able to move. So that is one way that we can prevent all these things. So immediately after surgery, they will put a POP which avoids the movement of the reimplanted limb. And give a good pain relief, and then the reimplantation success rate is very good. You have to immobilize it with a POP.
Yeah, we have to immobilize it. But as Dr. Vishal was saying, they send the patient home with the catheter. Then it is really difficult to manage. Yeah.
No, we don't send the patient, because these patients with reimplantation will be there in the hospital for about minimum about 10 days to 2 weeks, because they might need a repeat surgery in the form of a skin grafting for a small raw area which is present following the reimplant. So for this, that's why it took almost 10 days to 2 weeks in the hospital. So you're going to remove the catheter after 5 days, and after that, the chances of pain is very, very less. And for them to go into a chronic pain is also less.
Yeah, I totally agree. My reference to sending them home was more for elective surgery rather than for reimplantation surgery, because they have to be monitored in the hospital for resurgery. And usually we can't send them home with the catheters.
Yeah.
And by the time they get to the stage where they're ready to go home, pain and reperfusion is not really an issue, so the catheters can come out.
Thank you. Thank you very much.
Can I ask a question? Dr. Venkateshwaran, my just one concern was like when you're giving a block immediately on arrival, like I assume it's just immediately when the patient has come before he has been examined, so that there is analgesia. Is there any problem you face with regards to the surgeons examining the hand and like they're not able to appreciate the sensory deficits which are present because you've already given a block? Is there any concern from the part of the surgeons?
Yeah. So in our hospital as such, the surgeons, they are so cooperative that moment the patient comes, we are the first person to see the patient. So we just do a primary survey and we will get the help of the surgeon to identify is there any peripheral nerve injuries or brachial plexus injuries. They can identify it quite easily because we have a lot of orthopedic surgeons and the plastic surgeons who do a lot of brachial plexus surgeries. So they were able to identify the acute brachial plexus injuries and the peripheral nerve injuries which are there in that trauma, in that open injury. And after that, we just get a consent from the patient attender and then we give a honorable brachial plexus block. So we don't do it immediately once it arrives. We do a primary survey and we get the help of a surgeon to identify if there is any nerve injury, so that for documentation purpose, it plays an important role. Suppose we don't miss a peripheral nerve injury for not for replant, but for other injuries like a compound femur or a compound upper limb injury, where there may be a chances of peripheral nerve injury, that also we can identify with the help of the surgeon, and then we can go ahead with the block. So that matters only if it takes an extra 1 or 2 minutes for them to examine and then tell there is no nerve injury or no brachial plexus injury, we can go ahead and give a brachial plexus block. So surgeon is always there nearby because it's always done in the ante room of the operation theatre. That's a resuscitation room that makes everything very well done in our hospital. Thank you.
Yeah, so that is what. So primary one examination is done before the block is given.
Yes.
To identify any sensory deficits.
Yes.
Thank you. Thank you.
All right, we'll close this session here. We move on to the next session. Thank you so much.
Thank you, everyone. Now we'll start our fourth session, which is the keynote lectures. I would like to introduce the chairpersons. Professor Kajal Jain, Professor, Department of Anaesthesia and Intensive Care, PGI Chandigarh, Course Coordinator, DM Trauma and Acute Care, and Secretary, Association of Obstetric Anesthesiologists, India. With multiple international and national publications, areas of interest, trauma and obstetric anesthesia and cadaveric organ transplant. Dr. Narayana Sir, Professor, Department of Anesthesia, PGI Chandigarh, Course Coordinator for DM Critical Care, PGI Chandigarh, with many international and national publications, areas of interest, critical care. Dr. Naveen Malhotra, Senior Professor and Head, Department of Cardiac Anesthesia and Pain Management Center, PGI Rohtak, and also Secretary of Indian Society of Anesthesiologists, with multiple national and international publications in international journals, and he is our virtual chair. Dr. Pradeep Bhatia, Professor and Head, Department of Anesthesiology and Critical Care, AIIMS Jodhpur, Editor-in-Chief of Journal of Anesthesiology, Clinical Pharmacology. He is also the virtual chair. Thank you.
Yeah. Good afternoon, everybody. Good afternoon. We will start this keynote session with Dr. Rajesh Mishra, who is a consultant internist in Ahmedabad and who is a
He is the President-elect of Indian Society of Critical Care Medicine. He will be talking about triaging of patients who need intensive care. This would be a recorded talk first.
Dr. Mishra, you are not audible. Dr. Bhatia, you are able to listen to him?
No, but I guess this is a recorded talk. I am unable to listen to anything. But, is it a recorded talk?
We are troubleshooting it. Just give us a minute.
Okay, Dr. Kajal.
I guess,
Is it audible?
no, not yet.
Please give me a second.
Meanwhile, I'll just tell the audience there is no formal lunch break because of COVID times. You can just go in between, but don't go together. I'll request like take turns and then come back and be with us. Lunch will be in the foyer. Cautionary warning, don't eat a lot. It's okay.
Namaste, dear friends. I have been asked to talk about one of the very
It's okay now. Yeah.
for triaging of patients who need intensive care. This is in context of a trauma patient, but we all should appreciate and recognize that in recent time, the importance of triaging has increased tremendously. Particularly during COVID time, we have seen that there was scarcity of resources, doctors, healthcare worker, and hospital. And at that time, triaging has played very important role in salvaging those patients who can be saved and trying to give or utilize our health resources to appropriate people. This is also very important for all polytrauma patients as as during mass casualty, when ICUs are full, hospitals are full, and then you get surge of the patient, and you have limited numbers of beds. You decide that which patient has to be given treatment, which patient has not to be given treatment, which patient can wait, and who should not be treated. It all depends upon appropriate triaging. Triaging is a complex decision, and it's a teamwork which involves appropriate person, appropriate timing. So what it means, triaging? Triaging literally is a French word. It means to sort and choose. And it is, process is called right patient to right place, right time by right care. So you have to provide the right care at right time to the right patient at right place. It has got a very important relevance. Suppose you come across a polytrauma incident in a place where you are in a remote area, and if you do not have anything available rather than trying to save those patients who can be salvaged, you try to protect the airway, or try to intubate somebody, or try to take care of patients who are bleeding and going to die. Will waste a lot of important resources. And triaging is all about training appropriately that who should be taken care immediately, who should be left, and who can wait for care. Triaging is normally done at the site of accident. Second place where triaging is done is the emergency room, where you have surgery of the patient, and third place where triaging is done in ICU. Then, if they have limitation of some of the life supporting device like ventilator, like ECMO, or like RRT, in that case, you try to offer the life supporting device to that patient who is salvageable and who has got good quality of life, rather than, like say for example, if you have a 30-year-old young man who has pneumothorax, who is alert and conscious, and who can be treated quickly, rather than you have a 60-year-old diabetic hypertensive patient who has polytrauma, who has severe head injury, who is comatose. So if you are given a chance between these two, you will try to save that patient who is salvageable and where you can fix up the problem immediately. So triaging is all about this, providing urgent or immediate care to the right patient at right place, in right time, and the right type of care. Every sentence has its importance. As I said, triaging is a complex issue. Complex issue is you have to take decision. This is a very tough decision, that if you have a two patient, one patient is just exsanguinating and second patient is merely salvageable, you just leave exsanguinating patient to die because you cannot salvage, you are always going to arrest and die, and to pick other patient who is salvageable. You need a lot of training. You have to communicate the thing properly. The problem happens that most of the clinicians have very limited experience of triaging, and there is very few centers who train their doctor or physician for the triaging. So decision is a complex. How it has to be applied, it needs a lot of experience. Here, you need a wider experience. Like if you have been taking care of patient-centric approach in ICUs and you are sent to the field, you may not be able to take a decision. So this becomes very important that time and again, institution, organization, state, or even hospital should have a triaging program, a program for particularly the people who are dealing with emergency, that how to do triaging. Because it's a complex issue, not everybody can take this decision. What is the condition which requires triaging to allocate? Basically, triaging is allocating a resources to the right person in right time at right place. So first thing is declare state of emergency or something national significance, like suppose COVID was one condition. We may have even H1N1 like of endemic or pandemic or epidemics. You have disaster like in form of trauma at some place, you have like earthquake, you have flood condition, you have suddenly fire condition where a lot of people get suffocated and get injury. So here the place where we have to quickly try to fix up those problems which can be fixed in our available sources. Simultaneously, we have to also find out that which patient needs to go to the higher center, which patient can be treated at primary health center, which patient can be treated at district level. So everything has to be treated. That means you need not have only the decision making, but you need to have very powerful communication system to appropriate authorities for offering appropriate treatment. Second thing happened that your search the patient, you have too many patients and you have limited resources. There you need to apply. We have to identify our resources and appropriate. Like as I said that identification of our resources, particularly the ICU beds and ventilators are very important. I have to identify an infrastructure. Many times if you are flooded with the patient, you do not have enough manpower, you do not have enough bed, you do not have enough emergency room to do that. It can happen that your local authorities can make a request to you, or that due to this particularly surge or emergency or endemic or localized surge problem. Many times some genetics spreads out, like you have viral hemorrhagic fever. So any of those conditions arises. So in this condition, you may be asked to be ready and to be triage. This has the whole purpose of triaging is to offer our limited infrastructure and resource to a person who is most probably salvageable, rather than offering those to those patients who is non-salvageable or not. When it is a disaster, it is a little bit complicated. The triaging process in disaster condition like flood, like this COVID plus condition, like somewhere fire, that become a company. So here you have to sort out, you have to prioritize, and then you have to allocate the resource. Allocation of resource is something which is very important. And this allocation will decide by the most probability of survival, post-survival good quality of life, and appropriate consumption of resources. So whenever we are faced with a condition in a disaster situation, maybe it is on road, on accident site, on the site of fire, on the site of flood, or inside of any of these condition, we have to first label the patient, and this labeling is done based on the potential salvageable condition, available resources, and treatment we can offer. Priority one is emergent or immediate, where within 15 minutes we have to offer the treatment. And these are the condition who has life-threatening injury, but this is with minimum effort, a minimum intervention, they can be salvaged. Like somebody has injury, pneumothorax, just putting a needle and just relieve the tension pneumothorax, and this patient can be salvaged. Like somebody had injury not severe enough, but they are obstructing the other way. Rest of things are fine. Just turning them on one side can salvage save them, and you can offer. So somebody has abdominal blunt injury. They might be bleeding inside, but bleeding is stopped. It's rushing to the place where surgery, abdominal, particularly most of the time there is clinical liver injury. Just packing them and may salvage the patient. So identifying those patients who are having severe injury but still salvageable and offering treatment, they come under red flag, and we put a red flag, that means immediate attention has to be given to them. Second is the urgent condition, but these are the patients who can wait for some time. The transfer, shifting of treatment can be that. So, say for example, long bone fracture. The patient is awake, alert, conscious, lying down, breathing comfortably. So these are the patients who comes under LO, that within hour or two, they should be taken to the hospital, and if they are little unstable or due to pain or bleeding, they can be offered different treatment, but they are given a LO flag. Third, either they have minor injury but no breathing difficulty, no pneumonic stability, they are alert and conscious, they can move, So they can be treated locally with minor, with appropriate ABCD examination, and they do not, like somebody may have cut, they need some step, some suturing, somebody may have abrasion, they just, but need to observe. Fourth is a condition is called blue, is expectant treatment. They have either got such a severe injury that is non-salvageable, like somebody has got severe head injury, immediately becoming comatose, obstructing their airway, and do not have availability of good neuro center, do not have availability of CT scan immediately. You do not waste time in this patient because even if you put efforts, they are not going to be safe. Or somebody has like open abdominal injury, open chest injury. So if you do not have availability of resource, immediately do not give your time. But if the resources are available and you have time, you may give support, but these are the patients who after support also, who after treatment also, like Jesus less than 3, open chest injury, open abdominal injury, may not survive, vascular injury may not survive. So they come under blue category, and at fifth category is dead, that is black level. They are the patients who are not breathing, not moving. So don't waste time with them, just put a black flag. So at accident side, these flags are put to the patient. This assessment takes less than 15 seconds to do that. And based on few parameters, that is movement, breathing, and pulse, just pulse, you decide that what category of patient this patient is, and accordingly put flag. The first priority is given to the red flag, second to the yellow flag. Because these are the patients where minimum or available resources management help them in managing and treating them and salvaging them. So this, as I said, that once this patient comes to the ER or ICU, their scoring is done along with SOFA scoring, or they have to see that how many other organs are damaged. And as I said, that blue category patient has a more severe injury, red patient has lesser severe injury, and yellow has like one organ dysfunction. Green patient do not need ICU care. So basically, it's yellow and red category patient who are given preference in ICU and who has definitive good outcome. Blue category, they are severely injured most of the time. Even if ICU treatment are given, this patient has severe injury, and most of the time, like near cardiac arrest, severe head injury, These are the patients whose treatment is most, our patient is having underlying some disease, whose treatment is mostly futile. So they should be like expectant treatment. If resources are available, they can be offered, otherwise they can be left. So what do you do when you walk in? Look what patient, if patient is moving or walking, yes, put a green tag, no immediate treatment. Not moving, is patient breathing? Yes, look for the pulse. If there is a pulse, it means at least for practical purposes, if distal pulses are radial and tibial pulses are distal pulses are there, at least patient has 90 blood pressure. Here, you can put if patient is not pulse not palpable, then put a red flag. Immediately shift to the ICU. Try to find out the cause of shock. Mostly it is bleeding. Even during shifting, this patient should not be given fluid. Just scoop and run in one piece. So should not have further damage during shifting. And once you reach to the destined position, assess properly airway, breathing, circulation, deformity with fast ultrasound, and then you go for definitive treatment. Do not try to increase blood pressure because low blood pressure is kind of hemostatic for this patient, and even 70 or 80 blood pressure you can tolerate if patient is alert enough, is breathing and alert enough. If patient is not breathing, then if accident side cervical spine, there is always a possibility. That's why you give jaw thrust. Don't move the neck. Just give jaw thrust. Try to give open airway. If it helps in breathing, then this patient, if is not breathing, that means patient is dead. If that helps in breathing, they again come in the category of blue or red zone depending upon the severity, and then you have to decide that they should be offered. If patient is pulse is palpable, breathing well but not moving, then they come in yellow zone, and there you can wait for some time. So basically, if I have to decide based on clinical sign that this which patient has to go to the ICU, the first priority goes to red, second priority goes to yellow zone. All those patients who need different kind of life support, immediate surgical intervention, they have to go. But in that also the priority is given towards the red tag, not to blue, and definitely not to the black tag patient. Based on just breathing, you have to further, if you decide, just position the airway. If no if patient is respiration, he go under the red category. He again should be followed immediate intervention. If patient is breathing, if rate is less than 40 and good pulse, then this patient comes under yellow and monitor. If patient is breathing but tachypneic, then this patient has something, particularly most of the time, this patient has either pneumonia, hemothorax, or that is the most important cause. There can be other, and they again come. So all those patients who are in red category, they are the first patient to go to the ICU, and secondly, the yellow category patient, they need to go to the ICU. And second priority, green, black, do not, green or black category patient, do not, green or blue or black category patient, black definitely not, but green or blue do not get priority in ICU. So, as I said, why we need to do the triaging is whenever demand exceed over available resources. So that time we have to offer our treatment to the best, the most salvageable patient in our limited resources. If we do not do that, it may happen that patient who comes early, they can be admitted, and then really the patient who really needs ICU care and whose outcome can be changed, they will not. Like say for example, somebody who is at home due to fume or due to smoke comes to ICU breathless, who are bedridden, who has all neurological problem. He is admitted in ICU, and after 2 hours, an hour, somebody comes with pneumothorax with 30 year and with all probable survival chance. And there is one bed. If that bed is given to that person, so that person will not get bed. And in that scenario, the patient who is most probably salvageable and going to have good quality of another 30 or 40 years may not get and may die, while other person who is bed bound, not a productive, not an appropriate person, and not a person to be offer life support because it does not have any productive quality of life. That person there will not do justice. So this is very important. This concept we have to understand. So application based on the magnitude of the search, magnitude of the problem. If it is minor problem, our conventional conserved resources are enough by doing. If the like accident at one side where we have 10-15 patients coming at one hospital, you have moderate, then you need to have a contingency plan where you have to reuse or conserve your resources, like you have some endemic or a mass casualty like plane accident or plane accident site, something like that, or you have some accident like mass drowning of boat, something like that, where you may suddenly get 50 odd patient at one emergency. In that case, you have to go to your contingency plan, you have to sort out, you have to prioritize. But in a condition like which happened in COVID, where it's not only the contingency plan which is a crisis situation, where you have to conserve your resources, you have to apply appropriately, prioritize your resources, you have to allocate your resources, and you have to reuse your resources. So response strategy in a major crisis is conserve, substitute, adapt to the condition, reuse, like you have seen that we have used PP, we have used mass, reuse, we have used circuit, so many things are used when there is a scarcity during COVID-19. This can happen during the hospital. Triaging in field within 15 seconds based on just breathing, movement, and pulse of the patient. Then it comes to the ER, you have more competent doctor, you have more competent healthcare worker. Here again, you try to prioritize who should get ICU bed. And that is done based on the type of injury, physiological disorder patient has, and probable outcome. There are different trauma score, different scoring there. But most important here, again, all those patients who were in red zone and yellow zone in emergency, particularly red zone patients, suppose somebody has severe head injury, but his score is somewhere between GCS between 6 to 9, he's impending, coning is there. We know that if neurosurgical intervention is available, just by doing that, they can be solved. But somebody has this kind of severe injury, another has got severe hemopneumothorax with plied chest, just putting ICD and putting it on ventilator. There's more chance that the patient who has got plied chest will survive better way than those patients who has got severe head injury of GCS 6 and less. So whenever it comes like you have 2 bed, so 1 bed home to be given, you give to the person who is most likely to survive. Same way in ICU also offer definitive treatment to all the patients who has, because trauma patient most of the time they are young, little bit of interventional intervention help them in salvaging them more. But do not offer to those patients where injury is irreversible, damage is irreversible, and it is worsening, and particularly those patients who have got low physiological reserve or who has got too many comorbidities, who are sitting at home, who has got underlying chronic neurological problem, who has got other comorbidities. So these are the patients who comes lower down in trial. As I said that in some part of the world where there are repeated disaster has become nowadays a routine for every country, and concept of triage officer, triage skill officer, and triage skill is coming up, where you have a healthcare person who has got extensive experience, knowledge, and training about triaging, about available resources and how to allocate that resources. That person, a strong leadership training that person should undergo, need to have extensive experience, and really need to have very effective communication skill between hospital, patient, and different available hospitals. It may happen that one person at field side may have to communicate with ambulance, district hospital, central hospital, tertiary care center, may need to communicate with the helicopter team, airlift. So many things are required depending upon availability of resources and what can be offered. That means, and the decision is not a fixed decision, changes very fast. All those criteria we should have, and this is one specialty which we really seriously need to work on to develop that. So, triage scenario in hospital, identify the most injured, offer definitive treatment, while in pre-hospital setting, you need to really assess, prioritize, and scoop and run. So, if you just see the scenario here, this patient looks stable, but this looks a red flag, while this person has been given a black color because this looks non-salvable. This is very important to understand in trauma scenarios. And generally, in field triaging, it's done based on the physiological compromise, like somebody has got GCS less than 12, but above 9, above 8, become. Somebody has got breathing difficulty, but awake and conscious. Somebody has got somebody has got hypertension, but palpable pulse. So these are the patient who was given priority, oxygen, tachycardia, but still pulse is perfect. Anatomical criteria, like somebody has got with severe penetrating injury, there is less chance of survivor to the vital organ. If penetrating injury is not to the vital organ, they have more mechanism of injury. If there is a blunt trauma, patient is alert conscious, there is a more chance that definitive treatment can be offered. While penetrating injury will give at vital organ may do damage more, and it may be possible due to penetrating injury, patient may die immediately. Mechanism of injury is also very important, like somebody head-on collision. If somebody has died in the same car, there is a more chance that patient has got severe injury. Ejection from the car, the patient will have severe injury. Then special population like pregnant, pediatric, neonate, very elderly. This patient has got even mild trauma the impact will be high, and we have to be careful about it. So when it comes to the hospital's triage system, there is a scoring called triage C, a triage sort, and another is simple triage and rapid transport. Third is the sort, assess life-saving intervention and treatment transport system. What you do In triage shape, it's a two-step triage model. And here, you just based on the, as I said, walking, breathing, and respiration and capillary refill time, you give a flag of red, yellow, black, and green. Particularly, the red flag should be immediate attention, and then second come the yellow should be given second priority. Dead patient does not need to waste your time. Green patient can wait for some time. Same way, based on other triage scoring system, that triage sort that is done based on respiratory rate, systolic blood pressure, and GCS. Now, if the score is less than 10, you give a less priority 1. If the score is 11, priority 2, and if the score is 12 and above, then priority 3. That means all these scoring are based on one principle, that patient has got severe injury but salvageable. The compromise, physiological or anatomical compromise is severe, but that's not severe enough that patient is dead or non-salvageable. Same way, simple triage and rapid transport. Here again, based on if patient is able to walk or spontaneous breathing, about respiratory rate and perfusion and mental status. Give them a red, green, yellow, and black marking, and complete assessment less than 60 seconds and prioritize where this patient should go. Another scoring system is sort out, assess, life-saving intervention and treatment transports called SALT. And again, based on the walking, purposeful movement, and still there is no life left. Just based on the walking or purposeful movement, we decide that patient is breathing. If no, then dead. Yes. If it moves the command, and there is a minor injury, then either he goes in yellow or green zone. If there is the patient does not follow the command, there is no peripheral pulse, he is in red. But since he is breathing, he needs immediate attention. And if patient is breathing but doesn't follow the command, doesn't follow the pulse, and there is no spontaneous breathing efforts, the difference between red and black is very, very minimal. And we have to be very, very careful that when we are assessing very sick patient, very severe injury, we have to be very, very careful that sometimes we should not be transporting. Particularly, the near cardiac arrest and impending cardiac arrest in failed trauma has got very poor prognosis, and most of the patients will not survive even if they reach to ER. And that is well-known fact. And based on that, we have to be very, very careful when we are doing triaging, not to triage the patient who has cardiac arrest or near impending cardiac arrest, or who are in the condition of no breathing, no movement, no pulse. Here the patient, this should not be given any priority for shifting. So, who are the patients who has to be admitted in ICU? Patient who has mechanical ventilator support, patient has got refractory hypoxia, but even with giving oxygen, patient oxygen do not improve, even by doing intervention, oxygen do not improve, and they need further life support. If there is a respiratory astosis, that means they are getting CO2 because of the hypoventilation. This can be because of airway obstruction or because of the pneumothorax, or maybe massive airway obstruction. Impending respiratory failure, patient may be having breathing effort but not able to breathe due to upper airway obstruction, and maybe thoracic or lung injury. Patient whose GCS is less than 8, but between 8 to 6, they are the patient, like 6 to 9 who has got head injury. These are the patient who needs intervention immediately, and airway has to protection. Hypotension, but no shock. And second is clinical evidence of shock in form of altered sensorium. Like somebody may be having clinic injury, they're bleeding, their blood pressure drops, and they start becoming drowsy. This drowsiness is not because of the head injury, because of the hypoperfusion. So these are the things which you have to always keep in mind, because quick intervention in these patients may help in salvaging the patient. Who are the patients who should be excluded, like trauma, severe trauma, which is non-salvageable, like I said, that's severe open head injury, open chest injury, penetrating injury to the major vessel, to the heart, something like that. Severe burn with inhalation injury, where you have 80% or 60% above burn with lung injury and patients start developing hypoxia. These are the patients who will consume your resource. Cardiac arrest due to trauma, there is very bad prognosis, and most of the patients, all of the patients will not survive. No need to waste your time. Severe, somebody has got baseline cognitive impairment, neurological problem, pre-existing neurological disease, advanced neuromuscular diseases, malignant patient has got malignant metastatic diseases, somebody who like advanced HIV or advanced patient of the immunosuppressed condition, which is irreversible, end-stage organ failure with like CKD or CLD with severe trauma, and then we should not be doing any elective palliative surgery in case of them who needs elective palliative surgery. Because at the time of crisis, you have seen in COVID, and when COVID hit, even OT and post-op care was converted to the ICU. All the elective procedure has to be provided from the hospital. SOFA is very important scoring system. Anybody who comes to the ICU, whenever you give life support, patient is in red zone or in blue zone or yellow zone. How the SOFA progress with the supportive care, and that helps within admission within 42 hours, after 5 days or 7 days. This progression of SOFA helps in assessing and predicting the outcome of the patient, and most of the time baseline SOFA score and then how it progress helps in outcome. Most times it has been seen that patients who are in blue zone, their outcome remains poor, and one can take a decision based on the hour of assessment and their SOFA score. But as I said, that all the patients who are in red zone, like if SOFA score is less than 7 in initial assessment, less than 11 in 48 hours, less than 11 after 12 hours, 120 hours, they should be given a higher priority. While if SOFA is higher during initial assessment, after 48 hours and after 120 hours, they should be either avoided or just given palliative care, no definitive ICU care should be given to this. All those yellow, green patients do not need any assessment ICU care. Yellow patient can go into intermediate unit or maybe high dependency unit. So, what are the ethics of triage and how to govern triage? You know, triaging is not something, a decision one person has to take. It's a teamwork. It's a question of life and death. You are not going to offer treatment to somebody who is not going to get better based on your clinical judgment. And there can always be question, how do you decide? So it's a continuous process. It's a continuous interaction. It's a dynamic process. And ethics plays a very important role. And there's always a chance that due to some known person, due to position, due to social factor, due to influential factor, due to political region, ethics can be, it's not possible to be totally ethical. Still, we need to have some ethics, and that should guide our treatment, and this should be purely based on our judgment, protocol, and priority. Many a time, although we know that it's not possible to take appropriate decision, but to our conscience, we should be trying to keep and do the triaging of best care or right care to the right person who is probably salvageable, than rather than giving right care to wrong person. You need an infrastructure and process for effective triage governance, and for that, as I said, that you need to allocate the resources, you need to have a backup plan, you need to have a national disaster tribunal, you need to have people who, as a reserve, who can work in time of disaster. you need to have a fund, you need to have a policy, and you need to have an effective central command control, because this is not something which everybody can manage and maintain. So certain budget has to be allocated for that, and for that you need to have a very regular training, because you do not do training, even the best trained person can forget that. So all this process should come as a state responsibility. A certain budget, certain people, certain resources should be always allocated for that, and that process should be on. And you definitely need huge psychological support for having effective triaging program and process. Triaging, as I said, that is a matter of research and analysis. It's a matter of supply and demand. It's a matter of outcome monitoring, check and balance. And based on that, there should be a central command committee which keep all the available resources on the table and appropriately allocating the resources as per needs. And this can only be done when there is an effective committee and communication happening. So at the time of disaster, at the time of mass emergency, at the time of pandemic, when you have a well set program in place, when you can tide over this situation. Again, I'm thankful for the opportunity, and I'm always grateful to the God for all that I have. So always a gratitude and always thankful. Thank you for it.
Thank you, Dr. Mishra, for that excellent talk about the triaging of patients. As is customary after keynote addresses, we will have no discussion or questions. We would just like to thank you about this. I would like to just make one comment on this. The triaging, the need for triaging is a tragedy. But when we have to do it, we have to do it. But the thing that we need to remember is that when we do a triage, when we have an opportunity to or need to do a triage, we need to aim at improving our systems later on. That means after every period of triaging, we must have an audit. Did our triaging episode have an under triage rate of less than 5%? Did our over triaging rate was our over triaging rate less than 25%, or things like that? Unless we do that, we will continue to be stagnant. I'll just hand over the mic to my co-chair, Dr.
Do you have any point to add?
Dr. Chan, you are not audible. Please speak loudly.
Yeah. Naveen, can we get a closing comment from you?
Thank you, Dr. Rajesh Mishra, sir, for an excellent and elaborative talk on triaging in trauma emergency vis-a-vis admissions to intensive care. It was pleasure listening to you, and I'm very sure that all the delegates have been benefited from your talk. Thank you for sparing your valuable time for us today. Thank you very much.
Thank you, sir. Thanks a lot.
Thank you very much, sir, for joining us online. And you have addressed a very important topic.
My pleasure.
And coming from a senior faculty like you, all our residents will be benefited, because as Narayana sir has correctly pointed out, it's a tragedy to triage, because we want all patients to get equal care. But as sir always says, ICU beds are premium. So that's it. Thank you very much, sir, for guiding us. Thank you very much.
You. Pleasure is mine. Thanks a lot.
We close the session and I hand over to Dr. Abhilasha.
Thank you, everyone. Now we'll start our next session, the fifth session, specialized trauma care. I would like to introduce the chairpersons. Dr. Harkan Singh, Professor, Department of Cardiovascular and Thoracic Surgery, PGIMER, Chandigarh. Areas of interest: beating heart surgery, minimally invasive cardiac surgery, and redo valve surgery. Dr. Samir Sethi, Additional Professor, Department of Anesthesia and Intensive Care, PGI Chandigarh. Areas of interest, transplant anesthesia. Dr. Vishal Kumar, Associate Professor, Department of Orthopedics, PGI Chandigarh. Areas of interest, regional anesthesia and pain medicine, trauma anesthesia and acute care, with multiple publications and scientific presentations in national and international journals. Yeah, we welcome you, sir. Dr. Jayashree Muralidharan, Professor and Chief, Emergency and Intensive Care Units, Advanced Pediatric Center, PGI Chandigarh, Chairperson, APC COVID Management Committee, and past Asian representative of World Federation of Pediatric and Intensive Care Critical Societies. Areas of interest, decay and antimicrobial resistant. She's our virtual chair. Welcome, ma'am. Dr. Parshottam Lal Gautam, Professor and Head, Department of Critical Care Medicine, DMC Ludhiana, Fellowship in Liver Transplant Anesthesia, also a member of Editorial Board, Indian Journal of TEE, authored in 3 books and 7 chapters. He's also a virtual chair. We welcome you, sir. I would like the chairpersons to introduce the speakers. Thank you, sir.
Good afternoon. I invite Dr. Choube Sani, who's professor of in JP and Trauma Center of AIIMS, New Delhi. She'll be talking about triaging of geriatric trauma, a problem worth discussing. Over to Dr. Choube.
Good afternoon. I'll be talking about under-triaging of geriatric trauma, a problem worth discussing.
Dr. Choube, can you put it on a slideshow mode, please?
Okay. Am I audible?
Yes, ma'am. And if there is any other device logged in, can you please log off that?
Yeah, that's logged off.
Okay, thank you very much.
Am I audible?
Yes, ma'am.
Okay, fine. So, good afternoon. I'll be talking about under-triaging of geriatric trauma, a problem worth discussing. So, my topic has been made much simpler by the previous speaker because he's talked about triage. Now, triage we know, as he's already told, that means to sort out. And under-triage means proportion of severely injured patients who are not transported to appropriate trauma center, and that is basically in pre-hospital scenario. But now this holds true for hospital scenario also, where the patient is not considered or he doesn't appear as sick as he really is. So that's the in-hospital under-triage, or in other words, this is false negative triage. It is considered to be a quality indicator for the precision of triage. Now, less than 5% under triage is actually the acceptable limit by American College of Surgeons Committee on Trauma. Now, coming to the problem of geriatric trauma, we know the geriatric population is increasing. In 2020, it was around 6.7%, and it is expected to increase to around 20% in the next 20 years. And come closer home, if we talk about our data on geriatric trauma, for the last 5 years, in 2015, there were around 4.75% of the geriatric trauma patients admitted in our center, which increased to around 7.7% in 2019. And now if you look at the discharge also, we can see that with appropriate triage, aggressive management, we were able to discharge most of the patients. Now, pre-hospital and in-hospital under-triage of geriatric trauma is well documented. So much so that in 2021, a systematic review was conducted looking at 23 studies, and it was found that under triage and geriatric trauma was more than 50% for the pre-hospital scenario. And now higher the under triage rate, higher is the mortality, more would be the complications, longer would be the hospital length of stay, and lesser would be the ability to return to independent living. So there's a lot of literature available on under triage of geriatric patients. So yes, it is a problem which is worth discussing. But why do we have under triage? What is the issue? So as Dr. Mishra told earlier, the triage is done on the basis of mechanism of injury. Now, if we look at the geriatric trauma, we find that even low energy trauma, like fall, can lead to severe injury in geriatric trauma patients. Falls are the most common cause of trauma in the geriatric patients, and age and frailty is considered to be a predictor of mortality. This is followed by motor vehicle collisions and then blunt trauma, which can be because of a pedestrian walking on a road hit by a motor vehicle, and pediatric trauma being the penetrating trauma being the least common cause. Now, the other causes of under triage and geriatric trauma include age-related anatomic and physiologic changes, which lead to altered response to injury, significant comorbidities, and the multiple treatment and the multiple medications or the polypharmacy that these patients are getting. Now, the triage or the protocol for management of the trauma patients remains the same for all age groups. It is the ATLS protocol that we follow, which is ABCDE. So coming over to the airway concerns. Now, these patients, they have decreased cardiopulmonary reserve, so they might require early intubation. Now, if we are planning for a nasal route for taking care of the airway, or we need to, for gastric decompression, we should be aware of the fragile nasopharyngeal mucosa, which can lead to hemorrhage and further complicate the management of these patients. We all know that geriatric patients have difficult airway, which includes difficult mask ventilation because of loss of buccal pad of fat or edentulous, and difficult intubation because of loose tooth or fixed spine. And moreover, in trauma patients, we have cervical spine collars in situ, which makes it more difficult. Now, respiratory system concerns. Now, we know that that is B, and we know that all trauma patients should receive supplemental oxygen. Now, the issue is in COPD patients who have a hypoxic drive. Now, this can lead to obtundation of the drive, but still these patients should receive oxygen, and it should be on the basis of the level of PCO2 or the condition of the patient that we should decide to intubate the patient. So we have to be careful. Again, compromised respiratory functions in the geriatric age group. We know that there is reduced functional residual capacity, reduced compliance, decreased coughing, and decreased mucociliary movement. So all this leads to increased work of breathing, and these patients are at risk for early respiratory failure. Now, the chest injuries, even simple chest injuries like your rib fractures, then simple hemothorax, pneumothorax, contusions are poorly tolerated in this age group. Next is C, or cardiovascular system concern. Now, a hemodynamic unstable patient is the easiest to triage because we know he's hemodynamically unstable, so he goes to the radial. But in geriatric patients, because of structural and functional cardiac changes like atherosclerosis, catecholamine insensitivity, or myocardial fibrosis, so these patients will not mount the same amount of response to hemorrhage or shock. They will not have tachycardia. They might be having normal heart rate. They might not have. So this would give us a false sense of security. So normal presenting vital signs are considered unreliable. Now, we consider hypotension as a systolic blood pressure less than 100 or 30% lesser than the baseline. Now, for a geriatric patient who has a baseline blood pressure of 150, even 110 would be hypotension. So there are studies which have recommended the use of systolic blood pressure of 100 millimeter mercury as hypotension for geriatric trauma patients. Now, fluid resuscitation, which is recommended in ATLS, and we need to give judicious fluid in these patients. One, because these are chronic volume contracted patients with the potassium depletion due to decreased renal function. One, and second, overtransfusion can lead to pulmonary edema, which can further make management difficult and lead to complications. Next is neurologic concerns in these patients. Now, because of cerebral atrophy, the bridging dural veins, they are stretched. So these patients are vulnerable to acute and chronic subdural hematomas. Then basic neurologic defects like dementia, stroke, hearing, visual loss, they can make the assessment of these patients difficult, leading to under-triage. Again, GCS or Glasgow Coma Scale is also considered to be unreliable. So a CT head, which is considered to be an adjunct to primary survey, should be done early on for these patients. Osteoarthritis of spine makes these patients prone to cervical spine injury. Although we consider all trauma patients to be having cervical spine injury unless proved otherwise. Now, polypharmacy. Beta blockers, which will reduce the chronotropic activity and thus the response, which I've already discussed, to hypotension, to hemorrhage. Antihypertensives, again, these will exaggerate hypotension already present due to blood loss. Now, anticoagulants, which is another issue in these patients. Now, because of anticoagulants, it could lead to increased bleeding. On the other hand, if the patient is on anticoagulant and needs emergency surgery, that is where the main issue arises. We need to reverse, or we need to take up the patient under cover of fresh frozen plasma. That we have to decide. Again, diuretics. Now, diuretics can again lead to two issues. One is you will not be able to estimate urine output properly, one. And second is this can further lead to fluid loss, loss of electrolytes, and exaggerate the situation. Steroids, they impair the response to injury, and for the wound healing would be impaired. Psychotropic drugs would mask injuries, and on the other hand, these can also lead to withdrawal symptoms. So these are the comorbidities with which we find most of these patients. 50 to 60% patients having hypertension, dementia, diabetes, COPD, hearing, vision loss. All these are the factors which lead to under-triage of these patients because we are unable to assess them properly during triage. Now, we know various triage criteria are available, as sir already said. There are conventional triage criteria, although I haven't written. These are based on anatomy, these are based on physiology, or combined triage criteria. Based on anatomy, we have these injury severity score, abbreviated injury severity score. Then we have based on physiology, that is revised trauma score or trauma score, and combined stress score. Although none of these are very specific or sensitive for geriatric trauma, but trauma score and revised trauma score, because they are based on physiology, they are better for the geriatric trauma. And moreover, there are studies which say that age can also be considered as a cutoff criteria for this. It can also be used for triage. But yes, this is useful in pre-hospital setup, but for in-hospital setup, still there's a lot of controversy. Then we have geriatric specific outcome scores or geriatric specific triage protocols. These have been tried and in one of the studies, the authors found that although these protocols or these outcome scores were helpful, but the patients, severe patients with ISS more than 15, some of these patients were could not be triaged properly, but the number was quite less. So still there is controversy. Again, frailty is considered to be better as compared to age for as an outcome predictor. But for frailty index, you need to fill lots of questionnaires, which is not possible in trauma-based. So again, many authors have used functional status and sarcopenia, but all these are predictors for mortality rather than triage. So there is still a paucity of data for which is the best triage criteria for geriatric trauma. Again, there's a lot of literature available in which the authors have looked at the criteria for improving the geriatric outcome, but this is still we still do not have anything proper. So to conclude, it is under triage of geriatric trauma is well documented. The reason is age-related, anatomic and physiologic changes, comorbidities and medications, and we do not have a robust geriatric specific triage criteria. However, appropriate triage evaluation, early aggressive management can improve the outcome in geriatric trauma. Thank you.
Thank you, Dr. Choube. It was a very nice lecture. I think only one question should be allowed. Any one question from the audience? In case nobody has any question, we can move to the next lecture.
Thank you.
Thank you.
Now I would like to invite Dr. Sharmili Sena, who is a Senior Consultant Critical Care Medicine in Apollo Hospitals, Bhubaneswar. She will be speaking on bundle drip management. Is there a protocol? Dr. Sharmili, please.
Thank you very much, esteemed chairpersons, faculties, and all my dear friends and colleagues out there. At the outset, I would like to thank immensely the organizing team and especially Dr. Kajal and Dr. Jitinder for giving me this opportunity to be part of this prestigious platform. And being an alumni of PGI, it's always a pleasure and privilege to be part of such academic sessions. I have been listening to a few of the lectures since morning. It is going really excellent and giving very insightful and informative, a lot of information towards the management of polytrauma patients. So moving on in the series, I will be discussing about the management of fracture reefs in patients and would see and understand if there is a protocolized approach or not. So bundle reef fracture management and is there a protocol? That's the topic for the sessions. So moving on. The learning objectives of this session would be to understand or to rehearse rather the key issues which are existent in the field of management of reef fractures. Surgical fixation, especially for this kind of reef fractures, have been a debate for almost 2 decades now. So we would actually inspect what is the evidence, where do we stand, and what is the practice. So what is the gap or the bridging gap between the evidence and the practice that we have or currently hold at this juncture? And what is the best approach? Is it a balanced approach or it is a bundle protocolized approach? And where the future lies. So we'll start with the case scenario. It's a very common case scenario that we come across in our day-to-day practice. It's a 35-year-old male who had a bike accident. Now he was brought to the emergency department in a conscious state with blunt chest trauma, with bruises all around. So he did not have any brain injuries, and after resuscitation, a CT scan was done which revealed fracture 3rd to 4th rib on the right side with underlying pulmonary contusion. And he was requiring around oxygen 3 to 5 liters, was slight tachypneic but not in respiratory distress. There were no significant collections to start with in the CT scans. So he was shifted to ICU for observations. Now pain score on day 2 is around 7 to 8. So how will you manage this pain? So these are the options. So we'll just please go through this question. We'll bring this up again later during the course of the talk, and we'll review what will be the best option for this patient. So medical or medical plus surgical, or a surgical plan at the outset, you give it option to the patient's families, and which could be considered after 72 hours, or all of the above. Actually, this is something to just to delay others, but it is definitely not the answer. Among the 3 we'll discuss it. Because in our practice, we have seen the moment we explain it to the family attendants that there is a fracture of ribs or the chest bones are fractured. And that's the reason we are keeping the patient in ICU, because we need to observe their oxygen status and any further hemodynamic changes or respiratory changes which might happen subsequently. The first questions that they put forth is, if a bone is fractured, can it not be fixed? Because most of the laymen are used to, fractures, they need to be fixed. Either it is a long bone or if it is a chest bone, it does not matter to them. So that is the question that we have to actually address in a day-to-day management during patient counseling. So the common issues that we encounter in the management of reef fractures are far and foremost is the pain management. And most of these multiple reef fractures are usually associated with lung contusions and flail chest to various degrees. Now, the extent of this lung contusion and the flail chest varies. If it could be mild, moderate, or severe, there are no such scores which actually classifies this, but generally we quantify them based on their clinical signs, symptoms, and their monitor parameters, mainly the respiratory rate and oxygenation status. And the debate actually is centered around surgical fixation for selection of appropriate cases which could be considered for surgery. So it is mostly about non-surgical versus surgical or a balanced approach between the two modalities of management. So regarding the approach to rib fractures, I think it can be broadly placed under four major headings. That is, first and foremost, as all the previous speakers have been talking, that after triaging, resuscitation and damage control is the first and foremost thing to happen, because the patient has to survive to have advantages of the trauma care, and subsequently you're looking at a successful discharge from the hospital. Pain management comes again first and foremost, is very crucial for these patients. Later in the course, we can also have a juncture. Sometimes some of these patients could be judiciously selected for surgical fixations. And the ultimate outcome remains for this particular category of patients, which should be aimed at quality of life. Because remember, it is just not the patient who is admitted with a rib fracture. There is some kind of compromise of the respiratory functions, and after some time, the patient just functionally improves. It is not aimed at just discharge from ICU or discharge from the hospital. It is also the quality of life ultimately which matters, because these patients, usually these trauma patients are young patients, they are in the productive phase of their life. So the aim should be giving them a good quality of life so that they can return to the work and live a healthy life. Now let's have a quick look at the literature. If you see the literature of last 2 decades, it is flooded with lots many paper which is focused on this blunt chest trauma management, and most of them are also about this management of fracture ribs. I have quoted the few important ones. This one by Wagner et al. In way back in 1998. They looked at actually this patients who had a failed chest with rib fractures, and they found in their study that surgical management in failed chest with pulmonary contusion actually increased mortality. Now, another group of investigators, almost after a gap of 18 years or 2 decades, you can say, they found that patients generally implement for patients with ARDS, that is acute respiratory distress syndrome. That is also the principle for these patients. But the good point or the favorable point for these patients who have got failed rib fracture or failed chest associated with pulmonary contusion and ARDS ultimately, they usually have a good recovery. They usually tend to recover fast and usually start improving after 3 to 4 days. And by 2 weeks, most of them actually improve unless there is a secondary or nosocomial infection setting in these patients. So these patients do have high rates of recovery and positive outcomes. So one needs to remain aggressive and support the appropriate organ support therapy as early as possible. So this is one actually after again a gap of from 1998 to 2016, almost a gap of 18 years. You see one study done by PRC et al. Which was published in this Journal of Trauma Acute Care. They actually found something favorable in favor of surgery, that surgical fixation would have a better outcome when done within 72 hours. Now this is a clinical contradiction, because most of these patients within this period of 72 hours are actually at the peak stage of pulmonary contusion. They are quite unstable, and even if they're hooked onto the ventilator, they take some time to stabilize their gas exchange and the cardiopulmonary parameters. So within that time, if you're actually opening up the chest, it is actually clinically is not going to help the outcome. But again, this study, if you look at in detail, they did not have much description or detail about the number or the extent of pulmonary contusions. Hence, this also actually did not make any influence or impact on the existing practices. Now, the situation is a bit different for patients who sustain polytrauma. So along with chest trauma, if they have also traumatic brain injuries or spinal injuries or other incapacitating injuries in other body parts, usually the management becomes little different. It is advocated that if a patient has got severe traumatic brain injuries, and if you are fixing their refractures by fixed surgical methods, subsequently when the brain function starts improving, it might help them in faster recovery. But it is more of a theory rather than practice. But I would say I would focus on those patients with spinal injury. If they have a simultaneous spinal injuries in forms of the fracture vertebrae, etc., if you can fix the ribs during spine surgery, it can actually help reduce the pain, because the proximity and the commonness of the neural nerve supply, this actually helps a lot in reducing the pain and facilitates cough expectorations and pulmonary rehabilitations, and thus reduces the subsequent respiratory complications. And the commonest respiratory complications being in these patients are the atelectasis or nosocomial infections. If there is printing of the diaphragm and the patients are not breathing well, there is retention of secretions, and it invariably leads to nosocomial infections. So now let's look at the guidelines. If you see literature, again, various societies and committees have their, or even the institutions have their own guidelines. The most common ones which is discussed or even followed partly in different parts of the world is about this two associations that I found, that is Eastern Association for the Surgery of Trauma. One was the 2012 and another edition they have in 2017 of United States, and Western Trauma Association again of United States. Both of them actually advocate for multidisciplinary team approach. And there is almost a consensus among all the society guidelines, if you inspect this, that when there is a frail chest associated with severe pulmonary contusion, usually surgery is not a good option. So coming down to the basics, that is about the pain management in patients with rib fractures, it is very, very crucial, and it cannot be overemphasized that how much necessary it is, because it has a very direct relationship with early pulmonary rehabilitations, the ability to return to work early, and less of chronic pain issues. Now, chronic pain issues are also a significant complication for these patients if they are not managed properly in the initial period. It is seen that the chronic pain syndrome in these patients who had a rib fracture and subsequently been discharged from the hospital is up to the tune of around 40 to 50%. It's quite high. It does affect their functional life styles and also social life. So pain relief can be, again, it's a multimodal approach. While the patient in the intensive care unit, we can give them all different kind of blocks or analgesias. It has been discussed in my previous talks about epidural and paravertebral. Now, logistically, administering this gives very good analgesia when it is done properly by skilled personnel. But logistically, again, it is not possible in all cadres of ICUs, because you need to have the trained manpower, and even maintaining this epidural catheter beyond a period of 5 days is also a challenge. Blocks are also very useful, and if it is given by the skilled personnel, works excellently. And definitely the drugs have a role to play. Most commonly, the drugs in the acute phase used are the opioid ones. Mostly the systemic ones we use are the morphine, fentanyl. Non-steroidal drugs also are excellent analgesics. And at least given for at least first 3 to 4 days, they do a wonderful job. But the issues remain, as my previous speaker, Dr. Choube, was speaking. If it is an elderly patient with multiple comorbidities, usually they might be having diabetes, hypertension, underlying nephropathy, etc. So with that, it becomes actually risk factors along with their potential for causing gastric upsets. So beyond 3 to 5 days, we actually do not advocate using more of this non-steroidal agents. But if a patient is elderly, having comorbidities from the outset also, we do not encourage use of these NSAIDs. Oral alternatives are also available. Patches, I would say, has made a lot of difference in the recent 4 to 5 years. Mostly this nalbuphine patches, ketorolac patches, when they are used in different combinations, go a long way in reducing the pain scores and patient satisfactions. This one of the meta-analysis also says that if these patients with frail chest, if they're offered surgical fixation, they can also reduce the pain scores. But again, there are a lot of controversies and variations in the practice in approaching this surgical method for reducing pain scores. So this Eastern Trauma Association 2017 recommendations do say that operative management, actually they have reviewed and changed their statement and more inclined towards operative management in appropriate cases, though, that this operative management can reduce mortality in certain cohort of chest trauma patients with rib fractures. Pain control continues to get the top priority, and it is said that in such patients it can reduce the duration of mechanical ventilation. Again, it can reduce the incidence of nosocomial pneumonia. However, as I said, there is no general accepted rule of surgery in the management of rib fractures yet, because there is a lot of variations, and also the kind of rib fracture is also so varied, because some, the site of fracture, the kind of, if it is complete or partial, or the combination of injuries, and also its combination with varying kinds of pulmonary contusion also continues to vary. So there is very difficult to achieve actually the uniformity in placing or formulating a guideline first of all, and practicing it uniformly across different institutions. So by default, there got to be individualizations and got to be customized decision as the patient protocol, patient profile, and also according to the infrastructure limitations. So this is a recommendation from this East Association of 2017. There is a kind of consensus on clinical indications for rib fractures, which are the following. If somebody has got 3 or more rib fractures with rib displacement or of more than 1 rib cortical diameter, there's a flail segment. If there is a worsening of the pulmonary parameters with progressive volume loss on chest x-rays, somebody going on to require invasive mechanical ventilations, requiring high dose of IV narcotics, and VAS score is remaining high, more than around 6. But somebody who also has got open chest defect or requiring stabilization on the retreat of thoracotomy or pulmonary herniation, these are absolute indications where, because the chest has to be open, and at the same go, the ribs can be fixed. Because otherwise, if the chest is not open, no open chest injury, opening the chest just for the sake of fixing the ribs has got its pros and cons. We'll just see that in the next. So now coming to my case scenario, I would like to place a question to the audience if that is allowed. Now on day 2, pain score is 7 to 8 by 10. So how will you manage pain? Is that allowed? The permission from the chairpersons, I would like to.
Pardon?
Yeah, I mean, this is a question for the audience. So can you get some responses or I proceed?
Any response from the audience? Which is the best option?
On day 2?
I think medical pain management would be the best possible option in this case.
Yes, I think day 2, and given that he has got only single organ injury, like that is a blunt chest trauma at this point of time, he is little bit oxygen dependent. He has obviously underlying pulmonary contusion, so he can wait and go for best possible medical management. Now on day 5, the vitals still remain stable. He is now doing well, but now has gone on to require 3 hours of non-invasive ventilation, and still requiring of NIV is requiring around 3 to 4 liters of oxygen. This is a very common scenario we see in our ICUs, and now the pain score remains high. What will be the option now on day 5? Now having come to this stage of discussions, I mean, it is something whatever we do in our practice, because there is nothing right and wrong as far as this refraction management is concerned, and it is at the end, it is customized according to the patient's profile and the infrastructure. On day 5.
I would still like to continue with the medical management, at the same time get a surgical opinion. What the surgeons have to say about the current status of the patient, and whether they feel that a surgical intervention would benefit or not. So we'll have to see a risk versus benefit ratio for the patient and accordingly decide the further management plan. So it would be a multidisciplinary approach for this patient.
Yeah, thank you very much for your response. I think that's the right way to go, because even on day 5, it's time to probably repeat the radiology to see the x-rays if the collections are accumulating, and if there is how much volume loss is there. If his patient is actually worsening, if there is secondary infection, it's a bit too early for secondary infection to set in. But if he is managing a few hours on NIV and rest of the times on oxygen, he is not decompensated. And at this stage, when there is no open chest injury, in opening the chest just for the sake of fixing the ribs actually will cause more tissue damage than the benefits of the surgery. So it would be still prudent and wise to wait for a few and watch the patient and try to optimize the supportive care by augmenting analgesia and other supportive care. So where we stand, as we said, the debate continues, but we see that in the last, again, say 4 to 5 years, there has been more inclination and there can be more endorsement towards surgical fixation of ribs in certain selective cohort of patients for fixing the fractured ribs. So it should be, if at all it is to be considered, it is to be considered after initial damage control is done, and in cases where surgery is the only option and when surgery can improve the quality of life. The last sentence is quoted because many patients actually have delayed presentation to tertiary care units. We get patients from peripheral who have, suppose, sustained the injury maybe 10 or 12 days ago. Because the pain has not been subsiding, they are not able to breathe and probably not comfortable, and oxygen status is not improving, they are referred to us. By that time, there could be some patches on the X-ray already. It could be the contusion, which is probably organizing, or secondary infections, but pain has not been well taken care of. So these patients actually are the risk of going into the chronic pain syndromes. And by those time, if you can improvise and optimize these patients with other modalities of pain management, with pulmonary rehabilitation care or physiotherapy, well and good. Otherwise, these are the patients who could be also considered for a surgical fixation after, of course, assessing the risk-benefit ratio, as our colleague just pointed out. So these are basics of clinical and critical care principles that should be applied. So less invasive approach. Now, what is the development of the modern practices towards surgical technique, even if at all it is applied, that it advocates for less invasive approach, because the target is to lessen the tissue damage and early recovery, to have best of the benefits from the fixations. So minimal or invasive techniques are being encouraged and practiced these days. This is term called MISO, minimally invasive osteosynthesis. They're using more of this biological osteosynthesis methods these days. And regarding the approaching or fixing the ribs, actually it is not necessary. Suppose this patient has got fracture of 3rd to 7th ribs. It is not necessary to open and fix each and every rib if you are going for the surgical fixation of the ribs. So it is not necessary. The order of priority is lateral and low ribs are the top priority ones. If they're broken, they need to be fixed first, because they are the ones who actually exhibit the highest grade of exhaustion during the breathing movements. Then followed by the dorsal rib fractures, followed by the anterior rib fractures, because they are in the floating stage. They do not exhibit that degree of movement during a breathing process. So fixation material also matters. Earlier they used to have more of this metal fixators, but they are less elastic. So if you are uniting the bone through this metal agents, they tend to restrict the movement in the subsequent period. So better to use the absorbable and elastic materials. I'll have few pictures. Yeah. So I was talking about this having a minimal invasive surgery. See, earlier this is to be a very long surgical incision. You see everything is exposed. A lot of muscular dissection has happened. So this is what is called tissue damage. And subsequently, even if they heal superficially, it gives rise to a lot of restrictions and movement, hence hampers the functional recovery. Compared to that, these are the minimal invasive approach, where you see there is only minimum field is exposed, minimum dissection of the muscles, and the ribs have been fixed. So this is a technique for this application of this plate osteosynthesis, where even less of muscular dissection is there, and with this just cut, they're trying to fix the ribs by these methods from outside. And this is a very small incision on the scapula by which they're trying to fix the ribs. So these ultimately cause less tissue damage, hastens the recovery. So best is to have a balanced approach. So adequately resuscitate the patient in the initial period and stabilize. Significant other injuries, if associated with the blunt chest trauma, has to be handled first. Severe frail chest with pulmonary contusions, surgical approach is a big no. Go for supportive therapy. We have to carefully select patients with multiple fractures with certain indications for surgery, as we saw that table. But again, as I mentioned, the patient profile and also your infrastructure limitations. Like one needs to have very experienced trauma thoracic surgeons for this matter. I believe most of those refractories are done by trauma surgeons or thoracic surgeons. Practice could be variable in other institutions. Multimodal analgesia remains the key step, and support with ventilation as required and basic good intensive care. That remains the principle as it applies to any other critically ill patients. To summarize, the take-home points will be multidisciplinary team approach to reduce mortality, morbidity, and improve the quality of life. Most of these patients who have got pulmonary contusion with rib fractures, actually they have very good outcome. And in my 17 years of critical care practice, I have seen most of these patients who are successfully discharged from the hospital. Couple of the patients who were elderly, as Dr. Choube was mentioning, with multiple comorbidities and also other organ injuries like head injury or abdominal injuries, they had succumbed. But if there is an isolated blunt chest trauma with multiple rib fractures plus minus flail or contusions, they generally do well with reasonable basic intensive care. So that is the role of combined medical and surgical techniques to be applied in the right patient in the right context. Pain management again remains the same key step. Fixation selection for pain management in certain codes can be considered. Rehabilitation for pulmonary or be it general rehabilitation remains the ultimate goal. Hence, it is important to give attention to these very basic and minute points from the beginning itself. So now answering the question which was put to me as my topic, that approach to management of rib fractures, is there a protocol? So the answer is there is no protocol. It has to be customized and it has to be individualized according to the patient profile and according to our infrastructure facilities. So a balanced multidisciplinary approach is best. Outcomes remains generally good with robust intensive care. And I would say again, simple principle is the common things are common. And that's why we should apply common basic principles for management of these patients right from the beginning. And I would say future research, if you see like, I think India is now almost, along with diabetics, is also the trauma capital. And the volumes of case that we get in our public hospitals or even big trauma centers are huge. So there remains a lot of scope for actually analyzing this rib fracture patients with blunt chest trauma patients and publishing our own data. That will go a long way in also clarifying this kind of debate, which is still existing. Thank you very much for this opportunity and patient listening.
Thank you, Dr. Sinha. I do agree with you that the balanced approach is the good approach, but the debate still continues. So any comments from the virtual chairpersons, Dr. Jayashri or Dr. Gautam, or any comments?
Yeah, Dr. Sharmili, it was a very comprehensive and I think you did not miss any thing related to this rib fracture saga going on for so many years, and it is going to continue for so many years. I am a cardiothoracic surgeon, have been dealing with the chest injuries, but definitely pain control and good physiotherapy. Physiotherapy is possible only with good control. These are the two basic pillars on which the entire chest trauma management stands. So rib fracture, I have never operated. Just to fix a rib, I have never done any procedure so far.
Good to have your opinion, sir, because something I have also not seen during my years in PGI and thereafter since 2004 I left PGI, and since now I have not treated a single patient who actually required a surgical fixation of ribs. But that's why in India we can have our own data about this because lots of public hospitals are dealing with huge number of cases. That will also pave a path for the world as well.
In fact, it's mentioned in certain papers that if some rib fracture patient is operated for some other reason, like for some lung contusion, bleeding from inside or whatever, they mention that these should have ribs fixed But as far as I remember, even for these patients, we have never fixed drips, and they have done well. Yeah, thank you. Thank you for a very good lecture.
Yeah, pleasure.
Good afternoon, Dr. Gautam. Hello. Dr. Gautam, could you hear me? Okay, then thank you, Dr. Sinha. Over to the next speaker.
So I take the privilege to invite Dr. Ankit Mehta, consultant pediatric intensivist at Zydus Hospital, Ahmedabad, to deliberate upon the topic size does matter, unstable injured child in resuscitation room. So all over to you, Dr. Ankit.
Sir, is my screen visible?
Yeah.
Yes?
It's visible.
So it is visible and I am audible?
Yeah.
So first of all, thank you. I am happy to see LT1 again back, and thank you so much. So this is a journey which is like I have done my DM in pediatric critical care, and once I have come back to Ahmedabad, I have joined a multi-specialty hospital, and 50% of the admissions here are more of a polytrauma. It is a level 1 intensive care, again a trauma unit. So that's why Kajal ma'am probably has thought that we should have some probably pediatric talk on this part. So unstable injured children in resuscitation room, size does matter. So first of all, learning objectives for me from today's presentation will be what is the difference between a pediatric and an adult polytrauma, and what are the common evolving concepts in the field of pediatric trauma. So first of all, what is an injured child? So what do you mean by an injured child? So injured child means that you have a energy, first of all, which is in the form of maybe physical, mechanical, maybe chemical, which causes a damage in form of interaction between an host agent and the environment, and it is significant enough, which is beyond the tolerance of a child. So it has to be an unintentional injury or an intentional injury. What we are talking today about is an unintentional injury. So what is the unintentional injury and what are the burden of these injuries in our country? So first of all, around 1 million children die across the world. That is 95% are in the low and the middle income countries. That is around 10 lakh children die because of all these unintentional injuries across the world. And around 40,000 of the children, according to the Indian data, die every year because of all this, which have been mentioned. And it is the leading cause of death in children between 5 to 14 years of age. So the commonest thing are road traffic injuries, drowning, burns, falls, poisoning. So these are all the things, but we don't have the breakdown of the data which is available for them. And the biggest thing is, look at the morbidity. For one child dying, 12 children are hospitalized or permanently disabled, and 34 children miss school daily for this. So I think this is a huge burden. And every trauma unit, I think, sees a lot of pediatric cases. And we know why they see, because most of these children, first of all, now, because of the age, they explore a lot. Then there have been a lot of especially road traffic accidents which involve children. We rarely have any safety guidelines for the seat belt. I think these all help. These all are difficult situations for children where we need real guidelines from the probably the authorities that how do we tackle them. So this is a first case. Well, how it is different, I just want to show. So this is a 3-month-old girl. She met with an unintentional injury. She was sitting in the rear seat of the car. She was coming back from a vaccination, and the car collided head-on with an moving vehicle, fast-moving vehicle, and this was the imaging finding. So this is the second hour of the trauma, and you can see multiple infarct and almost a hemispheric infarct on the right side. So this is case 2, 7-year-old child sitting on a tractor, fell down, and one of the wheels went on the left side of his body, brought to the hospital in respiratory failure. Again, had obviously an hemothorax. Along with this is a laceration, huge injury which has happened on the buttock. So, school bus accident. This is the incident which I have managed as soon as I went out from the PJ and went to the Ahmedabad. So this is a school bus met with an accident carrying out 20 kids on a highway. 13 of the kids were shifted to our hospital because of the non-availability of the primary treatment in a local hospital, and 6 of them were seriously injured. So that was the talk about how to triage. So I had only 9 beds and 6 of them were seriously injured. And these children were on the age range of 4 to 16 years of age. So we really had a tough time managing these kids. I'll get back to them later. So what were the learning from the above cases? The mechanism of injury in children can be completely different from the adults. The resources and the skills which are required to manage a pediatric trauma patient is completely different from a simple trauma unit which doesn't consist sometimes of other pediatric intensivist needs. And then level of trauma care also defines whether you can treat the pediatric trauma over there or not. So what are the type of accidents? I am not going into the more detail, but the commonest what we see is unrestrained car occupants where there's a head, face and neck injuries and hitting the dashboard and a windshield. It is very common. And then the cycling injuries, which we commonly see now, and again, sports injury, which we also see. So what are the common differences between the childhood and an adult polytrauma, which makes the differences in management? First of all, there are anatomical and physiological differences, and this definitely has some implications in managing. The commonest implication is the airway. Now, you all know, I don't need to do a detailed version about this, but there are definite differences in the oropharyngeal anatomy, which can make a intubation very difficult in such children. Obviously, they have a very poor oxygen reserve compared to an adult. And breathing wise, obviously, you cannot see the signs of external sometimes trauma and rib fracture signs, anything like an external mark, but they can have significant intrathoracic injuries, which may which in the triage, you may not even be able to appreciate. So triaging such children may be very, very important. I remember distinctly a case where a child was sitting on the back seat and there was a sudden brake and the child went onto the dashboard and the gearbox went into his abdomen. Immediately, the parents rushed to a nearby hospital. He was told that the baby is stable, looks okay, because he was seemingly looking fine. And after 4 hours, this child landed up in our hospital with a splenic injury, grade 5 laceration, and this child we couldn't salvage, and he went into the trauma-related coagulopathy. So you can know that, yes, this is a difficult situation. You should know the impact of injury. You should know that what can happen over a period of time. And probably given the situation, this child should have been kept in the ER and monitored better, because serial examination in such children may be better rather than only looking at one side of the patient, just like what we have discussed in the geriatric patients. So circulation wise, again, few of the speakers have already highlighted, children can remain normotensive for a very long time despite having significant blood loss. Please do not look for hypertension in small children. It is the very late event and it almost happens near death event. So please never look for normotension. Before that, the pulses can become very thready. They can have very poor CFT. They can become quite irritable and they can even have narrow pulse pressure. So disability wise, obviously they have different patterns of head injuries compared to the adults. They have a very great potential of spinal cord injury compared to the adults. And again, they have a very subtle signs of raised intracranial pressure. A child who comes with a GCS of maybe 8, 9, they can suddenly move to 4, 5 in maybe no time of 30 minutes or an hour. So their signs of raised intracranial pressure are very, very subtle and you need to be very observant to identify them. The most important thing is hypothermia. Many of our polytrauma patients land up in hypothermia and it develops over very rapidly. And we have done few changes in our system that we tackle this hypothermia. And obviously they have a very high chances of having multiple injuries once they have a polytrauma. So what are the changes which we notice in such patients? Look at the timing of organ failure. In adults, they may develop over a period of 48 to 72 hours. But in children with injured children in a resuscitation room, they develop immediately within 24 hours. Organ failure, again, it can be sequential, but in children, most of the time it is simultaneous. And the systemic inflammatory response in the children is very dampened compared to the adults. But if you look at the local inflammatory response to the injury, it is more robust. Acute lung injury, they have a low risk compared, but you can miss many of the intrathoracic injury because to identify some of the findings may be quite difficult if you don't do a proper examination along with the imaging. And death due to pelvic fracture, which is quite common in adults, may be at low risk. And neurological injury, one thing I want to highlight is they have a very, very good recovery rate. And I would like to post my data in the end and see that what is the good recovery rate, what I meant. So coming to my topic, what I have to do. So these are the things which I just wanted to highlight that these are the differences. Now, the main thing which I have to tell is that I don't need a differential diagnosis here. I immediately need to recognize and treat the life-threatening injuries. That is very important for every resident. You need not make a diagnosis that what has happened what are the things happening. First of all, please immediately triage them and fix them early. So the priority will be to triage them, prevent the hypoxemia, hypothermia, and identify shock, identify the cases of trauma-related coagulopathy, activation of massive transfusion protocol, identification of signs of raised intracranial pressure, use of fast and damage control surgery. So these are the few points which you have to immediately look into in a patient who comes with a polytrauma. So what are the differences between a pediatric advanced life support and a ATLS in a pediatric side? So initial assessment in a ATLS is absent, which is compared to in PALS, it is present. Primary assessment, obviously it is present, but here you don't do immediate initial assessment like a PAT, which is like look, listen and feel. Here you immediately start the children on oxygen without even doing a primary survey. And the more focus is here to identify the hidden sites in exposure once you complete the primary survey. And most of the time the team leader is trauma surgeon. In PALS, it is more of a physician. But I can tell you, rest assure you, obviously trauma surgeon is helpful. But most of the time, once they see that the pediatric intensivists are having so much involvement in the patients, most of now our units, I get the first call that the patient has come, sir, in the ER, is significantly injured. Please come and immediately see. And by the time the trauma cord is activated. So this is our dedicated trauma area. You definitely need to have a different place for children. There is no doubt. We have 2 beds for them and 1 bed, another is for the medical patients. ATLS staff we have trained. We look at the emergency signs, which you all know, they have already been explained in the triage. They almost remain same for the children. And in case of life-threatening emergency, a trauma cord is activated, in which a coordinator comes from the blood bank, in which the other persons from the ER come, and we almost get a team of around 8 to 9 people. The team leader here is the emergency consultant or a pediatrician. As soon as obviously the other consultants comes from the surgery and vascular surgeon, PICU registrar and consultant is available. 2 nurses and a radiographer is there, and there are availability of other specialized doctors as and when needed, like a plastic surgeon. And trauma cord activation policy is the need of an hour for pediatric patients. We have a different code for adult and pediatric. And then definitely a airway trolley and a cervical collar, which is based on the pediatric needs, has to be there. And they are all available now in the market. So obviously we don't have such kind of absolute system like the West, but many of these things are now possible in the hospital. So this is the trauma evaluation sheet, which we have developed over the period of time, where we look at the pre-hospital, whatever has been done, whatever fluids have been given, and the other details, which obviously you all have been taking. But we have specialized to children, and the last page of this has all the dosage written of the children, that how do you need to give. You just need to identify that, yes, it is a 10 kilo child. So then you'll just see the page and you can give the dose. So this is for the things, because many of the times it may take 10-15 minutes for us to come. So initially they can start the treatment. So child airway is different. This is the first part which I was highlighting. It is very important that once they are kept on the trauma board, they require some support on the back of the shoulder, because then otherwise, smaller the children, their neck will flex. And once their neck is flexed, their airway may not be patent. So it is a very important thing, and you don't need to design the different ones. We just put a small bed sheet kind of thing and just make the other part of the body elevated, just for the neck to be neutral. That is very important. And C-spine stabilization, again, like adults, we also do in children who have altered level of consciousness. There is evidence of now more and more children coming with sometimes intoxication, neurological abnormalities, which can be potentially due to spine injury. These all are the things, and where we are not able to 100% sure whether there is a injury to cervical spine or not, we put a collar immediately. So what is the primary survey do? You have to look at the airway, whether it requires any intervention or not. If the patient requires an intervention, and if you are not able to intubate or ventilate, please be very careful that after a failed ventilation attempt with bag and mask, involve your surgical colleague. Many of the times we need to do a surgical tracheostomy or a cricothyroidotomy. That has been done, as far as I remember, maybe yearly twice or thrice in children who have got very bad lacerations on the face. Sometimes they have been bleeding very badly and we are not able to see any airway. So these are the things which have to be available. So I think we require people who are specialized in that field and they are readily available, because it should not take more than maybe 10 minutes or 15 minutes for such children. Sometimes it can even be very hard for 10-15 minutes also to bag them. So second part which I want to highlight is you should prevent the hypoxemia, hypothermia, and identify shock. So how do you prevent hypoxemia? I have already told you should start oxygen, that is by non-rebreathing mask according to the size. You have got different size of masks which are available. And the main focus is to identify the tension pneumothorax or the massive pneumothorax. And sometimes most of these patients with polytrauma have got pulmonary contusion, which you will always see. And madam has already highlighted few of the things that even rib fractures are very common and they just require most of the time supportive care. As far as I have seen, I have not seen many of the tracheobronchial injuries, and I have seen in 2 children, but we are not even able to salvage for even like maybe an hour such kind of patients. So I'll not go into the details of this. I think it is similar to the adult one, but the important part, what I want to highlight in circulation is the controlling the external hemorrhage. Now the scalp laceration in such children can be very significant and they can bleed very profusely. So you have to be extremely careful and maybe put the pressure, as has been highlighted in some of the lectures that tourniquet use. We also use a tourniquet in patients. I just told you that the patient who had a tractor injury, this child had a femoral injury also and he was bleeding very badly. And we had done a radiological radiology intervention also in such children. So all of the things which have been done in the adult, probably if given a chance, they can also be done in adults. I would give a caution to use lot of fluids again. Right now the guidelines of ATLS tells 10 to 20 ml per kilo of fluid bolus in a child who looks in compensated shock. Please do not give to any child who comes in the emergency with trauma, because now it has been seen that you just run the fluids initially. I think with the assessment, you need to identify whether this child is in shock or not. And then you give a balanced administration of fluid. It is normal saline until proven otherwise, 10 to 20 ml per kilo over 20 minutes. And we usually repeat it just within maybe 20 minutes and ask for blood transfusion. We don't give any bolus more than 40 ml per kilo nowadays. And as already been highlighted in geriatric points, they do not tolerate the fluids very well, such children. So signs of shock, if there are no, then you just give maintenance fluids. If there are signs of obviously shock, then you give 20, that is a maximum of 40, and then you go for the blood product, which is the PCV. So the next thing which comes is these patients land up in hypothermia. There are available multiple now pre-warm blankets. You need to use lot of caps for the children who are less than 1 year. We use forced air warmer. This is the commonest thing which we do in our emergency. And we also have an area where we can use pre-warm IV fluids, and we definitely use every time a blood warmer to give the child blood, because these patients immediately require blood transfusion and you cannot wait for 15, 20, 30 minutes for them to get that the bag is getting warm. So definitely you need to use a blood warmer. So trauma-related coagulopathy, there have been recently many significant evidence which has come for using tranexamic acid. And now given an option, if the patient presents with polytrauma or patients presents with moderate to severe traumatic brain injury, in the recent JAMA publication in pediatrics, they have clearly highlighted that the importance of tranexamic acid holds true, and you have to use a bolus dosing of 15 mg per kg over 30 minutes to 1 hour and followed by an infusion of 2 mg per kg per hour. The reason is most of these patients land up with polytrauma with coagulopathy, as already discussed in the damage control, I think, lecture of the today's morning. So again, not going into the detail. And one thing which is very clear, we have initially missed many of the patients who have went into massive blood transfusion. So as soon as our blood transfusion goes about 20 ml per kilo of PRBC, packed red blood cells, we immediately order for the appropriate amount of the other blood components. So we have made such kind of protocol for massive transfusion. This has been taken from one of the websites from Boston Children's Hospital, and we have just replicated few of the points and changed few of things and made it for us. And we are very clear that the massive transfusion should not be missed in children, because it can lead to life-threatening bleeding and it can cause a lot of harm. And you all know that coagulation pathway in children is activated much more fast in the compared to adults, and they can have very significant utilization of platelet and fresh frozen plasma components, and they can bleed exsanguinatingly from other sites. So signs of, I think, identifying intracranial hypertension is important. Again, use of hypertonic saline has become very common in these patients. Loading dose has now changed from 5 ml per kilo to 10 ml per kilo, and the maintenance dose remains from 0.3 to 1 ml per kg per hour. The concept of permissive hypotension or patients having just borderline blood pressures in the patients with brain injuries now no more holds true. You have to maintain adequate blood pressure around maybe 25th to 50th centile. The problem is if your patient is bleeding along with in the traumatic brain injury, probably just justification around 10 to 25th centile may also be okay, because if you want to inadvertently raise PP, the bleeding never stops and it keeps on happening. So that is one of the things which is very difficult, and such cases are managed with the help of multiple people. If fast remains the same, I think our emergency consultants are very good in doing it, and we also do it if required. But this remains the most important finding, and we have identified many of the things initially based on the fast only, as highlighted in the adults. So damage control surgery, I'm not going into the details. So the only thing which I want to highlight is musculoskeletal injuries are very common in children. And if you initially in primary assessment miss it, it's okay. But again, you need to assess in next 24 to 48 hours. And many of the timings we have found that there have been multiple small fractures which you have identified. So there is nothing like that. You do a pan CT scan of the body. You need to clinically examine them once they become stable, and probably need to have a lot of radiographs if required to identify such small injuries. So this is our data pre-COVID. A total number of trauma cases seen over the period of 2 years was 104. Number of cases which were shifted to ICU were around 84. 42 cases were of the polytrauma, and the mean pediatric trauma score was 3, which is significant. Any trauma score of more than 2 means definitely this child requires an ICU care. Invasive ventilation was required in around 28 cases, and we have done an early decompressive craniectomy in 14 patients. Damage control surgery was only required in 2 patients. Intervention, if you look, most of them were orthopedic or neurosurgery, but in some of the patients, pediatric surgeon or an ENT was also required. There was a hepatic artery aneurysm because of the post-trauma, and that also required some intervention. So look at the number of deaths which has happened. It is just number of 2 and 1 DAMA, so 3 patients. So if given a chance to treat a pediatric polytrauma, I think once they come out of the initial 2-3 days, they do wonderfully well. And most of these patients in follow-up, even with diffuse axonal injury of grade 2, grade 3, will come walking, talking, and maybe have some few morbidities, but overall, the parents will be very satisfied. So what are the key gaps in managing pediatric polytrauma? I think we have not been given enough training in MBBS and MD for the pediatric polytrauma. There is no pre-hospital management. Once you see a children, they are all going away, and there is no IV cannula, nothing, even basic fluids, basic drugs are not given. The skill check needs to be again done for us, because such high acuity patients cannot be managed by even basic pediatricians. So we require some more training in this field. And team communication we are not used to as a pediatrician, because it is a field where we don't involve many of the people. So I think we need to improve in that. So my take home message is pediatric trauma has definitely a very high burden, and definitely it is not as easy as managing maybe in an adult unit. You require a definite care in such patients. Approach needs to be that you need to educate more people. You need to have more simulation for such children, and maybe in our training, and everybody has to have a ATLS training along with some more pediatric ATLS burden. A training has to be done. As a part of team, I think we require more resources. We require more documentation and communication. And as a preventive part, I think the important part is we need to have child safety guidelines, especially for drowning and for road traffic injuries. Thank you.
Thank you, Dr. Ankit, for such a wonderful presentation. Now, may I request Dr. Jayashree and Dr. Gautam to have their comments and inputs on this?
Yeah. Dr. Jayashree here. Thank you. And a very good afternoon to everyone. And thanks to Kajal and her team for this opportunity. And I congratulate Ankit for having very lucidly put across the important emphasis points for pediatric trauma. And I think as a chairperson and as a pediatric intensivist, I would probably say that 3-4 points are very important. One, children are not miniature adults. I think Ankit has emphasized that very well. And second, it's very important for a trauma team to recognize that physiologically and anatomically children are very different. So they may look very well at the overtly, but there may be many problems that may be going on inside. So it's very important for all of us to kind of anticipate, and once they start progressing or evolving, then they collapse very rapidly and they hardly give us time. So I think it's very important for us to catch that window, because as he has shown his own data, I think we are very hopeful whenever we treat children with neurological injuries, because the brain plasticity is something that is like it works wonders. We discharge them on a GCS of, let's say, 9 or 8, and then when they come back, they are like walking and even speaking sometimes. So I think hope is something where we should never let loose, especially when we are treating pediatric patients. And there are several changes that have come, especially in the TBI guidelines for children. And I think Ankit has emphasized those, especially the BP targets that we need to keep, the fluids that we need to give, and crystalloids. Normal saline still is the fluid of choice when we are resuscitating these children. And probably all trauma teams should have, I mean, I feel the future should be that there should be a pediatric intensivist or a pediatric anesthetist as a part of the team, so that these small children, they get recognized faster and stabilized faster. And about the golden hour, unfortunately, most of the golden hour gets lost before they come to tertiary care centers. So therefore, I think we all have a huge responsibility of capacity building or maybe simulation training for level 2 and level 1 healthcare, so that these are recognized early before they're referred. They're stabilized and then referred to tertiary care. If we are looking at an outcome which is something like what Ankit has shown, is a very heartening data that he has shown. And I'm sure our trauma center also has similar kind of data, but there are children who lose their golden hour before they come to our advanced trauma center. Over to you. Thank you so much once again for this opportunity.
Dr. Gautam, your comments or inputs on this? You are not audible, sir.
Hello.
Yeah, you are audible. Yeah.
Can you hear me?
Yeah, very well, sir.
So, first of all the speakers very well discussed about particularly the extremes of age. I would say it's very important triaging, and problem is always missing the injuries in these patients and not taking seriously, because they may be hemodynamic stable, like even then they may be having injuries. Even the aged patient, they have a lot of problems. So focusing on under triaging, that is very important in both cases, whether it's adult extremes of geriatric patient or pediatric patient. So another thing is, now with the coming up, like we have fast and others, effect is also coming, like whole body scans or the low dose scans that are going to the future on most of the centers, advanced centers. Another thing is, like the rest of the world, the trauma centers are there, because here very few trauma centers are there. So we have to look up to the patient, the general surgeons or the orthopedician or every surgical teams, they have to be trained for these things, the issues of extremes of ages also. So that we cannot, because over-triaging is okay, but under-triaging in these patients is harmful. So in both cases, it's very important. Congratulate Dr. Kajal and the whole team for a wonderful selection of topics and the speakers. Thank you.
Thank you, everyone. So without wasting time, now we will hand over our chairs to the next session. Thank you.
Thank you everyone for this wonderful session. Now we'll move to our next session, in which there are two arguments which will be presented. I would like to welcome the chairpersons, Dr. Anju Grewal, Professor, Department of Anesthesiology, DMC Ludhiana. Areas of interest: resuscitation, obstetric and pediatric anesthesia, airway management, neuro and trauma anesthesia. Also chief editor of Journal of Anesthesiology and Clinical Pharmacology, founder member of Airway Management Foundation, and ex-joint secretary of governing body of AOA India. Dr. Sanjeev Palta, Professor, Department of Anesthesiology, GMCH 32 Chandigarh, with in areas of interest in critical care medicine, airway management and pediatric survey, with multiple research articles and citations. Thank you. They are both virtual chairs. I would ask the chairpersons to introduce the speakers.
Good afternoon, everybody. Am I audible, Ji?
Yes, sir, you are.
Am I audible? Thank you very much. Thank you, Dr. Kajal and Dr. Jitendra and their whole team for giving us this opportunity. And I have the privilege to now introduce our first speaker for the first argument, Colonel Kiran S. He is Professor in Department of Anesthesiology and Critical Care at Armed Force Medical College, Pune. He has got numerous awards like Chief of Army Staff commendations and GOC in C commendations also. He has important appointments as Senior Advisor of Anesthesiology and Critical Care. He has been Secretary of Society of Defense Anesthesiologists and is also an ATLS, ACLS instructor. Thank you, Dr. Colonel Kiran S. for joining us. I hand over the mic to you.
Yeah, I request you to confirm whether I am heard and the screen is seen. Is my screen seen?
Yes, sir, you're audible and the slides are visible.
Thank you very much. I thank the organizers a lot for giving me this opportunity. Thank you, chairpersons, as well. I bring greetings from FMC Pune. Being in the army, I've seen the use of whole blood quite a bit. So my topic is whole blood, is it back again? So in the army in the early 2000s, when I was an anesthesiologist posted in the peripheries, we did use a lot of whole blood. And unfortunately, over the last 10 years being in tertiary care centers, I did not get to use it. So definitely I am for the topic. Yes, it is using whole blood. It is back in again, and it's of enormous benefit to patients. Yeah, so hemorrhagic shock, we all know is almost 40% of preventable deaths occurs due to hemorrhagic shock, and whole blood has been used for resuscitation for a long period of time, right from the early 1900s. So even in World War I, World War II, it was not, it was mainly blood or whole blood that was used for resuscitation to save lives. And they used to have these blood bottles made of glass and used to have blood in them. It saved a lot of lives in World War I and II. Then came crystalloid solutions, which are used in huge quantities, normal saline, lactated ringers. People thought they could make do with volume by giving large amount of crystalloids and then save lives. Then came the colloids, which probably commercially backed, and there's a heavy use of colloids in trauma resuscitation, especially during the Vietnam War and in the 70s. In the 60s and 70s, that's when fractionated of whole blood into blood components started. And once this became feasible, component use started. Component use started mainly for targeted replacements. It was used initially to treat specific conditions such as anemia, thrombocytopenia, any like thrombophilias, any coagulation factor deficiencies. And there was a little bit of decreased reactions, transfusion-related reactions as well with component use. This led to sort of a commercial angle, and the use of donated blood, to use this donated blood more economically. Most of the blood was, or almost all the blood in the Western was converted to components, and this led to a huge unavailability of the whole blood. Having only components with you led to the use of more and more components in all clinical situations, including trauma. So this change from using whole blood to components, largely because of using the blood more economically, this occurred without any lack of evidence or any studies occurring in this area, and more and more patients treated with hemorrhagic shock were given components, and there was absolutely no evidence for this practice, but it just happened. We also know that use of large quantity crystalloid fluids, which was in vogue for the initial resuscitation, has been proven to have worse patient outcomes. It leads to increased mortalities. So at some point of time, after giving some limited amount of crystalloids, you have to go and give the blood in blood, whole blood or blood components. And there's a huge mortality benefit of using balanced ratio of blood, platelets, plasma in massive transfusion over the use of crystalloids. So when they were using 1:1:1 ratio of components, they found that definitely it's better than using just crystalloids. And why did they use this balanced ratio of components? Again, it was to simulate a reconstituted whole blood. So the thought came back again, why not just give the whole blood itself? Why give the components? The US Army recently in the last 10-15 years in its conflicts in Iraq and Afghanistan used a lot of whole blood, and this was mainly because of logistical constraints in delivering the stored whole blood and blood components to the forward areas. So they came up with many publications over the last 10-15 years, and all of them did favor the use of fresh whole blood, at least in the far forward areas, and this has led to significant decrease in mortality. So again, what is old has become new again, and even in the civilian areas, people are, or civilian trauma, we are thinking of going back to whole blood. So is whole blood just a sum of its components? Definitely not. Whole blood, even if components are given as a ratio 1:1:1, there is significant lower hematocrit, platelet counts, coagulation factor activity, and fibrinogen as compared to whole blood. As you can see over here, one whole blood, which is 500 ml, may have around 38 to around 50% hematocrit with about 1.5 lakh platelets at 100% plasma coagulation factors, whereas the balanced component of 1:1 is going to be much more in volume. It's going to be almost 660 ml in volume with a hematocrit only of around 30%, platelets of around 80,000, and coagulation activity is around 65% of the whole blood. So actually to get the equivalent amounts to stop bleeding, you're going to require twice the volume. And this also leads to twice the anticoagulant use of when you use the components. Fresh warm whole blood has been independently associated with improved survival for patients in combat-related traumatic injuries. So many studies, this was published in Journal of Trauma in 2009. So many studies done in the US military and by the NATO forces in trauma resuscitation have shown that this increased use of whole blood, even if used for massive transfusion, has the potential to increase the survival of casualties who have massive hemorrhage, and there's a survival benefit as well, substantial survival benefit as well, and the number of patients who are actually killed in action came down quite a bit. The US Army has its tactical combat casualty care, and they change their guidelines frequently. So it was in 2014 or so that they started introducing whole blood into their guidelines. This is because these studies from Iraq and Afghanistan, where they studied more than 500 soldiers with life-threatening injuries whom they transfused warm, fresh whole blood, and they found that they have a much better 48-hour and 30-day survival compared to massively hemorrhaging patients who were given stored red blood cells. So they actually introduced their whole blood into their guidelines in 2014, and the guidelines became much stronger, the recommendations became much stronger in 2018. So the present recommendations of the TCCC is the use of cold stored low titer type O whole blood being the first choice for resuscitation and hemorrhagic shock. Use of fresh type O low titer whole blood from walking blood banks is the second option. So these walking blood banks are individuals who are in units who are already pre-screened, and you know their blood group, and they've been screened for transfusion-transmitted diseases. So all you need to know is calling these people, take their blood and transfuse it. Collect the blood over half an hour, do initial screening and transfuse it within half an hour or so. So this is the second option, and it recommends the use of 1:1 PRBCs and plasma only if the whole blood is not available, but red blood RBCs, packed RBCs and plasma is available. So this is a huge change. What about the civilian setting? A lot of studies have come up in the civilian settings as well. This study in Shock in 2020, which studied whole blood resuscitation of severely injured trauma patients, suggests that there is equivalent or improved resuscitation and hemostatic markers with the use of whole blood compared to components. The whole blood for hemostatic resuscitation in major bleeding, this is another study by Philip Spinella, who's done a lot of studies on this topic. We've been doing it for the last 15 years. And is whole blood good? Yes, definitely whole blood is good. Whole blood, the use of low anti-A and anti-B titer type O whole blood is very, very safe. In this study is brought out that it's good as a universal toner, and whole blood can also be stored at 4 degrees centigrade to retain its platelet function for almost 15 days of storage. So it's not just that you're going to give only the blood components. Even platelets, when stored at cold temperature for a long period of time, can retain their function for almost about 15 days. Whole blood also has good coagulation activity and fibrinogen as well. So are platelets in the stored whole blood good enough? So in cold stored whole blood, in vitro, they have a good hemostatic capacity for 14 days and even up to 21 to 35 days, depending on the type of additives used. What about why is this so? This is because of the immediate hemostatic ability of the platelets. That is our primary concern, and not what the platelets are going to do in the circulation. So the minute you give the platelet, it is going to cause some aggregation, and it's going to cause clotting, and it's going to be better for the hemorrhagic shock patient. A lot of studies have shown that cold storage of platelets is better than storing platelets at room temperature. Platelets are generally stored at room temperature and can be stored for a long period of time if you have an agitator. But if you store the platelets at cold temperature, there may be improvement in its hemostatic function, and this can be due to the increased in vivo aggregation, and this has led to superior correction of bleeding times in a few studies. This one is really huge. If you use 1 unit of stored fresh whole blood, it has the same hemostatic effect as that of 8 to 10 units of platelets. So actually, instead of giving so many units, you can just give 1 fresh whole blood and achieve the same effect in a hemorrhagic or a shocked patient. So we all know that trauma has its unique trauma-induced coagulopathy, which is a vicious cycle and is one of the main causes of death in trauma. And this systematic review of whole blood transfusions versus component therapy in trauma patients with acute hemorrhage has shown that whole blood contains individual components, but it's there in a much smaller transfusion volume, and it's got much higher hematocrit and fibrinogen, hence it's much more effective. And it causes much lesser dilutional coagulopathy as well. And in this systematic review, none of the studies that they went through showed any worse survival with whole blood as compared to components. This other study from Injury, which is also a systematic review, looked at outcomes of 24-hour and 30-day survival when whole blood and components were compared in acute hemorrhage. And this showed that there might actually be an apparent benefit in blood product utilization if you use whole blood. And definitely use of whole blood was not associated with an increase in transfusion reactions. And however, this study did show that there was no statistically different or significant difference in survival whether you used whole blood or whether you used components. This systematic review and meta-analysis again for 2020 from JACEP. This also showed that whole blood was not associated with an increased 24-hour mortality or a 30-day mortality. So is fresh blood only to be used, or fresh whole blood only to be used, or can you use stored cold whole blood as well? So this study showed that survival is equivalent for fresh whole blood resuscitation when compared to stored cold blood resuscitation, even when patients were more severely injured. Is whole blood safe? Whole blood is collected in licensed blood bank centers just like the components, and in fact, whole blood is collected and then it's made into components within the next 6 hours. So it offers the same level of transfusion-transmitted diseases safety as whole blood. The risk of there could be a risk of hemolytic reaction secondary to the increased plasma that you're going to give when you transfuse whole blood, and this is due to the passively transfused anti-A or anti-B alloisoagglutinins that are there in the whole blood. But this risk of hemolytic reactions is very, very low, to the tune of 1:1.2 lakhs, and this is much lesser than what occurs with 1:1:1 massive transfusion protocols. Also, the transfusion associated circulatory overload is much lesser with whole blood than with components, as the volume that you're going to infuse is much more with components. A lot of minor blood group antigens can cause alloisoimmunization, but it can easily be overcome. The problems in these are problems that occur only in multiple transfusion dependent patients. So once you've done trauma resuscitation, a lot of times these patients don't require multiple transfusions lifelong. So then this generally is not a problem. There can be a few febrile transfusion reactions in TRALI, which can be countered by leukodepleting the whole blood, and this can decrease the febrile transfusion reactions that can occur. And some mismatch in RH antigens generally don't lead to any immediate hemolysis, and especially in the emergency settings, it's quite relevant. Component therapy, however, has huge amount of problems. There are huge amount of storage issues. Platelets can at max be stored at 5 days for room temperature without an agitator or an incubator. There could be a huge amount of bacterial contamination when it's stored at room temperature. And most of our blood banks have this policy of first in and first out for component therapy, which ensures that only cold, old acidotic bags of PRBCs are transfused to the patients. So here you can see that packed blood cells require only refrigerators, whereas FFPs require deep freezers and platelets require incubators. Components with prolonged storage times, when you give huge amount of components, especially in massive transfusions, it can lead to severe hypothermia. It can increase the risk of hemorrhage due to the presence of anticoagulants. So here in the table below, you can see that component therapy, if you use 6 packed 6:6, that's 1:1:1. If you use a pack of 6, you're going to give anticoagulants to the volume of almost 1000 ml. Whereas if you use 6 units of whole blood, you're only giving about 378 ml of anticoagulants. So this huge amount of volume is more and anticoagulant volume is much, much more. This can lead to dilational coagulopathy, citrate toxicity, hypocalcemia, acidosis, hyperkalemias, all those things which is going to lead to much poorer outcomes with the use of component therapy. Also, there's huge amount of increased number of donor exposures when you use multiple components. Then this can be an increased risk of transmission, transmitted diseases as well, and transmission associated circulatory overload as well. So, is whole blood the ideal resuscitation product in massive hemorrhage? Yes, it is, especially in hemorrhagic shock in patients with acidosis and coagulopathy. It reduces the anticoagulant volume. You can transfuse fresher blood cells, you can provide physiological ratios of components, you can avoid over-resuscitation, and there's much lesser citrate toxicity. And the main thing is that it breaks the spiral of acidosis, coagulopathy, and hypothermia. Storage is the same for whole blood and components. So if you're talking of giving components more economically or more prudently and giving whole blood leading to more of a waste, the storage is the same for whole blood and components. So if both are not utilized, whether the component is not utilized or the whole blood is not utilized within the time period, it has to be, both have to be discarded. So the key thing is to have many more innovative ways to use it in time before these components or the whole blood expires, and this can be done by rotating the hospital's inventory. The ideal thing is to hold about 4 units of low titer type of whole blood, and this should not be in the blood bank or far away from you. It should be right there in your trauma bay, in your emergency. Hold these 4 units for about 15 days, and then you can replace these. You can replace it as and when required. Another thing you can do is hold about 2 units of blood in the blood bank as well. As you all know, time is the enemy in resuscitation. Hemorrhagic patients can exsanguinate quickly, and rapid administration of blood is required, and it does not allow time for any traditional typing and cross-matching. So you have to have it right there and administer it immediately. For this type of whole blood is very, very efficient. Stored components there can be a lot of shortages in stored components. Time period to give plasma from the blood bank to get it to you is quite a bit, because plasma has to be thawed. After the patient comes, you're going to send a request and the plasma has to be thawed. Platelets and rare groups are almost invariably not available in blood banks. So again, you don't end up doing 1:1:1, you end up doing inefficient resuscitation. In pre-hospital environments, you have to go for whole blood. There's no electricity, there's no trained manpower. Early management is vital for these patients, and trauma occurs everywhere. So you have to be ready with whole blood in these areas, definitely. Cost of whole blood is much, much cheaper than cost of preparation of components. And adherence to massive transfusion protocols are also much more difficult with components. Whole blood just simplifies the whole resuscitation procedure, and especially with platelet transfusion, whole blood is a much better option than using individual platelets or platelets as a component.
Dr. Sanjeev Balda wants to say something.
Yeah, can
we just, we are really running short of time. If you can just...
The whole blood saves lives. So whole blood has to be given either early in the pre-hospital phase, either in the field, in the ER or in the OT. So it's not just in the pre-hospital care. Even in the OT, you can give whole blood. And the other problems of whole blood are secondary. And in the Indian Army, we have this operational blood support plan where we have these portable containers which are capable of maintaining cold storage conditions for almost up to 72 hours. And this can lead to, the whole blood can be heli-lifted to forward surgical centers from the nodal centers in each theater, and you can actually
save lives in the peripheries as well, and this can be easily implemented elsewhere. In giving components, actually reconstructing deconstructed whole blood, it's much safer to give whole blood itself, and ideal would be to store about 4 units of whole bloods for a few days. Now it's entirely up to us to ensure that it's available and demanded. The blood banks will come on board and eventually start issuing us whole blood. Yes, whole blood is back and here to stay in trauma as the preferred resistant fluid, and it's definitely not a waste of resources by any means. Thank you.
Thank you, Dr. Kiran. Dr. Anju?
Thank you so much, Dr. Kiran. I think we'll move to hear from Professor Sandeep Sahu, who is professor at the Department of Anesthesiology and Critical Care at SGPGI Lucknow, to talk about the sheer wastage of going back to our old, which perhaps Dr. Kiran has made it as a gold standard now. So over to you, Professor Sandeep Sahu.
Thank you, ma'am. Is my voice is clear? My slides are visible?
Yeah,
good afternoon to all, and thank you to Colonel Kiran, because we both share the same thing. It's nothing, कोई लड़ाई नहीं, because what is available, I will not say it's sheer waste, but definitely what is the evidence. आज के जमाने में आपको पुराना नोकिया फोन दिया जाए तो आप वो इस्तेमाल करेंगे या आप आज एंड्रॉइड और आईफोन के भी नया वर्जन यूज करें? So why the whole world has shifted from whole blood to component? Because whole blood practically not available. अभी OT, ICU या पेरिऑपरेटिव जहां भी हम काम करते हैं, whether it is a trauma center or not, अगर आप आज मांगे तो शायद आपको अपने सिस्टम से बात करके जुगाड़ लगानी पड़ेगी, where is whole blood? So I think it is not freely available in India and worldwide, as the evidences say, and it's logistically really very difficult, because whole blood ऐसा नहीं कि we have taken whole blood in a bag and we have given transfers to anybody. It takes not only cross matching and grouping, but also all testing, all type of the battery of tests for all blood component to be done. It is very essential. We can't delay it and we can't leave it, क्योंकि किसी भी ट्रांसफ्यूजन को हम बात करते हैं कि ट्रांसफ्यूजन नेसेसरी नहीं करना जब तक लाइफ सेविंग के लिए जरूरत नहीं, और लाइफ सेविंग में भी लाइफ सेव इज नॉट बिकॉज एट दैट टाइम फॉर प्रोलॉन्ग, बिकॉज एविडेंस इज एनफ. आप देखिए स्टडीज भरी पड़ी है हेपेटाइटिस बी और HIV इन पास्ट, although they have also been tested, but what are the window period and why the transfusion related acute, immediate or late, and why problems occur. So logistically, whole blood is really difficult and limited shelf life, and all perioperative, whether we are in emergency trauma ICU or we are using components since 1950s, and use is growing like anything, because we give therapy, we target point of care, and we either point of care, अगर आप target नहीं कर पाते तो traditional testing, it's there and it is valid. Only the time difference is the issue. And war-like situation definitely is nowhere. We are delaying our wars. We are not fighting with our good enemies. Pakistan and China, we are all listening in the paper daily what they are doing. But still, war-like situation is not there for last 50-60 years, and whole blood definitely worth the use. And in life saving, when we have nothing, then ये वैसा ही कि जब आप 3 दिन से भूखे हैं तो और आपको क्या चॉइस है, ये हम नहीं जाते हैं, हम जाते हैं कि क्या अवेलेबल है. So only remote conditions और periphery conditions में वॉर में, लेकिन अभी पिछले 50 साल से अगर आप देखें, artificial blood product for oxygen carrying capacity and for coagulation is there. I am not contrary, because this is not the platform to fight, and this is no army and civilian war. But definitely, what are the real use, what are the real availability, and what is the real evidence is issue. So if we see whether we are in OT, ICU or in trauma setting, the hemorrhagic shock, because OR it's 90% anesthetists, they work in hemorrhagic shock because patient bleeds. An acute bleed, whenever patient in the hypotension, this is grade 3 and 4 shock, and we want to avoid coagulopathy and trauma-induced systemic inflammatory response syndrome and multiple organ failure, because we have not only to save our patient on table or ICU bed or in the periphery, a trauma patient, but we have to see what is the cause of delayed mortality, and delayed mortality is a lethal triad, and this is the 90% of any hospital mortality. And here coagulopathy, hypothermia, acidosis is a linked one, and these three things can kill any patient, whatever the status of patient is there. So as sir is also shown this slide, 40-50 years ago whole blood was the concept, but आज हम बात करते हैं components की, packed RBC, and the platelet and plasma for targeted transfusion. This slide definitely shows that कि अगर आप एक PRBC और एक platelet और एक plasma को compare करेंगे whole blood 500 और 650 ml, जहां पे 40, 50, 60 और 100% blood loss है, वहां 150 ml doesn't matter. If you compare hematocrit almost usual, and if you are able to achieve what is our target, we are not targeting the bag here, because it's same like when you go for a chart. आप मीठा ज्यादा पसंद करते हैं, आप नमकीन ज्यादा पसंद करते हैं, या आप उसमें कॉम्बिनेशन क्या बनाना चाहते हैं, ये डिपेंड करता है कि पेशेंट किस कंडीशन में. What I have to give, what is my target, it is PRBC और platelet और coagulation factor, क्योंकि आज हम ऐसी टारगेटेड थेरेपी की ही बात कर रहे हैं. सो थ्योरेटिकली फ्रेश ब्लड में ये कहना कि होल ब्लड में भी प्रॉब्लम है, कोगुलेशन की एक्टिविटी विद टाइम डिके करेगी, बिकॉज अब जो हमारा सिस्टम है जिसमें हम काम करते हैं, जिसमें हम आजकल चाहे हम वेस्टर्न वर्ल्ड में हो या इंडियन वर्ल्ड में हो, स्टोरेज होल ब्लड इज ए इशू. मोर देन 14 डेज है ही नहीं आपके पास, तो जो चीज आपके पास ज्यादा रहेगी नहीं एज कम्पेयर टू PRBC, जिसे आप 42 डेज रख सकते हैं, क्रायोफेपी आप 1 साल रख सकते हैं, और प्लेटलेट, क्योंकि हमें प्लेटलेट बहुत कम लोगों को देना होता है, जिनको देना तो वहां टारगेट हमारा बिल्कुल, अब मुझे एफेरेटिक प्लेटलेट देना तो मुझे एफेरेटिक देना, 50,000 में बढ़ा सकता हूँ. व्हाई आई विल गिव अ प्लेटलेट ऑफ टू इंक्रीज 5-10,000, बिकॉज टारगेट कैन बी डिफरेंट इन डिफरेंट टाइप ऑफ पेशेंट, and that is the need of patient, and accordingly we can target the component. Especially in trauma, if we say, if we are getting a hypotension in the OR or ICU in a trauma patient, then this shock more than 40% blood loss, and they clearly says the ATLS on all the trauma life support courses, whether in the British or the American or the Canadian, they say we have to start massive blood transfusion, and massive blood transfusion can only be possible with recent use of blood component. So damage control, massive blood transfusion, damage control, resuscitation, we have to restore physiologically, and we have to avoid preventable death by balanced hemostatic relaxation with early use of blood component, and this is accepted worldwide. So massive blood transfusion, it's 70 and it got started, and we have to target. And we have to stop the bleed, and we have to take this patient early. We have to physiologically stabilize so that this patient remain alive. The surgery can undergo, he can tolerate further bleeding, and then we will stabilize this patient in the ICU, and then we do definitive surgery. So definitive surgery will definitely only save the life, but till the patient should survive. And what the massive blood transfusion or all the trauma guidelines saying, use of blood product in a combination, whether it is 1:1 or 1:2:1. So we have to stop the bleed, and by this we can give only combination and component therapy, that is better. Transfusion strategy can be like, अगर आपके पास point of care testing है, it is very well. If it नहीं है तब भी, otherwise you can do hourly INR, platelet and blood grouping and transfuse accordingly. So this all is well established, protocolized, already working without falsies for last 50-60 years, and all guidelines saying that our target is either 7 to 8 hemoglobin gram percentage, INR 1.5 to 1.10, and fibrinogen. So when I have to give fibrinogen, then I will think of cryo. When I have to take care of INR, I will give FFP, and this is only possible with the component therapy, and target of platelet is not only 50,000. So, and if we can practicing this component, then only we can achieve this. We can do point of care and else. So massive blood transfusion guidelines already working. They everybody knows how to ask them, how to practice them. So component blood therapy can do best a lot of patients, not only trauma patient, in non-trauma situations also, because component we have to give in thalassemia. A lot of patient of thrombocytopenia, hemophilia, and they need the component. So जो जिसको चाहिए अगर हम वो target देते हैं तो we are not doing unnecessary transfusion. Whole blood we have to keep at 4 degrees centigrade, but components platelet is a very big issue when you are taking care of whole blood, क्योंकि उसको temperature plus 22 आप देखिए चाहिए. So 4 degrees centigrade is for whole blood. For platelet is different temperature. So temperature maintenance now system is well tuned. Even blood product जो आते भी हैं वो blood bank से वो कैसे आते हैं और हम लोग कैसे उसको early prepare करते हैं. We have warmer, we have fast diffuser system. So at patient body temperature, we can give all the blood components and we can prepare. So time is not a problem because we have to think of not immediate but long term also. So whole blood component is a better choice because it can be given for better patient management. It avoids circulatory overload, unnecessary transfusion, and adverse reaction is more with the whole blood. So we can minimize it. And if my patient need a platelet from 20,000 to 50,000, I have an option of component apheretic platelet. So 1 unit can raise same higher, even higher as compared to the whole blood or random platelet. So cost is not an issue because it's similar cost. You have to think twice to arrange a whole blood in our setting because whole blood is very limited use, only 21 days. Processing definitely has an issue because without process we can't transfuse directly with infection, and whole blood to keep more than 8 hours is an issue. आपने अगर कहा भी किसी को आज की मुझे होल ब्लड चाहिए अपने ब्लड बैंक में अपनी सेटिंग में, तो उसको 8 घंटे से ज्यादा वो रख ही नहीं सकते. दे हैव टू प्रोसेस, अदरवाइज द कंपोनेंट कैसे बनेंगे. और अगर किसी सेटिंग में हम होल ब्लड देते भी हैं तो एडवर्स रिएक्शन आर वेरी हाई लिमिटेड. इट्स मैंडेटरी टू डू द प्लूम टेस्ट एंड हेप्टोग्लोबिन. जो पेशेंट को आपने होल ब्लड दिया है इसका डेफिनेटिव केयर के लिए अगर आपको दूसरे सेटिंग में भेजना है और वो लोग अगर होल ब्लड यूज नहीं कर सकते हैं तो ट्रांसफर इज ए मेजर इशू इवन इन वेस्टर्न वर्ल्ड इफ पीपल आर यूजिंग होल ब्लड. और इवन इन कॉम्बैट इज नॉट स्टे एंड प्ले नाउ. We have to take care of airway, stop bleeding in a scoop run. Even in Indian combat, they take care of all the patient and they by heli or helicopter they reach a definitive higher center or a good center where they can do the definitive care. So earlier days the wasting of much time in field has gone. So bleeding was more and we have to give something. But now the scoop and run, even it is seen in Afghanistan war and people are running from Iran, Iraq to US because UN forces are there and nobody country want to waste any life. There is cross disadvantage of whole blood. It's not FDA approved. AVO matching is needed. High bacterial contamination, increase error because your system is not tuned for whole blood. And a component when it's not universal donor recipient thing, and female patients have RH issues, RH negativity issue, and there's no use. Even if we compare PRVC with whole blood, you can increase more than 1 gram with this 1 PRVC as compared to whole blood. And also the other problem are more here with the whole blood as compared to PRVC. So whole blood not to be used as a convenience. It is not appropriate to use as alternate of blood product or component therapy. Only when we have to say that nothing is there, nothing can be done, and we have to save a life only in combat patient actively bleeding, then you can think of that. Otherwise, it's not recommended even in guidelines. So very, very limited use. People are only earlier using for exchange transfusion for ECMO or infant and pediatric cardiac, but nowadays they are using combination of PRVC and the plasma for even the exchange transfusion. So it's not even proven. Otherwise, scenario has been changed. We are using whole blood in our wards. Even the researchers says, because people are doing research, definitely use of blood product and other products that can be used as a blood, but they had no replacement or strong recommendation for component replacement. This recent trial study head-to-head with published in recently 2021 in American Journal of Surgery, that they say that 71% patient has used the blood component and only 30% around have the whole blood. If we see the mortality in hospital, mortality is very high, 16 versus 23% with use of whole blood. So this trial, they say that even after 50 years later, it's no replacement for component therapy. This trial has also shown, but they say that additional study is needed to determine the effectiveness of whole blood. That is published in 2020. This 2020 study also says the limited poor quality evidence, even trial are not there, how to compare head to head with the whole blood with a component, because component we have thousands of studies, but whole blood very few, and the selection criteria cannot be similar. Even last 3 or 4 years, they say most of the data say there is a logistic issue with the whole blood and not very good as to compare the component. But definitely, if we have nothing to save a life, anything that saves life is better. But if we have option to do the best, then the component therapy is there. Because we are not going to back our old Nokia phone, till then we don't have any other option. So we can save more life safely. That's my view of point. Thank you.
Thank you so much, Dr. Rahul. Dr. Balta.
Thank you, ma'am.
Yeah.
Thank you, sir. As a moderator, we are just like the speakers in parliament on a
You're losing your voice. So I believe, both the components have a role to play. Blood component therapy, yes, definitely. Dr. Palta, we're losing, your voice is breaking.
Ma'am, is it fine now?
Yeah, it's better now.
Dr. Kiran? So, Dr. Kiran, in one of your slides, you said that the one full fresh whole blood is equivalent to 8 to 10 units of platelets. So, can we say there is a
capability? It has a hemostatic capability of almost 8 to 10 platelets. So, if you give one whole blood, you can, in lieu of around 8 to 10 platelets, that is going to be its platelet and hemostatic capability, not equivalent to. So that is the meaning of that. And this has been brought out in studies. So if you have fresh warm home blood, it's going to be much more capable of coagulation and decreasing the trauma-induced coagulopathy.
Dr. Sandeep, would you like to counter this point?
Sir, definitely whole blood has a, with time the platelet are decreasing. So if we after day 5 we think, then the component platelet are very less even in whole blood. But whereas in component therapy, everybody knows platelet has 5 days life, so they will always keep prepare and be replacing. So whatever you give in component, it cannot be compared with the whole blood, because we have also, besides random platelet, the apheretic platelet option for giving when we only want to increase 50,000 of platelet, and that is the role of all type of mostly surgery and ICU, except in neuro and cardiac surgery where we want to keep one leg. Thank you, sir.
But sir, there is one point pertaining to this only, that if one whole fresh blood is equivalent to 8 to 10 units of platelet, is there a clue for this for the dengue management now? Dr. Kiran, please.
So dengue.
Where is the need to give apheretic therapy if 1 unit is equivalent to 8 to 10 units of platelets?
So there are other components in whole blood which are your red blood cells and your plasma. So that is what is going to help in the other parts of trauma management. So in trauma management, definitely you can use it for hemostatic capabilities, not as an entirety, not just for low platelet count in dengue. So if you're using it for trauma, definitely fresh whole blood is better, but not if you got one component which is low or something, then definitely you're going to go for component therapy. But in trauma, all components are low. So it is not that I'm going to give more platelets, less plasma, more PRBCs. The ratio is 1:1:1. So you might as well give whole blood. That's the point.
So I believe it is the location, the site at which you are operating will make a difference and the clinical scenario, of course. But what exactly are we working at will decide on how, because there is an issue about availability of component therapies within a limited time frame. So that goes perhaps in favor of the whole blood in combat situations. But if you are in a controlled setting of a civilian setting or an OR, perhaps component therapies score better than, if that is something I've said correctly. I'll hand over the mic to my co-chair.
Probably whole blood would be better if you have time constraints. So maybe that.
Anyway, it's okay then. Dr. Sandeep, there's a question for you. When you say that we have to go in for a multiple this component therapy, won't you think that you require multiple blood tests, and then for each component to be taken out, you require expensive machinery also for collection and separation? And in a resource poor country like this, will it be that much utilizable for you to defend this point?
सर, जैसे कि आप देखो पेट्रोल पंप पे पेट्रोल बिकता है और ब्लड बैंक में ही कंपोनेंट, आजकल जो ब्लड बैंक हैं, they are from the last 50 years they have evolved like this, that they have component separator therapy units even at your district hospital. So now the cost is not an issue because वो setup में उनके already inbuilt है और उसी से सिस्टम चल रहा है. दूसरा आपने सर टेस्टिंग की कहा, डेफिनेटली सर जब हम शुरू करते हैं ट्रांसफ्यूजन, अगर हम 1:1:1 कर भी रहे हैं तो वेयर वी शुड एंड, और उसके लिए हमें एक एंड टारगेट तो चाहिए. मैं ये कह रहा हूं कि आपके पास पॉइंट ऑफ केयर टेस्टिंग नहीं है, कोई बात नहीं, लेकिन जब आप अपने पैथोलॉजिस्ट को कहते हो मुझे एचबी प्लेटलेट आईएनआर आधे घंटे में दे दो, तो जो 15 मिनट में आपको पॉइंट ऑफ केयर टेस्टिंग से मिलता है वही आधे घंटे में अगर आपने अपने सिस्टम को ट्यून कर लिया तो वही 150 रुपए में आपको सेम रिजल्ट मिल जाएंगे व्हेन यू हैव टू स्टॉप ट्रांसफ्यूजन और व्हाट कंपोनेंट यू हैव टू गिव मोर.
Right, sir. Dr. Anju, thank you, ma'am.
Thank you so much. As we are running, my final comment, as we are running out of time, I would say that we still need more randomized trials to actually look at the data more effectively and recommend one over the other. Till that time, I believe each of them have a role on the different settings that we are working in, and of course, the availability of each of them. Yeah, thank you so much. And I think with this, we will move to the second pro-con session. Thank you, Dr. Sahu, and thank you, Colonel Kiran, for an excellent talk. Thank you so much.
Thank you, everybody. Thank you so much.
So we move to the second.
And I'll ask the chairpersons to introduce the speakers for the next session.
So the next session is thromboelastography and traumatic coagulopathy. And to speak for the topic is Dr. Kapil Soni. Dr. Kapil Dev Soni is an additional professor, critical and intensive care at the JPN Apex Trauma Center, All India Institute of Medical Sciences, New Delhi. Over to you, Dr. Kapil.
Thank you, ma'am. So, thank you. What I'll do is that I'll stick to my time limit and I'll put forward certain arguments which will make sure that that will prove my point. So before I begin my talk, I must explicitly state my bias that I'm sticking for the use of thromboelastography or viscoelastic acid more appropriately. These are my disclosures. I'm a co-investigator in certain trials and I don't have any off-label association. But I am beginning to talk with explicit bias here. So what do you need to know about viscoelastic acids are that there have been multiple studies and enough of data to suggest that point of care or the viscoelastic acids are the future of the trauma management. There have been slew of the studies which have proven this point. if you look at the recent guidelines which were released from the European societies as well as other trauma societies, they all advocate for the use of point of care test in management of severe trauma. So when I say a trauma, what I mean to say is about moderate to severe trauma. So my first argument is that the trauma coagulopathy is a complex entity. So what does it mean? It's not simply a bleeding disorder. It's a complex entity in itself. It's a dynamism which is associated with traumatic coagulopathy. A single patient can fluctuate in different ways. He may fluctuate from hypocoagulability to hypercoagulability in just a matter of minutes to hours. And he can manifest in different phenotypes. Means what we have seen in our own practice is that they may present with hyperfibrinolysis, with decreased thrombin generation, increased thrombin generation, hyperfibrinogenemia, all phenotypes they may present. So when we are talking about point of care viscoelastic acids, our job is to pick this changing behavior of the patient. We have seen all these in our practice. We find the patients presenting with thrombocytopenia, hyperfibrinolytic states. They are presenting with disseminated intravascular coagulation, and sometimes they are also presenting with mixed phenotypes or with thrombotic disorders. So they are very common in trauma. A single notion that they are always bleeding, it's only a bleeding disorder, it may not be true. My second argument is in the trauma, the time is the essence. We all know. And coagulopathy with the severe trauma presenting with traumatic induced coagulopathy, patients may land up in a triad, what we call as trauma triad of death. They have acidosis, they have hypothermia, and they all perpetuate coagulopathy very much. So time is essence. Whatever interventions we need to do, we need to try and do it very quickly, and we need to do it with precision. If we want to transfuse blood, we transfuse them very quickly. We want to pick the state of the patient, coagulation state of the patient. We need to do it very early stage of the management. Otherwise, trauma-induced coagulopathy leads a lot of mortality. Third argument is conventional tests do not differentiate between hypofibrinolytic states, or they do not pick hyperfibrinolysis. And what the studies have clearly shown that hyperfibrinolysis is a major killer. And if the patient is in a hyperfibrinolytic state after a major trauma, then the mortality increases very much. On the other hand, the point of care or viscoelastic acids, they capture this stage at very early stages, and goal-directed therapy can be instituted. Argument for these patients normally do not, though they may have a reduced platelet count, but most commonly they also have a platelet function disorder. It's not only the platelet count which matters, but even the surviving, the platelets which are there in the patients, they do not function at optimum levels. The studies have, or the models have clearly shown that these platelets become dysfunction very quickly. They tend to contribute to the traumatic induced coagulopathy. So a conventional test would not be able to identify platelet function disorders at very early stages. My fifth argument, traumatic coagulopathy is a dynamic disease. All the responses which are initially adaptive, they tend to become maladaptive at certain stages. And in certain patients, this transformation from adaptive to maladaptation can be very quick. And so whatever interventions or whatever tests we are doing, we should be able to identify or pick these changes at appropriate time points. Then only we would be able to guide or titrate our therapy to that. My sixth argument, most massive hemorrhage protocols, they tend to give 1:1:1. However, we all know today's era is about precision-based medicine, or what we say, individualized therapy of the patient. So we need to, whenever we are treating these patients, we need to individualize them. We need to identify what is the traumatic coagulopathy status of those patients, and that can only be done through the use of repeated point of care or viscoelastic assays. The good point is that you can do it in very short periods, whereas conventional tests, they will take some time to come back, whereas point of care can give you a real state within such a small duration of time. My sixth argument is about the evidence. If you look at the evidence, most evidence are basically from observational studies. However, recently there were two trials which were published. One was a single-center trial, other was a multi-center trial. A single-center trial clearly showed that there was a mortality benefit if your therapy is guided based on viscoelastic assays or point of care assays. However, there were certain issues. One was the the trial had a very small sample size. It was single center trial, and people argued that the same protocol may not be replicable to other centers. They were very experienced in using this viscoelastic assays. There was in-house algorithms for the transfusion. So that's why the therapy which was based on viscoelastic assay or a tag-based therapy, they had a better survival compared to the therapies which were based on conventional coagulation assays, and it was clearly shown. However, the next trial which was published, which was a multicentric trial, and we were very hopeful that this trial would throw up a major boost to the use of point of care. However, this trial was a big disappointment. It was an ITACTIC trial. It was a multicentric done in 7 UK hospitals. This was the trial gave a message that the standard of care is delivered. It able to achieve the standard of care with empirically balanced hemostatic therapy and intensive conventional coagulation testing. Then viscoelastic assays did not improve clinical outcomes in intention to treat cohort. Now this was a big message. So what we did is that we went through the trial, we did a critical appraisal of the trial. What we found that there was a major hypothesis that the VHA augmented protocols would improve the mortality overall, and that would also reduce the need for massive transfusion the first 24 hours after injury. And both looked quite probable. But however, if you look at the results, the diamond or the overall results, there was not much of a difference. However, there were certain groups, specifically the severe TBI, if you look at they were able to achieve better, reduced need for massive transfusion in 64% of TBI, whereas it was only 34% of conventional assays. So in that sense, there was some trend whether it will improve the use of blood products. Most importantly, the mortality. If you compare the mortality, though there was not a statistically significant result, but there were certain subgroups which clearly showed there was a benefit of mortality. And we thought why they were not able to identify or they're not able to identify the difference, though there was a clear trend that the VHA therapy was better. Now, nothing seems perfect, and that's the only perfect. I can take the authors do not draw that conclusion that there is no role of VHA used in traumatic hemorrhage. This was not the conclusion they have drawn. What happens is, if you look at the sample size, if you narrow the sample size too much, you would be able to achieve the results. If the sample size is not good enough, most studies will not be able to show the results. So there were certain issues with ITACTIC. They were they screened almost 1,300 patients, but only around approximately 500 patients were eligible. So there was a problem of generalizability. Then the severely injured cohort was only 28% in CCT and 26% in VHA group. They intended to include only severely injured patients, but they were not successful. There was low occurrence of trauma-induced coagulopathy. There were 75% did not have actually prolonged PTR at this, and they did not have actually the trauma-induced coagulopathy. Only 25% they had a trauma-induced coagulopathy in the cohort. And no data, traumatic, we all know it's a heterogeneous process. There was no data on the proportion of patients who underwent surgical bleeding or who required intervention radiology. So most problem was that even with the per protocol analysis, there was 21% who were excluded and they could not contribute to the study. And that's why, despite being major trauma centers, most did not have VHA guided transfusion at time of study initiation. They were not experienced in providing the therapy. Transfusion thresholds were based on the same results for conventional testing, and this is a circular argument. So they did the same thing in both the groups, and that's why both the groups were not able to show any difference in the outcome. Though the trend was clear, and we are pretty sure if they could have gone on to recruit more patients, they would have seen the difference. In summary, I can summarize my argument. Viscoelastic assays, they are point of care dynamic tests that depict the changing coagulation profiles of the patient. The short turnaround time means the higher precision of therapy, and the evidence is evolving. It's important that we continue to do better quality research before we judge the utility of intervention. Thank you so much.
Thank you, Dr. Kapil. May we have the next speaker, please? The next speaker is Lieutenant Colonel Shyam Paul. Sir, I invite you to present your talk now.
Am I audible?
Yes, sir.
I'll just share my screen right now. Good afternoon, everyone, or early good evening from the Armed Forces Medical College in Pune. And thank you, chairpersons, for having me here. A special thanks to Dr. Kajal and Dr. Jitendra, who has invited me to speak here in this illustrious hybrid conference. And I had the privilege of serving in several peripheral and tertiary care hospitals all across the periphery of the country. And when this topic came to me, I was a little foxed. Why? Because I was speaking not for a technology which I believe to be very helpful in the management of trauma-induced coagulopathy. So I did some literature research and I had a change of view myself. So to introduce first, I'd like to go through the guidelines of major trauma by the Ministry of Health and Family Welfare. That states that India is a country that is second most populous, and we all know that increasing the trauma load, it accounts to nearly 20% of the global injury, and more than half of these deaths can be prevented by improving trauma services, developing guidelines, and investing in resources. So this is a country, you see, with 1.3 billion people, and we have got a hospital beds of 1.9 million, and ICU doctors who are trained in ICU doctors are about 5,000. This was pre-COVID era. So during COVID times, a lot of ICUs have sprouted up. I don't know what the quality of care is, but this is the actual care that is we are giving to our residents of this country. Now, this is, as Dr. Soni just told, about the immense cascade of biochemical and hematological reactions that has got a lot of phenotypic variations, adaptive and non-adaptive variations, and a major trauma. How does it cause trauma-induced coagulopathy? I won't reiterate it again, but I like to say the only way we can save lives is by prevention of coagulopathy, hypothermia, and acidosis, what we call lethal triad. We all know that. Now, to summarize, what is a good diagnostic test? So, good diagnostic test is that has to be beneficial for the person subjected to it. It has to prevent contradictory and confusing test results and prevent overdiagnosis and unnecessary burden and costs, and targeted investigations for improvement of health care of the patient. This is the meaning of a good diagnostic test. It should have a diagnostic sensitivity, a good specificity, a positive predictive value, a negative predictive value that is not so, and of course, a good likelihood ratio. Now, this is the article which I have just referred to, which states, and these are the findings. You see, in a patient of acute traumatic brain injury and he's having coagulopathy, this is the prothrombin time, activated partial thromboplastin time, and INRs, which are normally routinely used. So the p-values are less than 0.001. And when you compare the same as with a TEG or any viscoelastic testing, the R time, and that of the maximum amplitude and the lysis is not statistically significant. The sensitivity and specificity is also quite low as we are talking about point of care testing according to this article. The sensitivity is around 64% for kappa time and alpha angle is around 62. Similarly, specificity is ranging from 40 to 46%. Positive predictive value is around 75%, a negative predictive value around 33%, and a diagnostic accuracy of just around 60%. While we know that our prothrombin time and INRs are validated with and time-tested method. This study concluded that TEG cannot be replaced by conventional coagulation assays for identification of acute trauma-induced coagulopathy. So the effective what is effective testing? That is to help in the clinical outcome. Case control studies overemphasize the diagnostic effectiveness, so we require RCTs, which we don't have. And it's rare to find evidence that proves that testing improves patient outcome directly. There are a lot of variables in between. So what is the evidence? I'll just go through one by one because I have a limitation of time. So this article clearly states, though, that the TEG is a rapid test, but it doesn't have any significant importance as far as saving life is concerned or outcome is concerned. The Cochrane Library, Pandora's box, where we have got a lot of a lot of data as far as TEG and rotem trauma-induced coagulopathy in adult trauma is concerned. And this is one of those references which articles I have referred to, which states that TEG and viscoelastic devices should only be used for research purposes. Similarly here, in this article, which is also in the Cochrane Library, states that TEG and rotem are only for research, and a robust prospective randomized control study is required to compare TEG rotem to PT-INR. There are a lot of limitations to viscoelastic testing, which I'll refer as VET. This includes, as this article states by Dr. Govil, is that number one, TEG and rotem testing cannot be reflecting the contribution of endothelium to coagulation. Moreover, this is a very dynamic process. Every time the state of the body hemostasis is changing. So you cannot take one test and say that, okay, now this is what it is, and you're paying money for it, a huge amount of money. It is insensitive to aspirin and clopid and has decreased sensitivity to GP2B3 antagonist. The sensitivity and specificity is low, as I just mentioned, and the device requires calibration, and by trained personnel, that also costs money. There are other articles to it also, like this article that says the constraints of the viscoelastic testing. Manual pipetting is required in various other, not all equipments, but manual pipetting is required. That gives rise to a lot of confounding errors. There is interlaboratory variations. The vibrations on the surface, it's expensive equipment. Vibration on the surface do cause a lot of changes, and it has to be kept in a place, maybe in a trauma bay, but in a place that has to be secluded, and there should not be any vibrations. Citrated blood samples in the lab-based TEG analysis requires a resting time that delays in decision making. And decision making is a very, very specific job by a very trained person, while INR and prothrombin time anybody can interpret. Okay. Now, the fifth result shows that they are affected by age, gender, hematocrit, the platelet count, the prior infusion of colloids and crystalloids, and of course, mixing of blood with kaolin. That is an activator. There is a negative charge like endothelium. It activates the coagulation pathway. All are confounding factors. TEG results have to be interpreted properly when there is severe anemia, thrombocytopenia, and hemodilation. This study states that TEG is not a substitute for conventional coagulation assays. Rather, it complements the results of conventional coagulation tests. Now, this Canadian journal, they have got this entire database that states that there is cost effectiveness, which people say, because they say that if you go on a TEG approach way or a viscoelastic testing approach way, then you give less amount of blood products. So the cost effectiveness is there if you are using TEG in all your centers. But in Canada also, they found out that this is not true. A critical appraisal in this review article states that you may have a faster test, a rapid test, but that does not translate into a better outcome. When major obstetric hemorrhage was analyzed in this journal, TEG has a faster result. We all know that. Normal TEG will take about 5 to 10 minutes, while a lab investigation might take about anything between 30 minutes to 1 hour. But the lab test directly correlates according to the estimated blood loss, whereas TEG doesn't. Effect of age, gender, ethnicity, different phenotypes. Every person, every ethnicity will have a different reaction to the TEG. So it is important to derive the reference range of the target population before using the TEG into clinical practice. And hypothermia. TEG warms the blood to 37 degrees centigrade before it actually analyzes it. So in hypothermic condition, they are known to have results which are not accurate. So as a professional, I like to give alternate to TEG or a vascular testing. That is a point of care INR. The point of care INR has been seen to have, it's first of all economical, it's very cheap, and it gives a result faster than a lab, and though little maybe a minute or two later than TEG. And it has been seen that a point of care INR testing is faster and cheaper, and is in better testing as far as severe acute trauma settings are concerned. And I did some literature search. It's from Bible of pathology, the tides in which they have mentioned the point of care, prothrombin time and INR testing equipments that are available in the market. And it's far more cheap than a TEG machine, and it can be used easily. So this is my conclusion. And before my conclusion, I like to go a little bit according to the evidence-based lab medicine guidelines, which has got various steps. How do you go from idea to innovation to implementation? Now this orange line, orange circle is where our TEG is. We don't have adequate robust data suggesting the use of TEG or viscoelastic method of analyzing of blood coagulation. Till date, there's no randomized control trial. So we are still a little behind. And this is the world data, right? India is far behind this. There are a few questions to be answered. How long do we take to get, monocomponent therapy? Our previous speakers spoke about it a lot. But believe you me, I've been in many hospitals, and we don't have monocomponent therapy in the peripheries, no matter whatever the general view is. What about administration of monocomponents in the Western environment? We use TEG for administration of monocomponent therapy. But actually speaking, the role of whole blood is back. And if you have got whole blood, there's no role of TEG because you give all the components together, so you don't need to analyze TEG. You can just do with a routine testing. And one more important thing is the pre-hospital administration of tranexamic acid, which is widely used all across the US and UK and in Europe also, where at the moment where the patient is received by the ATLS team, they are administered tranexamic acid as early as 30 minutes before the patient reaches the triage of a trauma center. So are we waiting for the TEG results to come before we give tranexamic acid, fully knowing that the trials say that it has to be given within 3 hours? And of course, cost. Cost is a factor which a country like ours need to understand. I'll go back to the guidelines again. That is mentioned by the Ministry of Health and Family Welfare. And I'll reiterate the preamble. The preamble states that deaths can be prevented by improving trauma services, developing guidelines, and investing resources. With this in mind, I'll go to the PICO framework of the evidence-based lab medicine. Now, what is PICO framework? PICO framework gives an idea. We ask relevant questions when we try to understand a topic. It is patient problem, intervention, comparator, and outcome. Now, what is the problem of the patient? What is the problem of the patient? The problem of the patient is the patient coagulopathic? For this, we run a lab test for either screening, diagnosis, monitoring, or prognosis. The intervention which we commonly do as an intervention, as an investigation, is a conventional coagulation test. Mind it, I'm talking about lab. I'm not talking about the clinical intervention till now. And the comparator which we are talking about should be replacing or adding is a viscoelastic test like a VET or a ROTEM. So question 1, can VET be used as a triage test? That means if we use as a triage test, we label a patient coagulopathic or non-coagulopathic. Question 2, can the test be so good, the test comparator is so good that it replaces the earlier test? And question number 3, can this be an add-on test to the already existing coagulation test or conventional coagulation test? The outcome which I have come to after going through a lot of literature is VET cannot be used as triage. You cannot, because first of all, availability is not there. Second is the economics. Third is the sensitivity and specificity is not up to the mark, which has already been there for a long time for the lab tests like prothrombin time and INR, which is validated again and again. No guidelines are there except for some European guidelines and coming up American guidelines about the use of TEG in their population, not in ours. So can we actually use it? Now, VET it can be used as an add-on test, and I'm not against VET. As I told you, I was for TEG before I started this, reading about it. So I've been disillusioned by the immense the amount of work I've done by reading about. So it can be an add-on test in a resource-rich setting, and in the initiation of massive transfusion protocols, they're giving monocomponents. And of course, the point of care INR testing can also be a suitable alternative. My verdict is as follows. My verdict is TEG does not have any role in most of the scenarios except acting as an expensive gimmick, only meant as an adjunct to conventional coagulation testing and in research purposes in selective resource-rich tertiary care hospitals. Thank you.
Thank you, Dr. Paul. Is the other speaker, and Dr. Kapil is also there, right?
Yes.
Dr. Kapil, how would you like to give a rebuttal to him?
So,
his last line.
Yeah. So what I can say is that my dear friend needs to rerun his search again. There are two articles which I already quoted. One is clearly in favor, other showing trend. Definitely we need more evidence. There is no doubt about it. But what I see is that it's going to be if any intervention which improves the outcome, specifically in a severely injured patient, then we should research more, and if it comes in the practice, definitely it's already there in a liver transplant, it's already there in a cardiac surgery. Trauma is going to be the next field where you will see more and more use of point of care tests, and hopefully it will translate into better outcomes. That's all. At the end of the day, what you want is patient surviving, and if you can improve the survival of your patient by any means, that's the ultimate game. Yeah.
Thank you, Dr. Paul. Yeah, I think there were some issues with the audio of the online for us. However, having said that, one of our contentions is the availability of TEG at all centers, especially at level 1, level 2. So that would be an issue. And then having the machine ready and operational, and of course, costs and logistics would definitely be there, though there is a role to play for TEG. And maybe in coming times, and this is perhaps a technological advance and a research question for our younger generation, to perhaps have some devices that can overcome these limitations and make it much more easier to be used as point of care testing. Dr. Shamik Paul, my question around is that, if you were to use the conventional tests, there is an issue about the turnaround times, and they are indeed static, So how do we really validate their superiority over a dynamic test?
Ma'am, as you said rightly, and I totally agree with Dr. Kapil that TEG is an upcoming thing and it is the future. I don't have any doubts in it. But as today, as our country is concerned, it is not a viable option, number one. Number two is, ma'am, I mentioned about the point of care INR testing. A point of care INR testing is a very good test that is far cheaper than TEG. And that can be installed in trauma base, and we can find out it's already validated. So, and it can give us a dynamic assay if you keep on doing POC INR testing in 5, 10 minutes, 15 minutes, you can get a good outcome, and it will collaborate with the lab tests which we are sending at the turnaround time for a lab PT INR will take around 35 to 40 minutes. In a good lab, in a faster lab, low outflow, maybe about 20 to 30 minutes. But a POC testing will be done of INR within 10 minutes. I think that is my take in this one.
So if we have some time, do we have any questions from the floor in the auditorium? No? Okay. So I think with this, we'll perhaps say that we still, both the pro-con session, as my, we are still not able to find a clear winner between the two. Yes, both of them do have a role, and we still need to evolve into this field. But I do believe that TEG is something, the future of our management, and if it does help us to improve our patient and clinical outcomes, we should be starting to incorporate them, especially in our level 3 centers. So with this, I hand over the mic to the organizers. Thank you, Dr. Kapil and Dr. Shamik, and also Dr. Sanjeev Palter for co-chairing with me. He's having some problems with the audio. So on his behalf, I thank the entire team of today's conference, especially Dr. Kajal, Dr. Jeet, Dr. Nidhi, for inviting us over, and thank you all.
Thank you everyone for a wonderful pro-con session. Now we move on to our next session, which is a 10-minute consultation. I would like to invite the chairpersons on board.
A slide.
Hello.
I'd like to invite Dr. Vikas Saini, Additional Professor, Department of Anesthesia, PGI. He has multiple publications in index journals and areas of interest, ultrasound use in anesthesia, in critical care and intensive care. Welcome, sir. I'd like to invite Dr. Banashri ma'am, Additional Professor, Department of Cardiac Anesthesia, PGI Chandigarh. Areas of interest, anesthesia for pediatric surgery, cardiothoracic surgery, and use of TEE in patients undergoing CABG. Welcome, ma'am. I would like to invite Dr. Richa Sarova, Assistant Professor, Department of Anesthesiology, GMCH 32 Chandigarh, with areas of expertise in obstetric anesthesia and pediatric airway. Welcome, ma'am. I would like to welcome Dr. Kapil Soni, Virtual Chair, Additional Professor, Critical Care, JP and Apex Trauma Center, AIIMS, Delhi. Areas of expertise in trauma research and trauma critical care, with multiple papers in national and international journal. Welcome, sir, on board. I'd request the chairpersons to introduce the speakers. Thank you.
It gives me immense pleasure to invite Dr. Nusrat Shafiq. She is going to speak on interpreting cultures in trauma intensive care. She is professor in clinical pharmacology unit, and she has a lot of experience in developing and implementing tools, models, guidelines. She is also involved in antibiotic stewardship program in our hospital. And ma'am, please stick to 10-minute guidelines, 10 minutes.
Thank you, Chairperson, and thank you for highlighting the 10 minutes is all the time I have for discussing 4 cases there, which were presented by our anesthesia consultant, Dr. Kajal. At the outset, I would like to thank the organizer. Let me just keep it very brief. Can we have the slide show on, please? Yeah, so it's very heartening to know that you all are considering this as an important consideration for a conference like the one that you're having over here. Can we move the slides forward? Yeah, so the first case here is that of a 30-year-old trauma patient who is brought unconscious with a history of head injury. There is a record of fever in trauma triage and a history suggestive of vomiting at site. Question: should cultures be sent? Should antibiotics be started? So 2 important things to be considered over there are fever and a history suggestive of vomiting. So probably they want to point out a possibility of aspiration. So aspiration, I understand, would have definitely occurred. These slides. Yeah, so the slides, yeah, aspiration, definitely we'll have to go by what the history says, and we would consider this possibility, definitely. But important thing is the fever because of, is a consequence of aspiration. So as a consequence, we can have both aspiration pneumonitis and aspiration pneumonia. Fever alone itself would not be a good indicator. We would need more information. So what is the kind of information that we need here? So there is some difficulty, but I think since time is more important, I think I'll just continue with my presentation while they figure out what's going wrong with the slides there. So we need to see more signs of inflammation, leukocytosis, perhaps some respiratory signs and symptoms that would be important. Radiological signs, new onset infiltrates, especially in dependent positions, if depending on what the original position of the patient was, would be more informative. So on the ground, let me accept that distinction between aspiration pneumonia and aspiration pneumonitis would be rather difficult. It is the time course which would be helpful in guiding us more. Its aspiration pneumonitis would be more of a fulminant, very quickly starting process, while aspiration pneumonia would be more of an indolent course. If we do not have much of this information, I think it would be prudent to can somebody please sort it out? Yeah. No, it's not working. That's what I'm saying. So, in any case, if it is the time frames that we have to understand, and if all that is not very clear, we are on the side of making a judgment of aspiration pneumonia. Aspiration pneumonitis would have resolved within by good supportive care within 48 hours. If we are able to buy time, for example, in this situation where the condition is largely, the only indication there is for suspecting infection is possibly fever. And beyond that, we don't have much information. We could perhaps buy that time. So this is why I repeatedly would be emphasizing on time aspect. So time, they say you can buy time, so you could possibly wait. But if there are other indicators to suggest that the patient's condition is not all that good. And I think we should not be wasting too much of time on making all these distinctions and waiting. Then we could start with antibiotics. You wouldn't be erring too much if you did start. So which are the antibiotics that you will start with? If the event has occurred in the community setup, I mean, prior to where the patient was brought or in the triage early in the course of admission, then we consider community acquired pathogens, which would largely be commensals in the oral flora, and it would comprise gram-positives and anaerobes. If it is much later, it has occurred in the hospital setting, say 48 hours after hospital setup, then we could even possibly consider hospital-acquired pathogens. Depending which of these it is, then we consider it to be, we make a choice between amoxicillin clavulanic acid, and if you're not happy with it, we can even stretch it a little and make it to clindamycin. If it is in a hospital-acquired setting with the possibility of hospital-acquired organisms being involved there, then and that would not come from the patient's own flora unless the patient has been intervened repeatedly, then we would go for higher antibiotics. The next question was about sending the cultures. So cultures, can we have the slides moving, please? Yeah. Are cultures informative? They would inform to some extent, but we have to understand that anaerobes are rather difficult to grow. So which sample should you send? At best, you can send tracheal samples. So there are more aspects of this condition which need to be discussed, but I think we can move on to the next case. The next case, please. Case number 2. Yeah, so this is a case of a 36-year-old male who is received from triage after 3 days of boarding there. That's important. Patient is received with esophageal intubation, so that is important too. Following intubation, you take purulent secretion. Patient is afebrile and has a TLC of 9,000. Should I send tracheal culture? Can I start antibiotics? Which one? So here we go. So we are keeping in mind a probability of HAP, VAP, aspiration pneumonia goes down because by mistake it was esophageal intubation. But if that can be a possibility, you do not know how many attempts would have been made. So aspiration pneumonia also stays a possibility. So patient has spent more than 48 hours in triage. So classical definition of HAP could fit in, but perhaps not of VAP because we never had the trachea being traversed. But irrespective of the semantics, we would consider them as one entity only. It is important to understand that purulent secretions would alone not be enough to say whether we are dealing with a pneumonia at all or not. So there is a very important history which is suggestive of a high likelihood, but we should also take into consideration, may we have the slides moving please, oxygen requirement, chest radiography, hemodynamic stability and other indicators for sepsis. A good guide is clinical pulmonary infection score, which is a 6-point score, and for each one of these components has a scale of 0 to 2. And if the score is more than 6, then the possibility of VAP is high. It has its own issues. It is high sensitivity but low specificity. But our respiratory ICU is using it routinely, and they have been able to rationalize their antimicrobial use considerably based on this scoring system. So what I suggest is that for this case, you need to have more additional information. Tracheal cultures, yes, definitely. Cultures should be sent prior to starting the antibiotics, should the antibiotics be started. A purist approach would be wait, but I believe that would be seldom followed. Then if at all you take a decision for giving antibiotics, I would say even still make a very intensive attempt to classify it as pneumonia or based on more grounds than just purulent secretions. Depending on the site from where you believe the infection to have occurred, you could make the choice of antibiotics. If it is our triage, though Dr. Kajal would choose to disagree, we do have MDR pathogens there, but it is still not that big a problem as it is in our ICUs and OTs. So I think piperacillin tazobactam as an initial starting treatment would be fine. If there are indicators of hypoxemia, hemodynamically instability is there, then we could go to a higher end antimicrobials, and depending on the microbiological flora of your hospital, you could even consider in such situation with hemodynamic instability, considering polymyxins. Important question is, do you add vancomycin or not? I suggest if only there is septic shock, MRSA, at least in our hospital, is not too much a problem as far as pneumonia is concerned, barring a few ICUs. And so it's important to review after 48 to 72 hours. Can we have the next slide case, please? Now, this case was very interesting. A critically head injured patient in intensive care is afebrile on day 6 of ICU stay following initial fever on arrival. The microbiologist tells later in the day that a gram-positive cocci is growing in the sample and it is in clusters and clumps. You review the patient who is well and afebrile, and you ask the consultant what is the significance of this positive blood culture and should antimicrobials be started. So I think this is a very, very real case. I think I remember it too. Can we have the slides? So possibility of organisms should immediately run into your mind. These could be staph, including your cons and streptococcus. Patient is important, that is stable and afebrile. So I would suggest no change. So let's just twist the scenario a little. If the patient were stable and febrile, then what would you do? I would wait for the organisms to be identified. It wouldn't take a long time, and tailor antimicrobials accordingly. But before doing that, send a repeat culture. If it is a cons or something, I can just suffice by sending a repeat culture and being doubly sure. However, if the patient was unstable, irrespective of fever present or not, what we would do is add vancomycin if not given on already tailor according to full report. If cons, send a repeat culture and source control if warranted. So basically, it is a clinical scenario in totality which would need to be taken into consideration. We come to the next case. This is a case of 49-year-old male with penetrating injury on ventilator develops high-grade. It was abdominal penetrating injury of the abdomen on ventilator develops high-grade fever. On day 5 of the ICU stay, he becomes hemodynamically unstable in next 2 hours. The clinical suspicion is suggestive of abdominal sepsis. What should be the next steps? So this is again a very, very real case that we see quite often. So intra-abdominal infection with sepsis is definitely a high possibility. But we cannot ignore considering the fact that the patient has been there for 5 days in ICU, other HAIs that have to be taken into consideration. We would need to send appropriate cultures and look for any collections. The possible organisms early on the course of illness, they would have been E. coli and anaerobes only, but now that the patient has already stayed in the hospital for 5 days and must have gone several interventions, then you have these MDR pathogens that we all dread, which are a possibility. It is important to know their antimicrobial susceptibility. For example, over the period of time, we understand our susceptibility patterns. For our setup, I'm emphasizing, considering the fact many of you are not from tertiary care settings and there the situation may be different, it would be colistin, vancomycin, and metronidazole. That would be an empiric regimen. Source control would be of utmost importance here. But it is very important to modify according to culture reports and other infected sites. Now, the twist happens here. The twist in the story happens here when a few days later you get cultures which are reported as sterile. Patient continues to be status quo, or even worse, may worsen. What should be done? Antifungal, do you add antifungal? Do you add antibiotic, or do you de-escalate? It is easy to de-escalate, say that you should de-escalate, but it is rather difficult to do it. So preemptive antifungal use does not have evidence. I say lack of evidence. I'm not saying evidence of absence of benefit there. Over the period of time in certain ICUs, working with those ICUs where antifungal use was high, looking at their own data and their outcomes of patients, we have been able to cut down the unnecessary use of antifungals, but it has to be ICU to ICU and patient to patient decision. Adding another gram-negative cover, evidence does not support, clinical evidence does not support it. De-escalate, yes, you have certain tools with you, biomarkers. If there is an alternative explanation which may have emerged by now for considering the worsening of the patient, then those are the only two situations where you could de-escalate. But I'm telling you, on the ground, it may be very difficult to do so. I'm just coming to the last slide. May I have the next slide? So this is the last slide. Do I have your permission to go, considering the fact there were technical issues? Yeah. So important take-homes would be assess patient in totality while looking out for focus of infection. We must have an idea of time frames. And in fact, under Dr. Kajal's guidance, Dr. Prerna carried out a very beautiful exercise in evaluating these aspects from triage to ICU. The possible organisms that may be involved. It gives you an idea about possible organisms. It tells you what could be the foci of infections. And then most importantly, how much time you can buy. So it gives you a lot of idea about that also. You must pay attention to turnaround time of the lab. If your report is going to come in 5 days, patient is worsening, you must start the treatment. Know your patient and organism profiles. I've seen ICUs which do it very diligently. Over the period, they have really been able to rationalize their antimicrobial use, and even without compromising on the outcomes. And in some cases, outcomes have improved too. Generate and analyze your data, evidence, and develop algorithms which are based on your own local practice setting. So this is the most important things. Don't borrow practices, just learn from them, but generate your own algorithms. Keep in mind that not every new inflammatory response requires antibiotics, and fever is an anti-inflammatory response. And not every culture requires treatment. Dose and other pharmacokinetic consideration, for example, penetrability of an antibiotic in the site of infection may be more useful than adding more antibiotics. So these would be some of the points. With this, I would be happy to take questions, perhaps at the end of the session. Thank you. Thank you.
Take questions at the end of the session.
Thank you.
So what could be better than coming facts from the horse's mouth? So next speaker is Dr. Kamal Kajal. He is an associate professor in the Department of Anaesthesia, PGI. He is a learned person in his own field in critical care and liver transplant anesthesia. Welcome.
Very good evening to chairpersons, faculty, and delegates. So I will be discussing briefly in the next 10 minutes regarding how to interpret lactates. So as we all know, lactic acidosis is one of the most common metabolic acidosis that happens in intensive care units. So next slide, please. Yes. So as we all know, lactic acidosis is one of the most common metabolic acidosis that happens in ICU settings, and as well as, happens in trauma settings as well. So briefly, I will just have a few slides on the physiology. As lactate levels normally less than 2 millimole per liter. Any value higher than 2 describes it as hyperlactemia. And when the serum lactate level concentrations are above 4 millimole per liter, then it is described as lactic acidosis. And if you see the acidosis mostly is of elevated anion gap, but moderate levels of lactate often is associated with the normal anion gap as well. Next slide, please. Next slide. Yes. So you can see you all know where the lactate is produced. Basically, the glycolysis that happens in the cytoplasm, the glucose is converted into pyruvate, and that pyruvate has actually two outcomes. One outcome is that it can be converted to pyruvate acetyl coenzyme A by pyruvate dehydrogenase enzyme that enters into Krebs cycle and generates ATP, that is oxidative phosphorylation. And the other pathway is the pyruvate is converted to lactate by lactate dehydrogenase enzyme. So as you see the right side of the screen, whenever there is increase in the glycolysis by the processes, that is physiological stress, catecholamines, or whenever there is a lack of oxygen, so there will be a diversion of the pyruvate towards lactate. Next slide, please. So there are three main pathways. One for the enhancement in the lactate levels. One is the enhanced glycolysis. Next, and when there is a blockage in the pyruvate diversion to the Krebs cycle. So next slide. So generally it is classified as two types. One is the type A lactic acidosis, other is the type B lactic acidosis. Type A generally is associated with the poor tissue perfusion, and it could be global and the regional one. Global, we have shock, systemic shock, and the other are the regional that may happen in trauma settings, localized limb ischemia or the compartment syndrome. The other is lactate accumulation, that is absence of any clinical evidence of the tissue hyperperfusion, that is type B lactic acidosis. Next, please. So coming to the clinical case scenarios. So this is actually a single case where we can witness all the causes for the lactate elevation. So this is a 44-year-old male patient presented to ASOPD with history of roadside accident with blunt trauma abdomen and with long bone fracture lower limb. GCS, conscious oriented vitals, hypotensive, tachycardia, room air saturation was 97%, chest examination, CVS tachycardia, patient has cold and clammy limbs. Next slide, please. Primary survey, airway was patent, breathing, tachypnea, circulation, tachycardia, low volume pulse and delayed capillary filling time. Patient was alert and there was an exposure, open fracture of left femur. Next slide, please. So this was the routine examination was sent, and this was the EBG. So looking at the EBG, next slide, please. You can see this is pH is low, acidosis, bicarbonate is low, predominant metabolic, and lactate is high with low hematocrit and the high anion gap. Next slide, please. Next, please. Yes. So this is the echocardiogram. As you can see on the right side, the patient is having kissing ventricles, and the IVC was diameter was low and collapsibility index was high. Next slide, please. Next. So the variables hemodynamic data, CP low, cardiac index was low, mixed venous saturation, central venous oxygen saturation were low, dynamic indices were high, SVR was high, and IVC was more than 50% collapsible. So any guesses from the audience what type of shock it is? So next slide, please. Next. So it is hypovolemic shock. So fluid and blood resuscitation was given using appropriate targets. As you can see, after resuscitation, lactate levels return to normal. So this probably is the cause related to the low tissue perfusion. So that has resolved with the fluid and the blood resuscitation. So patient was planned for surgery and intraoperatively patient did well with stable hemodynamics. Next slide, please. So as the patient is having open fracture, so POD 5 patient 12 high grade fever, again hypotension, tachycardia, decreasing urine output, local examination, wound unhealthy with purulent discharge. ABG again showing metabolic acidosis, predominant elevation is lactate. Next, please. Next, please. So, stop, yes. So this is stop the slide. Stop. Yes. So this again is a hyperdynamic echo. If you can see, along with again IVC is collapsible. Next slide, please. In this, the variables obtained hemodynamic data. You can see the cardiac index was high, PCV, pulmonary capillary wedge pressure, CP are low, dynamic indices are high, mixed venous saturation almost normal, and center venous saturation is normal to high. IVC again is collapsible and less than 2.1 centimeters. So any guess regarding the type of shock this patient has? So this is septic shock. Next slide, please. Septic distress. So there are two main mechanisms for the elevation of lactate in this case. One is the hypoperfusion. The second is impaired utilization of oxygen, as happens in sepsis. Because of inflammatory mediators, they actually block the conversion of pyruvate to the lactate in this case. Next slide, please. So the blood and wound swab cultures were sent and source control achieved through debridement. Appropriate antibiotics were initiated. As you can see, this is the recommendation of the latest surviving sepsis guidelines, where they suggest measuring blood lactate in patients suspected of having sepsis. But although it is a weak recommendation with low quality of evidence, but definite high quality evidence is to start antibiotics as early as possible whenever you suspect strong suspicion of sepsis. Next. So POD 8, the patient condition deteriorated further with again a very high unstable hemodynamics, with patient on high vasopressor support and fluid resuscitation. Again, there is impairment in sensorium, increased work of breathing and decreased urine output. Patient again presented with metabolic acidosis, predominant lactic acidosis. Next. So the patient is having echo showing global hypokinesia biventricular, along with IVC diameter more than 2.1, non-collapsible. Next. Patient again cardiac index having low, mixed venous saturation low, CVP high, PC pulmonary capillary wedge pressure high, SVR high. So can you guess the type of shock? So this is probably cardiogenic shock. So this next slide, please. So this is cardiogenic shock, probably septic, sepsis related septic cardiomyopathy. And next. So pan culture send restriction of fluids were achieved. Dobutamine or ECMO was considered to enhance the oxygenation or stroke volume, and the lactate again dropped from 9 to 3, but still the metabolic acidosis is persistent. So what could be the likely cause in this case? So this patient may have other cause of high anion gap metabolic acidosis, that is due to renal failure, AKI. Next. So patient was having AKI, so dialysis was started. And next slide, please. So the POD 10, the patient again showing new symptoms, new onset jaundice, worsening sensorium, persistent oozing from blood from ET secretion vascular line. Routine labs were sent, serum bilirubin 8, and enzymes were high, AST, ALT, INR 5, and PTI were 35%. Again, the lactate was high 9 with predominant metabolic acidosis. So can you guess the likely cause in this case right now? So next slide, please. So it could be the liver failure, and in the liver failure, the most likely cause for lactate elevation is the impairment in the lactate utilization. So this is or the lactate clearance per se. So next slide, please. So other case scenario is different from this case. So this is actually a 56-year-old male patient with type 2 diabetes on irregular medication, presented to ER with 10 days history of fever and 4 days shortness of breath. RT-PCR was COVID positive, and conscious, vital, stable room air SpO2 86%, mild derangement in sugars, ABG normal, PO2 59, lactate was 4. Next slide, please. So oxygen supplementation were achieved through ventimask, dexamethasone, remdesivir, insulin were started, and lactate then reduced to 2 in a couple of days. By day 4, we started to switch the insulin to metformin for long-term sugar control. By day 8, patient showed normal oxygenation but again the elevation in lactate to 4 millimole per liter. So this is actually a type of lactic acidosis that is type B because of the drug metformin. So in this case, if you can look, the initial elevation in lactate is because of the low oxygen, and later on because of the initiation of metformin, so then we switch the oral hypoglycemic metformin to vindagliptin in this case, and we have reduction in the lactate levels. Next, please. This is very useful flow chart that is recently published in one of the studies in intensive care medicine. We looked at if the lactate level is more than 2 millimole per liter, and if you are suspecting strongly that patient has sepsis, then you should need 3 parameters to assess. One is the central venous oxygen saturation. If it is low, then you should increase the cardiac index, and then there is obvious reduction in the lactate. And if the patient has normal central venous saturation and has strong suspicion of sepsis, you should look for the signs of peripheral perfusion, like mottlings and capillary filling time. And then if it is normal, then measure the dpCO2. So this dpCO2 is basically a difference in the CO2 between central venous blood and the arterial blood. So if it is more than 6 mm of mercury, then you should increase the flow to make it less than 6. And if it is less than 6, then you should look for the other causes of the elevation in lactate. Next slide, please. So again, this is very useful L algorithm. If you can see, lactate actually points towards the pathophysiology, but you should corroborate the final pathology with the help of other hemodynamic variables like central venous catheter, echocardiography, and dynamic indices using arterial catheter. Next slide, please. So this very important question is, does linger lactate we use as a resuscitation fluid can affect the serum lactate level? But so far studies demonstrate that there is no effect by use of the ringer lactate. And in fact, the buffering effect of ringer solution may have a positive effect on blood pH because it has more physiological strong and difference. Next slide, please. So lactate as a marker of, every time the lactate is elevated, it is not a sign that patient has poor outcomes, but definitely in few instances like patients with sepsis, it is a powerful predictor of mortality. Next slide, please. So take-home message is, it is the most common cause of metabolic acidosis. Type A lactic acidosis usually we encountered is associated with impaired tissue oxygenation due to tissue hyperperfusion in shock. Thank you very much.
Thank you, Dr. Kamal, and thank you, Dr. Nusrat, for enlightening us on these topics. Dr. Kapil, you have any comment to make?
Yeah. So my question to Dr. Kamal is that, do you target lactate clearance? And if yes, what threshold should you choose? And what should be the rate of lactate clearance, which in a septic patient, that would be acceptable?
So the goal is, whenever there is hypotension, and we usually measure the guidelines say we should measure it within 1 hour, and so we measure it, and the goal is actually the main thing is the improvement in the hemodynamics. As early as you diagnose the process of derangement in hemodynamics, then you can able to correct it. Suppose patient has cardiogenic shock underlying, and you are treating it as a hypovolemic shock and giving too much fluids, it will further actually downgrades the tissue hyperperfusion and enhancement in the lactate. So when the cause is clear-cut hemorrhagic shock, you give a fluids, you will get a definite response by achieving appropriate hemodynamic targets. So making a diagnosis after diagnosis of lactic acidosis or is made is important. That is the main thing.
Thank you. So my second question to Dr. Nusrat is, ma'am, do you recommend bolus antibiotics or do you recommend infusions of certain What is your experience?
Yeah, so these are time-dependent antibiotics which bring about more effective killing through time-dependent killing. And we have sufficient evidence now to say that longer duration of infusions with the for penicillins and carbapenems can be useful in achieving the target attainment goals. So for these two sets of antimicrobials, it is important to have longer duration of infusions. As a general dictum, though there are different time periods which have been defined, those have been optimized based on various studies, but it may be difficult to implement them in the intensive care settings or emergency settings. As a general dictum in our hospital, we say that run the infusions for at least 2 hours. So that is important stewardship intervention that we do. So thanks for bringing that up.
Thank you, ma'am. That's all.
Yeah.
Ma'am, one question I want to ask. Do you take help of procalcitonin? In first two cases, I mean, there was doubt in starting antibiotics. So do you recommend?
So procalcitonin so far hasn't best body of evidence just for stopping antibiotic, but we do take a help of procalcitonin. In the first case, for example, there is even a study which has been carried out where usefulness of procalcitonin in managing patients for aspiration pneumonia, oblique pneumonitis was evaluated. Unfortunately, there was no benefit which was seen. So I don't think first case would be a very right case for making use of procalcitonin. I'd rather say that the third case wherein you had a patient with the abdominal sepsis, the last case, therefore stopping antimicrobials, it may be of use. But for the first case, we have evidence to suggest that there is not much of use. Thank you. Thank you for bringing that up, though.
Yeah. I would like to congratulate both our esteemed speakers who made the topic so much apt by presenting it in a case-based manner so that it is absorbable by the audience. This is the end of the day. So I congratulate both of you. And my one question to both the speakers is, like the topic is moving from the first hour to the platinum 10, where do lactate stand and where do antibiotics stand?
Yeah. So can I take that first since I'm standing here?
This is
So-
exactly I wanted to ask, that what is our time? Because when a patient of a trauma comes to us, we need to decide the time when we need to start the empirical antibiotics, which is imperative. So what is the cutoff time for that?
So, if you have some suspicion of sepsis or septic shock, then every hour matters. You would start as early as possible. Now, you would say that how do you think of sepsis being there or not? The current definition of sepsis involves organ involvement, which could be a consequence of trauma and trauma-related bleeding and other things. So that's why I was repeatedly emphasizing on the understanding of time frames. And the nature of injuries. Could the patient have been subjected to that kind of inoculum of pathogens which could have resulted in that permanent infection? Say 3 days down the course from initial trauma injury to organ involvement and other things, I won't miss even an hour. But if the patient has just been rushed in directly to you, there is no reason for you to suspect sepsis being there. It would, even the organisms which were there already, or even from the source of infections that could have been environment based, it would take some time. So that would be my take on trauma patients specifically. But if it were the last case which ma'am had sent to me, and I am the first one to receive it, and 5 days of stay was elsewhere in another hospital, which is often the case in our setups, then you would start from day one, and as soon as you receive, and you will hit hard.
And there is no role of preemptive antibiotic treatment for trauma patient?
So that's one important distinction. We kind of use this term preemptive interchangeably with empiric. Empiric treatment in situations would definitely be needed. I'm telling you again, when we have time frames into consideration. And possibility of hospital acquired infections or even community acquired infections sitting there. So it's not that we don't make use of empiric antibiotics. For example, aspiration pneumonia, most of our use would be empiric only. You can't possibly dig in deep and get the kind of pathogens that you want. So there is a place of empiric antimicrobials. Next, we come to preemptive antibiotics. Preemptive term would be at best applicable to, say, for your example, your antifungal use, where sometimes some units make use of beta-D-glucan and galactomannan to guide their therapy. But let me tell you, this is not evidence-based. We need to generate the evidence for that, though it is a common practice. We have some observational prospective kind of evidence there, but not an RCT-based evidence. But we do make use of preemptive antifungals, especially say 15 days down when the patient has been on broad-spectrum antibiotics and you have certain sources which could be a source of fungal infection. So there we do make use of preemptive antimicrobials. I mean, that would not be considered appropriate in trauma setting.
Recording stopped.
So I'll not discuss another example of preemptive, which is totally a little out of context. So we do need empiric and preemptive antibiotics, both of them.
Yeah. So actually, ma'am, thank you so very much, because I think this covers the entire this thing, because the antibiotic therapy, I think it needs to be tailored. It needs to be tailored to a particular patient. It needs to be customized always. So, that is why we need to take the patient, when the patient is coming, what is the clinical condition of the patient. And I think you actually very nicely summarized it up. And one of the most important things which everybody forgets is de-escalation of the antimicrobial therapy, which is as important as escalating it. So thank you so very much, ma'am.
Thank you. And it is as difficult, I must say. Ma'am, if I have just 30 seconds, or Dr. Kajal, you would want to add to that?
I just want to thank you both, because this was one of my very heartfelt topics, and there are so many residents sitting here. And I always find when I go to intensive care that they are stuck at these 2 points. One is that most of the times their lactate interpretation is very, very jittery. And for that, I thought Kamal has done a very excellent job. And handpicked speakers, by the way. I just thought who will be the best person to deliver. And Nusrat has been trailing now. Nusrat is going to come. Please try to tell me why you have started this. So I want the same question in the mind of the residents when they write any antibiotic or when they go outside from this institute, that why am I writing this antibiotic? So basically these scenarios were taken from our own institute, the way we face the problem. And then Nusrat has answered for the benefit of all of you. So my personal thanks, a big round of applause to both the last speakers. And thank you, chairpersons. Thank you for making a very logical interaction. Thank you to all the audience sitting in the virtual, and thank you, Dr. Kapil, for posing your questions from the virtual listing and staying with us till the end of the day. I must put here on the records that we have 98 virtual audience still sitting with us, and our residents are also sitting here. I thank you all for being so patient and being with us. So we have a very lively session coming up now. And again, a big round of applause so that we stay awake. No, not me, but Shyam, who is going to hold the fort from now on. And I can assure you he's going to make it very live and interactive. So something very interesting is going to come along. Thank you, Nusrat. Thank you so much.
Just give me half a second. And I'm just deviating from the norm. I would like to take this opportunity to send a personal thank to Dr. Kapil Soni. So your care made my father see today. You perhaps are not even aware of. He was under your care, and you took such a beautiful care for him that so we are personally indebted to you. Thank you so much.
Thank you, ma'am. I'm really humbled. Thank you.
गुड इवनिंग। जैसे मूवी में नहीं होता है ऐसे बेजान दारू वाला, हाँ ऐसे श्याम क्यूज वाला या चॉकलेट वाला भी बोल सकते हो, ठीक है। So so anyway, the 30 candidates ने participate किया pre-Q session में. Okay. 30. मेरे को दुख तो बहुत हुआ आप लोगों को, मतलब इन द सेंस डिस्क्वालीफाई करने के लिए, बट देयर इज नो डिस्क्वालीफाई एट ऑल. सो बेसिकली मैन क्यूज में पार्टिसिपेट करेंगे. वी आर जस्ट सेलेक्टिंग ओनली 12 कैंडिडेट्स. सो we'll take them, we'll ask them. Okay. So मोहम्मद फ्रॉम मुलाना. हाँ चलो आ जाइए भैया, आगे आ जाइए, आगे आ जाइए, आगे आ जाइए. ठीक है. So 30 candidates were there. We just choose only 12.
12 candidates from 30.
Okay. Ankita. Himanshu.
हिमांशु पुनीता.
ये आप अपना बना लेंगे
या तो आपस में बना लो. You 12 people नहीं, sit in front only.
दो का थोड़ा गैप लेके होते. प्रीतम फास्ट. प्रीतम. संतोष come forward man. Sandil. Good. Amy. Vinayak.
Recording in progress.
Revati. Dhatri. Udit and Adit. ये बाप बेटे आ गए. उदित नारायण. क्या बात है, मजा आएगा. तो प्लीज बाप बेटा जोड़ी मत बनाना लेकिन ना. सो अब फटाफट टीम बना लो अपनी. आप कैसे बना रहे हो? आप टीम. तो दे आर 6 टीम. नाम बताते जाइए और वो बनाते जाइए. हाँ उदित एंड आदित्य.
नहीं
उदित आ गया ना.
आदित्य.
ठीक है.
We have 3 teams here, 3 teams on this side.
इनको नाम बताते जाओ. जो टीम है ना, नाम बताते जाओ. टाइम कम है अपने पास. ठीक है. ओके. Vishwan is the our recorder, मतलब ठीक है. She is judge actually. अंकिता के साथ कौन है पार्टनर? फटाफट बताओ. बगल में सैंदिल को ले लो. ओके. ओके. मोहम्मद इज और गेस्ट एक्चुअली ना. उसको प्रिविलेज दिया जाए. उसको कौन सा गेस्ट, कौन सा पार्टनर लेना है उनको. चलो ठीक है. जल्दी करो. सो बेसिकली इधर से हम स्टार्ट करेंगे. टीम ए सुबोध एंड प्रीतम एंड हिमांशु. टीम बी इज ठीक है. एंड टीम सी एंड टीम डी. प्लीज से योर नेम. So what, you are ready there? Okay. So he is chair umpire. Okay.
This is elimination round. First round में एक टीम एलिमिनेट हो जाएगी. remaining 5 will have 2 more rounds.
Okay. So इसमें ना ये मनदीप का ही नाम लिखा है. मैं इधर अनीस भी दिख रहा होगा तुमको और ये बुशमन भी दिख रहे होगा. ठीक है. These are basically team. Without team there is nothing. Okay. Subodh. So basically हम किसी भी कॉन्फ्रेंस में जाते हैं. When we go for any conferences, there are some attractions ना. Okay. City attraction. Change please. कौन सा शहर में हो रहा है? ठीक है. हैदराबाद बिरयानी मिलेगा खाने को उधर. ठीक है. नहीं. और दूसरा थीम के अलावा, कंटेंट के अलावा ना, सेकंड चीज होती है नहीं. एंड थर्ड क्रेडिट्स. सर्टिफिकेट मिल जाएंगे नहीं. सीएमई क्रेडिट्स. लास्ट बट नॉट लिस्ट ये जो क्यूज मोस्ट अटेक्टिंग ना ठीक है. So Dr. Mandeep will ask you question, or as he has already mentioned, this is the elimination rounds. We'll keep only 5 teams for next round. Okay.
हेलो आई एम डॉक्टर मनदीप. चलो स्टार्ट करो यार. फर्स्ट क्या खाना है आगे? हाँ क्विज. लास्ट इज क्विज. चलो नेक्स्ट. सो राउंड फर्स्ट एलिमिनेशन राउंड. इन दिस राउंड 2 क्वेश्चंस विल बी देयर. द टीम हु इज इन मिनी मार्क विल बी एलिमिनेटेड. अगर दोनों के
देयर विल प्रॉब्लम ना, मतलब लाइक अगर क्वेश्चन का हम यहाँ डिस्प्ले कर देंगे तो हाउ दे विल आंसर एंड हाउ विल. ठीक है,
हाँ तो वी विल स्टार्ट फ्रॉम टीम ए.
यस.
So first question team A, B, C, D, E, F. Okay. So first question will be for team A.
Two questions आएंगे.
2 questions. So first question for team A. A 30-year-old male patient presents with a stab wound. ये हटा दो यार. नहीं सर वो हाँ stab wound to the left side of the neck. He is alert but has active bleeding. He is in resuscitation cubicle. You would address this bleeding by your options: placing 2 large bore IV cannula and giving O negative blood, apply pressure to the site, clamp the bleeding vessel to obtain stasis, locally explore the wound and locate the bleeding point.
दूसरे को आंसर ना बताए, टीम बी टीम ए को ना बताए. Apply pressure to the site.
Apply
option D.
Option B.
Answer please.
Apply pressure. 10 marks. Next team. Next question for team B. चलो नेक्स्ट क्वेश्चन. यार ये somehow इसको एडजस्ट करो ना. ये second round. This is for team B. A 26-year-old male who sustained multiple trauma undergoing open reduction internal fixation of bilateral tibia fibula fracture during anesthesia with isoflurane, nitrous and oxygen with PPV. During the procedure, the patient has sudden onset of hypotension, jugular venous distension, deviation of trachea to the right, decreased ventilation compliance. Isoflurane is disconnected and 100% oxygen administered. Which of the following is the most appropriate next step in the management? Chest X-ray, blood transfusion, subxiphoid pericardiocentesis, fiber optic bronchoscopy, left chest needle thrombectomy.
सी लग रहा है. यस, डेक्स्ट्राइड बन गया ना.
टेम्पोनेट है.
कार्डियक टेम्पोनेट. तू बता.
ट्रिकी डिफिशन हुआ क्या टेम्पोनेट?
No more memory.
तू तो राइट जा रहा है ना. आज तेरी
10, 9, 8.
So we'll go with C.
C, subxiphoid pericardiocentesis.
कंप्यूटर जी लॉक किया जाए.
चलो आंसर. सर it was pneumothorax. Okay, it was a pneumothorax case. Next question. Regarding crush syndrome, which is not true for team C: rhabdomyolysis, myoglobinuria, alkalosis, DIC. Alkalosis. Acidosis. चलो good. Hello. Next for team D. Next question. Which of the following is the most appropriate initial management of a patient with hypotension secondary to sepsis? Calcium chloride, corticosteroid, crystalloid, dopamine. Answer is C. What is the answer? C, crystalloid. Good. Next. Identify the nerve block.
Identify
the nerve block. Popliteal sciatic, ulnar nerve block, adductor canal, femoral block.
Sciatic. Popliteal sciatic.
चल आंसर मार्क है. Completely random. चलो next question. Following blunt trauma to the chest, a patient has tachycardia, hypotension, and markedly distended neck veins. Each of the following is expected except cardiac output of 2.1 liter, mixed venous oxygen saturation 75%, pulmonary artery diastolic pressure of 25, diastolic arterial pressure of 25.
B. Mixed venous oxygen saturation of
Mixed
75%.
venous saturation. Correct. Okay. We'll start with the next round. This was round one. No, first questions of round one. Then again round one. Second question start from team A.
भैया आप जैसे टीम एक पास
हाँ यार,
तो उसके पास
फोटो
कैमरा
दिखा दो।
फोकस कर इनके चेहरे की चिंता में देखना इतना
Team A. Next question, please. Which of the following statement concerning the autonomic hyperreflexia after spinal cord transection is true? It occurs within 24 hours after injury. It occurs with lesion below T10. It caused by reflex increase in parasympathetic outflow. It is characterized by paroxysmal hypotension and tachycardia. It is prevented by blocking afferent vessel pathway.
D.
D. It is characterized by, answer is it is prevented by blocking afferent vessel pathways. Next question for team B. A previously healthy 60 kg 17-year-old boy is undergoing emergency surgery for a gunshot wound involving iliac vein. Ventilation is controlled with a tidal volume of 700 ml per breath, rate of 10, peak inspiratory pressure of 30 centimeter of water. Body temperature is normal. The most likely cause of an end-tidal carbon dioxide of 16 mmHg is endobronchial intubation, excessive expiratory time, excessive tidal volume, low cardiac output, pulmonary aspiration. Team B.
नहीं पता है तो आप बोल सकते हैं नहीं है एक्सपिरेटरी टाइम मेंशन नहीं किया हुआ था तो pulmonary aspiration should not cause this
Low cardiac output.
Very good. Low cardiac output. It was hypotension only because of the blood loss. The vein was ruptured. Next question. Each of team C. Each of the following condition is associated with autonomic hyperreflexia in patients with spinal cord injury except bradycardia, flushing below the level of injury, headache, sweating above the level of injury, systolic hypertension. Answer is flushing below the level of injury. Next question for team D. Which of the following finding is most likely in patient with acute transection of spinal cord at level of C6? Autonomic hyperreflexia, hyperkalemia with administration of succinylcholine, hypotension, increased pulmonary blood flow, tachycardia. C. Hypotension. Okay. Answer. Hypotension. Correct. Next question for team E. The acute onset of hypotension without a decrease in mixed venous oxygen saturation is most likely associated with onset of hemorrhage, MI, pulmonary edema, pulmonary embolus, sepsis.
Without a decrease. Sepsis.
And the answer is sepsis. Correct. Last question for this round to team F. A 25-year-old man requires exploratory laparotomy following a motor vehicle accident. He is acutely intoxicated with alcohol. Which of the following is most likely result of alcohol ingestion? Hyperdynamic circulation, hyperglycemia, hyperthermia, increased respiratory depression from opioids, increased sensitivity to neuromuscular drug blocking drugs. Increase respiratory depression of opioid. Correct.
So score for team A for this round is 10, team B 10, team C 10, and for team D, E, and F, 20 each. So we have 3 teams with the same score.
Which teams are same?
A, B, and C.
A, B, and C. So additional questions for this.
बेसिकली टाई हो गया पहले राउंड। So basically, after completion of first round, the 3 teams are qualifying for second rounds, and we have to shortlist from these 3 A, B, C. A, B, C. ये तो CPR में चेंज हुआ है भाई, हैं? CA भी हो गया इधर। चलिए, तो बेसिकली CA से एक क्वेश्चन पूछा जाएगा, ठीक है? जो सबसे पहले बताएगा हाथ खड़ा कर देगा, मेरे को आता है इसका आंसर, ठीक है? ऐसे करके जो बता देगा उसी को ले लेंगे, ठीक है? चलो भाई क्वेश्चन पूछो।
A 10-year-old trauma victim presents unconscious and hypotensive. Multiple attempted peripheral IV access are unsuccessful. The next access of choice is.
हाथ खड़ा करेंगे। नहीं जिसने हाथ खड़ा किया।
चलो next question will be deciding.
So they will answer or they will raise their hands. They will answer.
टीम में टाइम ब्रेकर है। हाँ इन तीनों में से जो भी बताएगा।
तो ये अभी
This is a difficult question.
They have not raised their hand. Okay. Yes.
चलो फिर भी we'll consider you. We are considering if still again time we will consider them also. Which of the following is not a predictor of mortality in trauma patients? Apache score, Ascot score, TRIS, GCS.
Hand पहले रेज कर दो। उसका आता है?
बताओ।
ठीक है। आप बताइए।
Correct. ठीक। ये टीम रुकेगी भाई। Next.
चलो ठीक। 5 हो गई ना?
हाँ हो गई।
5 हो गई।
हाँ ये तो ये बैठ जाओ। तुम्हारा हो गया ना?
Abhi, where you are going?
That team has been eliminated ना, not you.
Second round, please. Second round.
Second round.
Before the audience के लिए कुछ है? ऐसे पूछो।
Okay. Questions for audience. जिसको भी बताना है हाथ ऊपर. In a patient with hemorrhagic shock, a base deficit of -4 indicates which class of shock? No options. चलो. Class 2. Chocolate for her.
एक और.
Okay, next. Which of the following patient would not require radiological evaluation as per Canadian C-spine rule? A 12-year boy who fell from 3.5 feet, 68-year-old man who was ambulatory at scene, 35-year-old female with a delayed onset of neck pain who can actively rotate her neck 45 degree left and right, 23 man with midline cervical spine tenderness. चलो आपका हो गया। नेक्स्ट
यस एम्बुलेटरी
क्या नेक्स्ट रॉन्ग
सी क्या था
30 because the first is wrong because the age is more than 65, the age has to be less than 65, then it is okay.
इन्होंने मतलब
चल round 2
please
start. Okay, we'll start with that team first. No, team one. Okay, Team A. Okay, we'll again start with the team A. This is round 2, and in this we will have pass-on questions. So if you do not tell within 10 seconds the answer, either you have to tell something or the question will be passed. Not negative marking. And the pass will only be to the next team. These team will not speak, otherwise your marks will be cut.
हाँ, सही आंसर देने का भी मार्क्स कटेगी.
Okay, chalo. Round 2, question 1 for team A. A 12-year-old patient with multiple trauma is admitted to the ICU post-operatively. The early development of polyuria, hypotension, low urine sodium excretion, high serum osmolality, and normal serum creatinine concentration is best explained by adrenal insufficiency, fluoride-induced high output renal failure, inappropriate ADH secretion, intraoperative fluid overload, posterior pituitary insufficiency. Ten, 9, 8, 7, 6. A. Next. C. Next, any question? Chalo. The answer is posterior pituitary insufficiency. It is DI only. Okay. No marks to anybody. Next.
No marks to
anybody.
but chocolate.
Chocolate. For. Then sodium values were distinguished. The complete diagnosis is posterior insufficiency. Okay. Okay, next question. Each of the following statement concerning the ACT, activated clotting time, is true, except the ACT is more sensitive than activated partial thromboplastin time to blood heparin concentration. The ACT is prolonged if specimen is not warm during assay. The ACT should be greater than 300 seconds before initiating cardiopulmonary bypass. Hypofibrinogenemia may prolong ACT after cardiopulmonary bypass. Whole blood is used for measurement of ACT. Team B.
Sir, D.
D. Answer A. The ACT is more sensitive than activated.
It's okay. It's okay.
Okay, next. Which of the following is not a sign of tension pneumothorax in blunt trauma patient? Unilateral absence and decrease in breath sound, persistent hypotension, decreased airway pressure, tracheal deviation, increased CVP.
ऑडियंस बता रहे हैं 10 सेकंड के बाद ऑडियंस को आंसर
ऑडियंस नहीं यार नहीं पास है ये इतना सिंपल है कि we will not give for this kind of. The first question was very tough. So दो लोगों ने सर मैम ने पहले हाथ उठा दिया था कि हम So in this increase airway pressure. Okay, next. We will see which question to pass. Like it's not every case. Revised trauma score take into consideration all of the following physiological criteria except GCS score, respiratory rate, capillary refill, BP.
C. Capillary refill.
Capillary refill. Answer correct. Yes. Chalo. Next to last. Now we have A, B, C, D. Okay, your name has been changed.
नहीं AVD.
We will. Okay. Last. Next question. At what class of hemorrhage shock would the GCS decrease? 1, 2, 3, 4 doesn't correlate.
चेहरे पे हवाई उड़ रही देखिए पूरा.
10, 9, 8, 7. Class 4. Audience. 3. Chalo. Answer. Deterioration started in class 3 itself. The change in mentation. Okay. Next, we'll start with the team A again. A 10-year-old girl develops abdominal pain and bilious vomiting several days after injury herself over the handbar of her bike. The most likely diagnosis is pancreatic contusion, diaphragmatic injury with eventuation of bowel, liver laceration, gastric perforation, duodenal hematoma.
A. Pancreatic contusion.
Audience, please.
उसको सर वो लास्ट
क्या बोला आंसर?
हेमेटोमा. Anything in the duodenum will lead to bilious vomiting. सर वो पीछे वाले को bilious delayed presentation मैम. It is not. It is a delayed presentation. ये खानी है किसी और के लिए नहीं है. चलो next question. For team B, which of the following is true concerning traumatic thoracic injury in children? Pulmonary contusion is rarely seen without a associated rib fracture. Diaphragmatic injury can be reliably diagnosed with chest CT. Tension pneumothorax more of a concern due to increased mediastinal mobility compared with adults. Thoracic injury are usually not associated with organ injuries. Rib fractures are more common than in adults. Ten.
Yes.
9, 8, 7, 6, 5, 4, 3. D. Answer. Tension pneumothorax more of a concern due to increased mediastinal mobility compared with adults. Okay. Okay. Practice. Next. Okay, chalo. Which of the true for on-arrival blocks in acute trauma for upper extremity injuries? Nerve injury are not needed to be ruled out in trauma patient. Primary survey, secondary survey and rule out brachial plexus injury before giving on-arrival block. First give block as patient is already in pain, then do primary survey. It increases the time of resuscitation.
सब क्वेश्चन है अभी आराम. ऑडियंस प्लीज रिलैक्स पहले बताइए.
-5.
हाँ चॉकलेट वापस ले लेंगे. यस प्लीज नहीं उनकी तो
10, 9, C. चल ओपन टू ऑडियंस. यार तुम्हें तो सुना नहीं है तो बिल्कुल क्लास का क्वेश्चन है सर. 2-3 उनको देना. मैम को तो आंसर पता दे तो मैम को नहीं मिला. मैं मेल पे आपके पास आ गए थे. आप चीटिंग कर सकते हैं. चलो. So for honor, even if you have to give block, the primary and secondary survey has to be performed before all this.
प्लीज पढ़ाइए.
चलो next question. Which of the best form of regional block for analgesia for chest injury with unilateral multiple rib fracture in coagulopathy? Epidural catheter, single shot erector spiny block, intrathecal opioids, intercostal nerve block at all levels.
No, audience, no, please.
B. Single shot.
Single shot catheter. Correct. Chal. Next. How does regional anesthesia delay the diagnosis of onset of compartment syndrome in legs? Swelling will be decreased after block. Mask the pain and paresthesia. Increase painful movement after the block.
No, audience, please.
Will not cause any delay. B. Mask the pain and paresthesia.
रेंडमाइजेशन ना मतलब किसी को टपा सकता है किसी को नहीं जा सकता.
चल.
यस टीम ए आर्यन. सेकंड राउंड खत्म हो गया ना.
सेकंड राउंड खत्म हो गया
ऑडियंस के लिए.
ऑडियंस दिस इज ओनली फॉर ऑडियंस नॉट फॉर द टीम. चलो नेक्स्ट क्वेश्चन. सर आप देखना कौन आता है.
कोई बात नहीं.
25-year-old male, history of gunshot wound to chest, was brought to emergency department. His first vital sign ED 140/90, 120 SpO2 99, oxygen 15 liter by face mask, respiratory. चलो दे दो भाई दे दो. मैम क्या मैम, this was the direct question from the class. He told it like this only. So he attended, ma'am. Sir, he attended the class properly, it means. Chalo, next question. खत्म हो गया?
अच्छा कोई बात नहीं, उसमें से निकालो, उसमें से निकालो। नेक्स्ट जनरेशन लोग हैं ना सर, दे ऑल आर नेक्स्ट जनरेशन।
एग्जैक्टली ना, तो थोड़ा सा तो मैं रखने दो।
यस 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 प्लीज।
A 19-year-old male hiking in National Forest fell 10 feet through a rotten plank on a wooden bridge to the rocky stream below. So he fell down basically. He was transported to ED within 30 minutes complaining of chest pain. He is hypotension arrival to ED. What do you do? 2-liter crystalloid bolus sent to OR, 1-liter crystalloid bolus, CT chest and abdomen.
पहला कुछ नहीं, इसको मत देखो प्लीज। पहला ऑप्शन है।
Next option? No.
दो ऑप्शन है, चार ऑप्शन है।
2 लीटर
4 option है। First option 2-liter crystalloid.
दोबारा बोल रहे हैं।
First option 2-liter crystalloid. Second option sent to OR. Third 1-liter crystalloid. D is CT.
किसी थोड़ा करेंगे उसके लिए।
सी किसने बोला है?
C sir वहां से आया. Initially we will give fluid only ना ma'am. 1 liter. We had not given any fluid itself. हाँ, it is chest pain. So initially we'll start with fluid only, no? Then we'll shift him to OT. At least fluid we'll give. So the basically it was how much fluid you will try to give, 1 liter or 2 liter. The basic identification. चलो next. Pneumothorax में ICT डालिए, वहीं पे डालिए, OT में नहीं डालिए. अच्छा चलो.
So this girl who is
हाँ
basically
she is doing very good.
She's here for
collecting chocolates.
Yes.
For Mohammed Akram Khan.
So वो जाने नहीं देना है, इसको पकड़ इधर ही रखने का, ठीक।
सारी चॉकलेट्स बाहर नहीं जाएंगी।
हाँ प्लीज, आप सारा खाना पड़ेगा, ये ज्यादा आंसर देने का ये भी एक नेगेटिव पार्ट है।
चलो नेक्स्ट, ओनली ट्रू एंड फॉल्स।
इस राउंड स्कोर बता दें।
हाँ
प्लीज स्कोर।
So scores for team A is 20, team B is 20, team D is again 20, team E is 40, and team F is 30.
So highest is team
E
A,
followed by team
Revati
F.
and Senthil.
Senthil.
And the second is Ankita and Dhatri. And the remaining team on 20 each. Chalo.
So this is
next. So 2 more question left for each team. Next question. For team A, operation on shoulder can be carried out with supraclavicular block
only true and false, please. Huh?
alone. Sorry, supraclavicular block alone. False. Correct. So why it cannot? Okay, because we additionally need cervical plexus now to be blocked in this. Okay, correct answer.
Next, please.
With regard to brachial plexus block, the supraclavicular nerve arises from the lower trunk of brachial plexus.
Yes, I mean true or false.
So
please.
false. So they arise from cervical plexus. इतना time नहीं लेना है. True false में इतना time नहीं लेना है ना ज़्यादा. Rapid, it has to be rapid round. Okay, next. With regard to shoulder surgery, the axillary nerve is reliably blocked with an axillary block plate. False, because it is usually gets paired in axillary block. Okay, next. Interscleral block may sometimes cause a total spinal blockade. True. True. Sure. Chalo, next. In shoulder surgeries, brachial plexus block can result in long-term neurological deficit in more than 5% of the patient. True. It is false. So basically, they get negative mark. So only team to get negative mark is the last. नहीं, negative नहीं मतलब like they all get mark, they do not get any mark. So second round.
Second set of true and false.
For team A, Continuous thoracic epidural catheter infusion technique is one of the best form of analgesia in bilateral chest injury with multiple fractures.
True or false?
True. True. आज क्लास में पढ़ाया था, बच्चे तुम आए नहीं क्या? ये बताया तो था अभी क्लास में. True. Okay. Total spinal anesthesia with cardiopulmonary arrest can occur with brachial block in given to a patient with acute brachial injury in brachial plexus injury. True. True. Next. Horner syndrome result in contralateral symptom of sympathetic blockade. False. False. Next. Local anesthetic is hyperbaric. Hyperechoic.
False.
False. Last question. In infracollateral block, they are a good option for indwelling catheters. True.
Last one easy हो गया. नहीं कोई नहीं, अभी इनके ऑडियंस के लिए बेसिकली अभी हमारा जो स्कोरर है she is just calculating the scores. Okay, so I'm just telling the name of this thing. Savita, Navdeep, Himanshu, Himanshu Srivastav is there. Okay, Pravina. Okay, and Resma. Because of the time ना हम आपका टीम नहीं बना पाए, otherwise you also qualified in the pre-quiz sessions. Okay, so you will get a chocolate again. Okay,
वो कह रहे कि दो क्वेश्चन पूछ वो टाइम ब्रेक.
okay,
Okay, team E at 60 has won. Basically, we are deciding who will come second. So all other remaining 4 teams are at same level with a mark of 40. So team E will not speak anything. This next question will be only for these 4 teams, and it's a tiebreaker. One who will say first will get the point. But true false हो तो कुछ ही बोल देंगे.
इतना सारा सजेशन आ रहा है नहीं, ये करना चाहिए. तो तुम वो अभी ओलंपिक नहीं देखा गया जापान वाला? यू कैन शेयर सेकंड रैंक बहुत, कि चलो हम पार्टिसिपेट ही नहीं करते हैं, सेकंड रैंक हम दोनों शेयर कर लेते नहीं. ओके, चारों शेयर कर सकते ना. बेसिकली जो मैंने ये नाम बोले ना आपको, ये तो बोले कर रखे हैं, इन सबको चॉकलेट.
Okay.
इनको हमें टीम बनाना चाहिए था, बट
all the participant will get 1 chocolate each. नहीं है सविता
सिर्फ गोले लगे हो ना उनके देना है.
वेरी सविता यार टीम में नहीं है तो सी वेंट. दिस इज नॉट गुड स्पिरिट.
क्वालिफाइड बट जस्ट बिकॉज़ ऑफ टाइम.
Next Navdeep. Then all these participated, but because of 1 or 2 marks they could not come to the team. Himanshu Srivastav. Yes. Parveena. Sorry. Next is Vishwanath. What else? Subham. Deepshikha. अंकुर. चलो चलो अंकुर को दे दो. सुबोध. यार वो तो दूर हो गया सर, वो तो ज्यादा दूर हो गई. चलो और मिक्सिंग बॉक्स. रेशमा. Hina. See participate. So all these are those who got very good marks. Only 1 mark left.
Huh? So between this second and third, whatever what team are in second position? Na?
Sub-team second.
Okay.
Second from now.
So I don't have such rapid fire questions, but anyway. Actually, because of this, na. So what we have to do, ma'am?
Okay, we can do a twist here. We can say one of the team members can speak just for a minute on trauma. The one who speaks good.
This is
Not good about us, just about trauma. Don't. So just a minute. Anything.
Start with the team.
So, Emil, your oratory skills are good. Come on. You can talk anything. Like you heard so much. Since morning you are hearing trauma, so you speak anything. This is just because they don't have prepared questions. And having said that, I think that just tells that the average score of all participants is almost on the same platform. And that also means that you people are good, well trained in trauma. So I can congratulate my team members, Dr. Shyam, Dr. Mandeep, Bisman, that they have given good training. And even those who are from outside, I think they have done a good job. They've learned their trauma training well. Good.
And we try to put all the questions from whatever we have done.
Oh, great. That again emphasizes that you people were attentive to the talks today. Thank you. Chalo.
30 candidates for this question. 30 candidates.
Both can go. Or one from the team.
One from the team.
Good afternoon, everyone. Thank you for giving me the honor to speak.
Time starts now.
Trauma is something acute. So if we intervene acutely, if you intervene on time, you can have a better outcome. It is not like chronic medical diseases. It is something acute physiological change, which is like our Apache score itself. So if you intervene on time, which is basically our ATLS guideline, so we can have a drastic or dramatic improvement in the morbidity and outcome of patient, which we usually see in our ICUs. Like we usually take up head injury patients, which are like they are having a very poor GCS, but we do acute management, tire management of the brain injury, and we within less than a week, we see them walking out of ICU, which is a very blessed thing to see, and we like that management.
Good.
Thank you.
Spot judge.
Time हो गया.
Timing करो.
So trauma is an intense thing that we first encounter. It might be the first thing that gives us hope or gives us any thing to become a doctor, because it is an intense emotional situation out there. And if we are there in an anesthesiologist, we can relieve the pain of the patient. We can take the patient to OR, we can see the recovery of the patient. And apart from all these things, it is that one moment that gives you thrills, and which really is the best thing about trauma, that you can relieve pain of anything and you can save a life.
Yes, please. I worked in Department of Neurosurgery in LNJP for almost 2 years, non-academic JR. So I've seen a lot of trauma. And one thing which I learned in these 2 days was that during those time, I had a case in which there was a traumatic amputation of right arm of a patient. And when I saw him, I was like, how to approach him, how to decrease his pain. And I learned that we can give a supraclavicular block and all those blocks which can be used. Another thing, the great thing about trauma is that all the neuro cases which we see which I saw in my emergency, was that the EDH patients, they, they improve very good in an excellent manner. Because I had taken one case of EDH, within half an hour we took him to the OT. We did a decompressive craniotomy, stopped the bleeding, put the bone in the back on his cranium, and put him in the ICU. Morning, his GCS came back to 15. The patient was awake and he was asking us to remove his ET tube, which we did. So trauma is like the faster you give support to the patient, the better the outcome in the trauma is. That's the beauty of trauma. Thank you.
Good evening, everyone. We know trauma is the leading cause for morbidity as well as mortality worldwide. And managing trauma actually brings anesthesiologists on front, because we always stay behind a surgeon because the patient is first for the surgeon and we just manage and we will never be acknowledged. But trauma, on preventing, we need to manage, resuscitate as well as diagnose on the same time. We manage the primary injury as well as prevent the secondary insult. And actually, this makes us feel like a doctor because we actually work behind, we'll never get acknowledged. But then when you work, it gives you a satisfaction that you actually saved a life. So it is a quick, fast acting, giving you an adrenaline rush. So it is a good branch, and then you save a life and you feel good about it.
Very well, actually.
Yeah, all of you really spoke very well, and congratulations to all of you for participating firstly in the quiz and performing so well. So out of the 4,
ऑडियंस बताएंगे भाई.
This the boy who has told us that he will do supraclavicular blocks.
Yeah.
Come and collect the prize. They have 2100 and the certificate.
Trauma quiz certificate of participation, and
Dr. Shyam will be mailing
with.
Ma'am, pre-quiz. So we have, ma'am, one pre-quiz before they were selected here out of 30, and the topper among the pre-quiz was Ankita with highest number 17. Yes.
Out, and these are small gestures to tell you that you people are doing good and you should do even better and become the best. So don't go behind these things. This is just an endeavor to keep you prepped up. Okay.
The 17.
Yes, सवाल आ जाओ.
Just a moment. Chetan, are you there with us, Chetan?
Yes, doctor.
We want a group photo, so can we have the gallery on, and we can just make a sort of a view on how we can take the picture. We have a photographer here. As many participants are there in the Zoom gallery or wherever they are. And I want to thank all the participants, the attendees from wherever they've logged in. There are some international people also who were logged in. I want to thank our speakers and the chairpersons and my institute for allowing me to host this webinar, a trauma conference, both from virtual and live module. If there are people, we will try to, capture them on the camera. Chetan?
Okay. Ma'am, it's already on the gallery.
It's on the gallery? Okay. Yeah. Okay. So, okay, fine. So we will we'll have a picture. Come on.
Come forward.
पीछे तुम पीछे जाकर बैठो ना बेटा
Get used to the stage.
Future is yours.
yes
Come. This is fine. Dushman. आगे आ जा आगे सारे लोग आ जाएंगे बाल
Chetan, thank you so much for bearing with us all these days. There were times when we were a little, demanding, but on the whole, you have done extensively well, and the conference has come out with a big success. I thank OmniCuris platform for lending us support and letting us, do such conferences in a challenging time like COVID-19 pandemic. Chetan, are you there?
Yes, doctor.
Thank you so much, and to your entire team. And can we log off now? Is there anybody else whom I have to, acknowledge? Anybody who is sitting in the gallery or in the audience? Heartfelt thanks from my team, and we look forward to seeing you all face to face next year. Let's hope, God willing, this pandemic goes away and allows us to meet physically in Chandigarh, PGI next year.
Thank you, Dr. Kajal.
I also want to thank GE Healthcare for giving their, our industry partners in all, but GE Healthcare specifically. Thank you very much. Thank you very much.
Thank you, Dr. Kajal.
Thank you.